Good morning, everyone. A very warm and pleasant morning to all respected dignitaries, faculty members, and dear participants. On behalf of the Department of Pharmacology, IGIMS Patna, I, Dr. Bazda Nazir, JR, welcome you all to day 2 of the 3rd annual workshop on animal handling and experimental pharmacology, under the aegis of the Academic Society of Pharmacologists of IGIMS. Yesterday, we had a wonderful series of demonstration and interactive sessions. Today, we continue our journey with another knowledge-packed schedule with expert talks and hands-on demonstrations. Without further delay, let's begin with our first session of the day. Our first session focuses on regulatory toxicity studies for IND applications. We are extremely honored to have with us Professor Dr. Bikash Mehdi sir, HOD PGI Chandigarh. I now warmly invite Professor Dr. Bikash Mehdi sir to enlighten us with his valuable insights. Please, sir.
है कलर माइक है लेके आ जाओ लेके आए Okay, so good morning everyone. So you can request the people to come in, those who are having a breakfast. Yeah. पानी का बोतल भी रख दो. Okay, so let's begin the story. How do you look at the preclinical data? Yesterday we had a panel discussion about the regulation and how do you extrapolate the data. Okay, so today we are going to discuss in detail, and I'll also take a couple of minutes. How do you look at preclinical toxicity study for a vaccine? Okay, because normally vaccine we never discuss. Now, when you look at the medicine, what is the availability of medicine? Because if you ask the undergraduate student and if you say, do you have a medicine for all the disease? And they have a belief that we have a medicine for all the disease. Now let's begin the story, how many diseases we do not have a medicine. Then only you can think that these are the diseases we do not have a medicine and we must look for a medicine. I'll just give you one example. Normally there is an organization called Pharmacology, and that's headquartered in Hyderabad. So their duty is to export the medicine, and they have a workshop, and whenever they have a workshop, they call all the patients also, rare disease. So a couple of times they call ALS patient and other patient, refractory patient. Then we started some of the lab. Now if I give you an example, celiac disease. Celiac disease, if you go to Punjab and North area, it's a huge. And we had done a couple of projects in order to look at the diagnostic criteria for celiac disease, especially in children. Now if you look at the celiac disease, we identify the disease, we diagnose, and what do we say? Offer them, the patient, you have a gluten-free diet. That's it. So that means we do not have any medicine. We have been trying to develop a new chemical entity for celiac disease, similarly for autism also. Today, if you look at that autism, how many options are there? If it is severe, you give a aripiprazole or risperidone. You know, those who are okay. So you can hear me. So in case of autism, you have two options. Those children, they injure themselves, then only you go for a drug therapy. So there is no, so you can make a list of disease where we do not have a medicine. Okay, all the rare disease, we have 450 rare disease. So that means if we look for that, can we develop a compound for this disease where we do not have a medicine? And that is why. So normally when you look at a preclinical toxicity study, it takes around 5 years time. For doing that, you know, initially you go for an in silico, in vitro, then you go for a proof of concept study, and when you do proof of concept study, next immediate is you go for a novelty certificate. When you identify hit compound and lead compound, and you ask for a patent. So then you do all this acute toxicity repeated dose, I'm going to discuss in detail. And so problem is, if you look for 5,000 to 10,000 compound, maybe one compound is suitable, and then you file an IND. IND is not for marketing approval, it is for investigational new drug you are going to do first time in human. So what you do in case of a preclinical, you look at the safety and biological activity. How safe it is in mice, how safe it is in rat, and in higher animal. So this is how you go. So when you go for a clinical, you go for a phase 1 study, obviously you have a system of microdosing or phase 0 study that you need not have to do an animal toxicity study, just give slight amount, little dose into the human, and can you extrapolate the PK/PD for a human. So as I said yesterday, we have also created a human model. You can just go to the guideline for some of the disease. Then you go to, so purpose is determine the safety and dosage. Then phase 2 study in a larger patient, 100 to 300. So in that you are going to look at the efficacy and look for any other side effect, okay? Then you go for a larger patient in phase 3 study, and that is why it is going to take around 5 to 8 years time, and you file an NDA application. Earlier regulatory toxicity study, file an IND, and now after phase 3 you are going to file an NDA application, that is new drug application, and that is for a marketing approval. So this is how you go. So regulator might take time, then you go for a phase 4 study. Once you launch, you have a system of continuous surveillance of the product as long as product is in a market, and that's how one drug is approved. Now coming to this slide, you are going to synthesis and purification once you find a hit and lead compound. So that means you have done in silico data, you have done in vitro data, you have done in vivo proof of concept, and you file novelty certificate, then you file a patent. Once you file a patent, you get an exclusivity for 20 years. So during that time, you have to develop and you have to get the revenue of the marketing. Okay, so you go for animal testing short time, that is acute or repeated dose, long term, where you are going to use for more than 6 months in clinical use. So you are going to do 2 years toxicity study, because mice and rat lifespan is almost 2 years. Now look at this accelerated development review. In COVID, we have repurposed almost 157 drugs. Start from hydroxychloroquine, ivermectin, like that 157 drug. Now, let me tell you that there are mode of approval. One is from task force, another from the regulator CDSU office. Now, you might have seen that we approve as emergency approval procedure, emergency approval drug, EMD. Then you have a repurpose, reuse, and when the vaccine was approved, it was approved as clinical trial mode. It was approved as clinical trial mode. What is the difference of this accelerated development review and approval? There is an incident happened for an ophthalmologist. They use one of the biosimilar compound, in many of these people, like 5 patients, because one vial is used for 5 patients for retinopathy. So what happened, they develop an infection. So the file came to DCGI office. So we called the company, and company had told me that we never asked for this indication. It is an ophthalmologist they use as an off-label use, and they are at a fault. We never asked for it. So problem was it was very costly, 60,000, so they used for 5 patients, 1 vial for 5 patients. Now please remember that any drug which is approved from DCGI office as an emergency approval, so when you patient go to legal court of law, then you are at a fault. So when it is approved as emergency approval, you must take an informed consent of the patient. I'll give you another example. One of the patient had come from Himachal. So there is a neurosurgeon who prescribed a drug, and this Himachal patient had asked for reimbursement because he is a government employee. So when it was applied, the clerk is more clever than anybody else. He checked the DCGI website, and then he put the queries to neurosurgeon that how did you, sir, prescribe this drug when it is not approved in the country by DCGI office. So then he called me. So there are a lot of incidents like when you use emergency approval, repurpose or reuse, then you have to take an informed consent. And as you can see that when vaccine was approved, first time we have used the word clinical trial mode. So when it was discussed in a central ethics committee, I also said that if any problem comes, you have to give a compensation. So that is why you need to. So then you have a treatment taken parallel track, and later on you go for a phase 1, phase 2, phase 3, and obviously you go for a phase 4 study. So in preclinical study, what we do that we have thousands of database. So if you look at the zinc database, we have 78,000 database. So there you are going to check for new drug discovery. So you are looking for a lead compound. So when you identify this drug compound has an effect on this disease or this pathway, you are going to call it a hit compound. And when you establish a structure activity relationship, you are going to call it a lead compound. And once you find a lead compound, what you are going to do? You are going to file a patent. First novelty certificate, then file a patent. So this is how alternative method of new ligand. So once you find target identification and validation, you are going to file a patent, and obviously you look for, if it is a known compound, you are looking at all the preclinical data, secondary data, it is available, and that's how you go for it. So basically you need to know that how the drug is absorbed, how it is distributed, how it is metabolized, how it is excreted, okay? All detail you have to know. So problem is, you work on several compound, ultimately your success is by 10 years and 15 years, you are going to also only 1 or 2 compound, that is what. But nowadays it says that we had COVID, we had a repeated meeting. So recently when the number of cases was coming from Kerala and Maharashtra, we had another, because I'm a part of task force of COVID. So Dr. Paul had called for a meeting on 5th and 6th of June. And now say if the COVID come back, we have only 100 days to develop a vaccine. So because during the COVID, we developed the vaccine in the month of 8 months. It was a coordinated movement and a teamwork, based teamwork for the development. So when you look at the toxicity, so basically any chemical, how it is going to behave in human, animal or plant microbe. So you try to identify and understand the toxic hazard. Is there any toxic hazard? Second one is information allowed to risk export to the population. How you are going to extrapolate this data when you plan for a human study. So this is how. So when you look at this, guideline for preclinical toxicity study, it says 1 or more species. Why? Because during the thalidomide study, what happened? They studied in mice, rat, they also studied in rabbit. And rabbit, they could find teratogenicity. And that is why it was recommended that you must try in different species. Then we also look at that, yesterday we discussed how the drug is behaving in male, how the drug is behaving in female. Also you can look at the stratified age group, okay, in male, female, and rat also. Then you can say you go for acute toxicity study, then repeated dose, then long-term toxicity study, then safety pharmacology study. All this study is depend on how long you are going to use in a clinics. Depending on clinical use, you need to generate the preclinical data. So this is how. But it is very important that when you go for a regulatory toxicity study, you need to do under OECD principle. So all of you we can also organize a GLP, OECD GLP, because when you talk about GLP in India, people say, is it OECD? OECD is Organization of Economic Cooperation and Development. And people also mistake that there is also guideline of GCLP, Good Laboratory Clinical Practice, that is linked to GCP, okay, clinical work, and that is from ICMR. You can read that guideline, okay. So I'm also vice chairman for that guideline. Then another GLP concept is, DCGI office, they give a certification for drug testing lab under the schedule of L1. They also call it is a GLP certification. So we are discussing OECD. So when you look at OECD, 1970, US FDA and EPA, they got a complaint that there are a lot of labs in US, they are doing studies, but these studies are not according to the, that they are trying to falsify the data. So one of the lab, they have conducted 22,000 studies before the investigation began. So when they investigated, they find that study director is not qualified. They have not done as per protocol. You know that when GLP study you conducted, there is an appointment letter of a study director that Dr. So-and-so will do the study with this study personnel. And there is a legal liabilities. If I do a study in US or Europe, if I go to another company also, if something goes wrong, then I am legally accountable, because product will be approved in the market based on this study. So then they could find falsification and other problem. So what they did is, ATs, they formed 29 nations, they formed the OECD. But there is also one other angle. After World War II, there's a business was disrupted. So the France took the lead to streamline the businesses. So we fortunately, we become right now, last 2020, we are the vice chairman. Now we become a chairman of OECD. So India is taking the lead. So all this study, you have to do it under OECD principle. Let me tell you, when you plan for a preclinical toxicity study, design is very important. Like, clinical study, you have RCTs. And preclinical study also, you have a design. You have a control group, normal control group, you have a fecal control group. You have a treated group or disease group, we have a positive and negative control. Why the positive control is required? Because you are looking for a new treatment. So that you have to prove it, is it better than existing treatment, and that's how we have to prove it. Okay, you go for a randomization also. So all this need to be looked at, and then only. So what do you do in acute toxicity study? You give a single application and you observe the animal for 24 hours till 14 days. So when you observe the animal, how do you look at the toxicity study? Animal is not going to tell you that I'm not well, So you observe that how much food is intake, how much water intake is there. So you compare with the normal rat, then you look at 27 clinical signs, 27. Like you say, loss of fur is a sign of toxicity. Then you look at the orifices, any bleeding from orifices. Like that, there are 27 clinical signs in order to find out that toxicity. Okay, and then you sacrifice the animal. First thing you notice that all the vital organs. So it starts from brain, then lung tissue, heart, liver, kidney, all the vital organ. And next one is total 47 organ, including lymph node, total 47. So you go for a morphological, you go for a histological, okay? And that is for an acute toxicity study that is required if you prescribe the medicine in a clinic for 10 days, 8 to 10 days. Now when you go to prescribe the medicine for 28 days or 1 month, what you are required is, repeated dose toxicity study, at least 14 days. So there you are going to give, one dose twice in a week. And depending on clinical use, you go for 28 days, 60 days, 90 days, 1 year. What does it mean is, if you give the drug of 10% of the lifespan, how the body is going to behave. And that is what. Now, if you go for more than 6 months, In clinical use, like Alzheimer's, hypertension, diabetes, we go for years together. There you require the long-term toxicity study. You are going to give the drug till 2 years of their lifespan. And some of the questions you need to ask that, can it cause mutagenicity? Can it cause carcinogenicity? Mutagenicity may not develop a carcinogenicity. If you look at omeprazole, experimental data says it is mutagenic. It can cause cancer, but we do not have a human data. So this is how you go for it. So when you go for a new drug development process, you identify the target, select, synthesis the chemical, lead optimization, candidate selection, preclinical development, then you make an IND application, investigational new drug application. Then first time in a man, that is phase 1 study in healthy human volunteers. Obviously, when you go for anti-cancer drug, you are going to include the patient. You are not going to include the healthy volunteer. Then proof of concept study in a patient, phase 2, and larger clinical trial, phase 3. So their phase 2, also phase 2A, homogenized population. Phase 2B is comorbid condition. Similarly, phase 3 also phase 2A, phase 3A and B, then you apply to the regulator, and once regulator take time and give an approval, then drug come to the market. And you have a system of continuous surveillance of that product, and that is why you have a PMS study and the life cycle is going on. So this is how you ask for a IND application, that you do all the regulatory toxicity study, and finally you apply for first time in human, that is phase 1 study, that is an IND application. So IND is not for marketing approval, it is for, you are looking for doing the study in healthy human volunteer. So what are the data is required for filing an IND? You say acute toxicity study, repeated dose, safety pharmacology, pharmacodynamic, ADME, genotoxicity, reproductive, all this reproductive, it comes in segment 1 study, segment 2 and segment 3 study, 3 study. I'll talk about detail. Then special toxicity study, toxicity for local application for ocular, rectal. So all detailed data is required depending on clinical use. So now go by one, what do you do in acute toxicity study? So in acute toxicity study, what you do, usually you take 2 rodent, mice and rat. But FDA difference, they said only 1 rodent. Like you say, how many animal? Maybe 5 for a regulatory. We can go up to 6. So here, if you say 5 animal of either sex, you got the point? Male and female. How the drug is behaving in male, how the drug is behaving in female. Then you have, normally when you extrapolate the dose, your base is in silico, in vitro and proof of concept. That will come as median dose. So you take a lower dose and higher dose. But here you are going to discuss a lot of activity. Does it have dose dependent effect? Okay, so then you take an appropriate dose and 3 to 4 dose, and here single bolus continuous input several dose within 24 hours, and you are going to observe till 14 days, and that's how you have all record of clinical sign, mortality, morbidity, everything you are going to record. And here you can see that you observe for 14 days. One important point is vehicle control group. Because tomorrow you say drug has this toxicity, what about vehicle? And that is why design is very accurate. Many times, you apply for a DMSO, drug is dissolved in DMSO. You say this is neuroprotective. But when you look at the literature, DMSO itself is a neuroprotective. And that is why you have to keep a separate group of vehicle control, positive control, or second, in a proof of concept study. So what you are going to extract from acute toxicity study, it's a NOEL. No adverse event at that level, and the low adverse event that level, because this is going to help you to extrapolate the dose when you start with a human dose. So when you look at better, so how it is going to helpful, you are determined that how safe it is in mice, how safe it is in rat. Is there any species variation? Then you look at target organ. First thing you are going to ask, does it have any effect on vital organ? Okay, you can see that brain, lung tissue, heart, liver, spleen, kidney. Okay, so it might have an effect on vital organ if you say drug is liver toxic. Okay, today if I ask you what is the most commonest drug causes liver toxicity, is paracetamol. Okay, it is paracetamol. In COVID we use tons and tons of paracetamol. But how you use paracetamol, we know it is hepatotoxic. But if you stop, liver function come back to the normal. And that's how you say that, how safe it is it reversible? If it is reversible, then it is okay. But if there is a permanent damage, you are not going to go for a next stage. You have to stop it there only. So from acute toxicity study, you get to know that if you go up to 4 gram, safe, we use for arthritis. But if you go for beyond this 4 gram, it is going to damage the liver. So this data also help the clinician to give an indicate that if there is a accidental, suicidal, homicidal, how you are going to manage with overdose, okay, with toxicity data. But here if you look at that, you work on several compounds and you say this is safe or this is durable. But if you look like C, it is safe, but if you look at critically, it is more toxic than another compound, that is D. And that is why you have to look at critically and look at that how you recommend. Then you go for the next one is repeated dose toxicity study. If you go beyond, give a prescription for 21 days or 1 month, what do you do? One rodent, another one non-rodent, depending on duration of the study, 3 to 4 dose, and you give feed water, intended route to the human, and daily till time of sacrifice, recovery group, all this you are going to look at, whether it is 14 days, 28 days, 90 days, 6 months, 1 year. So all depend on clinical use. You have to say, suppose you say somebody say, I wanted to give it for 20 days clinically. Then regulatory will say that at least you come up with 14 days repeated dose toxicity study. So it is given twice in a week. Okay, and you look at all the clinical sign and you have a control, fecal control group. What you do here, you do all liver function tests, kidney function tests, routine blood biochemistry, everything you do. So here if you look at the physical examination, you look at all the vital organs. In CNS, you do all the behavioral tests. How many behavioral tests, 48 behavioral tests. And when you do behavioral tests, this is a battery of tests. Normally if you say that, does this drug affect CNS? If you don't have anything, you just go for a writing reflex. If there is a loss of writing reflex, you get to know that it has a CNS depression effect. So you can do it in mice, rat, but you cannot do writing reflex, only one animal, that is cat. Okay, so all this, then what you are going to extract? You are going to extract incidence, severity, magnitude, and deviation of normal range and reversibility of, you confirm from the acute toxicity study what you get NOEL and LOEL, and again when you do it, repeated dose toxicity study, you are going to reconfirm that NOEL dose and LOEL dose. Okay, but one more important point is when you start the lab, if you go to lab that you had done a repeated dose toxicity study, all the blood, liver function test and kidney function test. You go and ask the biochemistry and pathology lab, what is the reference standard you are using? And they will say, if you come to the north, they will say we use BioRed. If you go to south, they will say we use CMC reference standard. But here the point is, whatever reference standard you use, it is not appropriate for animal, rat and mice. So their lab should be asked that you should create a historical control. What is a historical control? I have been doing for last 15 years animal toxicity study. I have all this normal control group of the blood biochemistry profile of liver or kidney function, and that is called the historical control, that you have to cover that. So here another test you do is genotype. Can it affect the gene? Okay, and before COVID, let me tell you, there are 5 places USFD had come. I had to accompany. One of the lab, now it is closed, and all the blame it come to a senior lady, because when you do genotoxicity study, you do it manually. You count it, the plate manually. So you say, what is your procedure to count manually? Do you go clockwise? And that is why all this GLP lab, they say that when you do the test for pathological, all this counting in a slide, there should be peer reviewed. There should be peer reviewed. What is peer reviewed? Somebody else who have an expertise, they'll again review the slide, whatever diagnosis you have made it. And any of the lab, you say, where is your reference lab? Like we have an NTDL, National Dope Testing Lab, and you ask that where is the reference lab? If some athletes say that I'm not agree with this finding, so we have a reference lab in Cologne, Doha. So any lab, when they say that we are performing well, then you have to say that is there any reference lab, is all the tests 10 to 20%, it is been verified again by the reference lab. And that's how we have a lot of method for genotoxicity, like your in vitro test, mammalian system, in vivo test. You can take also healthy human volunteer, they can do a test. And there, that lab should have a Institute Human Ethics Committee. They have to give an approval. So this is how you do all the tests. Then in terms of when you use the drug for more than 6 months, you are going to go for a long-term toxicity study. So what are the findings you say? You say all the drugs that are expected to clinically use for more than 6 months, you are asking for long-term toxicity data. If any drug, it shows that it has a carcinogenic potential, even if you use for less than 6 months, you are going to ask for long-term toxicity. Like for example, we have a nano product. So anybody who asks for a nano product, if it is 10 days or 15 days or 1 month, still will ask for a long-term toxicity data, because this nano product is retained in the body for a long time, so there is a chance of mutagenicity and carcinogenicity. Okay? So that's how all long-term retention of the patent compound or metabolite, you are going to ask for it. So what you do in carcinogenicity testing? You are going to recruit at least 50 animal, rat and mice, because you are going to observe the animal for at least 2 years. Their lifespan is at least 2 years. So 50 per 6 and 3 to 4. Only difference is here we keep a carcinogen. Okay. Other acute toxicity and repeated dose, we do not keep a carcinogen, and that's how all the tumor, we also look at the biomarker of the tumor, and that's how you go for it. So any drug beyond 6 months, you are going to ask the question, can it cause mutagenicity? Can it cause carcinogenicity? So this is how. So you might have seen that we have many of the drug is very, very useful. One of the drug I can tell you is cisapride. So if you ask the gastroenterologist, very useful, but that had to be withdrawn because of QT prolongation. Tarfinadine had to be withdrawn because of QT prolongation. And most recent is COX-2 inhibitor. It was a blockbuster, but it had to be withdrawn because of arrhythmia. So now regulators say that all the drug when you introduce, you are going to look at all the safety pharmacology studies. So there is a special branch has come up. So you can also join as a member of safety pharmacology. It's a very good society. So there they're going to evaluate if you give a drug for GIT, can it affect respiratory, can it affect cardiovascular, all the system CNS. So if you look at that, cardiovascular effect, how you evaluate it? In mice and rat, there is a system called telemetry. So if you look at today how we develop, you remember Dale? Dale, he is from Cambridge University. And how it called Cambridge University? Because there is a river called Thames River. Tomorrow I'm going to go to Innsbruck University in Austria. So there is a river called Innsbruck, and that's how. So if you look at the Dale, he actually started recording the blood pressure. How he record? He put the cannula into the artery, and that is called direct record of blood pressure. Then it is modified, we have a tail cup method for recording. But nowadays, everything you are coming with a telemetry. So we have a sensor, invasive telemetry and non-invasive telemetry. So you can record all the blood pressure, ECG, EMG, everything you can record through the telemetry. Okay? You can read about telemetry. But here it is important point, if you take a rat ECG, and what is the difference between the human ECG? Human, our heart rate is 72 per minute on an average. If you take rat, it is 450. Mice may be 300 to 350. So typically you cannot record PQRS. So there is a difference. So that you need to study, how the difference is there. And when you give any antiarrhythmic drug, how you are going to record this. So you might have seen earlier, we can record the ECG, but we do not prefer to use some of these anesthetic agent. For example, ether, not recommended because it can cause arrhythmia, or there is also fire hazard is there. Okay, so you just read that how. Like suppose you wanted to do it for a dog, big L dog. How do you do the ECG or all the telemetry? They have a jacket. They put the jacket, they record the ECG, all the parameters. Similarly, respiratory function, we have an inhalation toxicity study. So when you go to GLP lab, all these rat and mice put into the chamber. I'll tell you the concept, and it was done by one of the Indian scientists. He is in B.P. Patel. He was supposed to get a Nobel Prize because he discovered a Z receptor. Okay, so you put the animal into the chamber, so there is an inner lung volume and there is an outer lung volume. So you make a ratio by connecting to the computers. So you have a model like histamine aerosol, egg albumin. So there are several models where there is a bronchoconstriction. So inner lung volume will be reduced, outer will be the same. And that's how when you give a drug, if there is a bronchodilation, you can record. So all inhalation toxicity study, if you say you sacrifice the animal, take out the trachea, put the normal saline, take out, put it in the slide, that called bronchoalveolar lavage. If there is a acute inflammation, you can see neutrophil. If there is a chronic inflammation, you can see the macrophage. And that's how you look at respiratory, autonomic, CNS. I just said that how do you look at the CNS? We do 48 tests. For example, you have a memory test. We have a Morris water. You wanted to see the coordination. You have a rotarod. Grip stain. All these total 48 tests is there. So minimally, if you say any drug acting on CNS, you have to do all battery of the test to establish. Okay, and we have a software also. We use Ituvision. Okay, so that's how we record. Then all the bowel transit and mechanism of action, you go for it. But any of the drug, if you say, I wanted to use a biosimilar, monoclonal antibody or vaccine, first thing you are going to ask that, can it cause autoimmunity? Any application come to the regulator of all this biologic or biosimilar or vaccine, we ask the question, can it cause autoimmunity? So we have a series of immunotoxicity study. Okay? So if it is autoimmune, what is the chance? So in the preclinical study, we do all these tests of autoimmunity. So normally when you say that how you generate preclinical data, when you look at clinical use, it should be more than 3 times the clinical data. If I wanted to use for 10 days, it should be more than 3 times. Okay, so this is how all the regulation up to 2 weeks, 1 month, non-resident 1 month, up to 1 month, 3 months, 3 months. So this is how all this, if you look at that Europe, if you look at US FDA, of course we have a variation. They say 1 rodent, 1 species, but our schedule say 2 rodent, mice and rat, and that's how you say. So when you go to special toxicity study, you develop a drug, you ask the question, can I use in pregnant women? Okay. Next question you ask, can I use in lactating women? Babies taking a milk. So here if you look at that, there is a provision that we do segment 1 study, segment 2 study, and segment 3 is perinatal study. What you do in segment 1 study, what you wanted to evaluate? You give a drug and you say, can it affect the implantation process? There are a lot of drug is causes recurrent loss of pregnancy. So there on the first segment, you are going to generate this data. Can I use the drug during the period of organogenesis? I'll just give you one example. We are doing an MMS trial, multiple micronutrient trial. I'm the vice chairman from ICMR. So when we call the meeting in AIMS, one of the clinicians say, we are not sure about iron, is it safe in pregnancy, early part of pregnancy. We do not prefer to give an iron also. And that's the reason if you see that any of the pregnant women do not give the drug unless it is proven. Okay, I'll just give you an example. We said do not smoke, do not take aspirin. Aspirin should be also avoided. It is not, in animal it is teratogenic, but it is human, it is not teratogenic. But we do not prefer to use, why? Because any analgesic if you give, there is a vasoconstrictor. Basic is, it inhibits the prostaglandin. So what you get output, there is a low IUGR baby, growth retardation. So we do not want to give aspirin also because it affects the placental circulation. Okay, smoking we do not allow because it causes vasoconstriction. So that is why. So when you look at that segment 2 study, you can take an example of thalidomide. It was developed in 1950, and when they developed, they had studied in mice and rat. It was absolutely fine. But please remember, mice and rat do not have a vomiting center. You know that? They do not have a vomiting center. So it was absolutely fine. But they also studied in rabbit. And rabbit, they could find teratogenicity. So incidentally, 16 December 1961, one of the pediatricians had written a letter to Lancet. And he had written beautifully that I am a pediatrician. Normally, I sit in the OPD. I feel congenital anomaly is 1.05%. But recently, I have seen a lot of phacomelia cases. And then people came to know, it became a signal. People came to know that there are 10,000 babies born with phacomelia. Then they went to the court, and court had asked for all the data. Court had asked for all the data. They could find, they already knew that it is causes teratogenicity. The same company, they applied to US FDA, and there's a lady inspector, and she had a serious concern. She never allowed this drug to be marketed in US. And later she was awarded by President of US. I went to Brazil because I look after the sports program. In my life, I first time saw the phacomelia case. He was participating in Para-Olympic. So you know that they do not speak English, they only speak Portuguese, okay? But I said, is it thalidomide? His mother was there. And she was so excited and say it is because of thalidomide. So today if you say that, how is the thalidomide is bad drug? Of course not. We use for multiple myeloma lepra reaction. We did not know how to reposition the drug, and that is why all regulatory studies should be there. So segment 3 study, what you do, if you give a drug to the lactating woman, baby is taking a milk, can it affect the babies? So you know that when you evaluate any drug, you say, is it suitable for less than 12 years, less than 5 years, less than 2 years. We never allow to use the drug like ciprofloxacin because it affects the cartilage. If the drug affects the cognition, you are not going to allow in children. And that's how we look at all this. So you have all genotoxicity study, in vitro study, both in vitro and in vivo, then carcinogenicity. So when you do carcinogenicity, it is going to take how many years? 2 years. So by the time you are going to complete phase 1 study, phase 2 study, before you start the phase 3 study, you are going to ask the company or any manufacturer, give us the carcinogenicity test, okay, to start the phase 3 study. So this is how all the male fertility test is done. Why male fertility test is required? We can read Schedule Y and NDCT rule. What is the requirement? You can read European Union or US FDA. Why the requirement is there? You do a phase 1 study. Who is the eligible candidate? 18 years boy, male. He participated in a study. After 2 years, he get married, and he doesn't have children. He might come back to you and say that, you know, I participated in a study, I don't have children, and it is because of your study. You know that during COVID time, there is a very good drug, mellocorabine. It's cheaper, and it is very effective, you know, but Dr. Bhargav had asked me, should we go ahead? I said, sir, no. Will not recommend. What is the reason? Only apprehension that when you use the drug, you need to take a protection because it is going to have a reproductive toxicity. Now, if you tell that you take the drug, you take a protection in India, you know that how many people will follow, you never know. So ultimately, we have a problem like thalidomide, and that is why we did not recommend mellocorabine. And that is why you have to look at all the reproductive toxicity study. So when you give the drug, you know, for male also or female also, all the testes and epidermis, everything you are going to give it. And for female production also, you go for a segment 1, segment 2, segment 3 study, and all this albino rabbit, you are going to do it. So subsequently, you know, during the vaccine, you know, ICM, I was a chairman. Somebody, DST advisor, he called me. He said, my son is getting married. I said, congratulations. Okay. Then second question was that, should we go for a vaccination? I said, of course, yes. Then he asked third question, can it affect the babies? So you can see that people look at in a, you know, different angle, and that is why you say that today you say, you know, any vaccine you give, you generate the data. Is there any site of reaction? So you sacrifice the animal. You know that there is a study of a vaccine we did a study in one of the lab in Bangalore. And later we started a clinical study, and 5 female were given, and it was a big abscess. So we stopped the study, then we again look at the preclinical data. Where there for a mice and rat, there is the same problem. It was absolutely fine, but in human there is a big abscess. And that is why you said that, why do you keep the data? In GLP data, preclinical, we keep it for 3 cycles, that is for 9 years. Clinical study, we keep it for 5 years. So all the regulatory, if you go to Brazil, if you go to any other country, even Sri Lanka also, they say 15 years, okay? So this is how you keep all the data. So you look at dump, body weight, food intake, everything, PUFs, and everything you do. For example, if you give a valproic acid, for example, it causes teratogenicity, it causes autism. How do you look at in animal PUFs? So you screen the PUP, male pup will be more prevalence to autism compared to the female pup. How do you do it? Just allow them to work on a straight line. Those who are autistic pup, they'll go to the side and they will fall down. Normal pup will work together. Then there is a delayed eye opening. What is a delayed eye opening? Like if you give any food to autistic children, what they do is, they do not learn. So that is why they say you have to put it in front of the eyes and there is well lighting. If you give a food, they will take the smell first and they will take that food later. So you do an olfactory test, we do a swimming test, screening. Then you say these are autistic, these are not autistic. So you can look at the curative treatment or preventive treatment. So similarly for teratogenicity also you go for fetus and dumps, everything you go for perinatal study. As you say, drug is excreted. How much it is excreted? Can it affect the growth of the baby and cognition? Okay, all these tests we are going to do it, all the perinatal study, and these are animal body weight intake, everything you are going to screen. And any of the study, you know that under OECD you go for a dermal toxicity study, any local application, topical application, you go for a dermal toxicity study, and there you are going to take more sensitive animal. Prefer to have a guinea pig because they are react more to the histamine. So this is how you go for it, photoallergy or dermal. So any erythema or edema formation you are going to do it. Then local application, like I said, there is an application. They had done the oral toxicity study, but they did not use, but they clinically wanted to use a vaginal application. Then we said that we must come with a vaginal toxicity study. Or in case of a rectal, so here any swelling, closure, everything, histopathology finding you are going to do. So why you do rectal tolerance? Because in children, you may not have availability oral or intravenous or intramuscular. So if it is suitable for children, so initially you generate the data, can I give it rectally during that time? So you have a blood, mucus, feces, condition of anal region or the gross, so any of this. So here if you look at that, any injectable, what I say vaccine, all of us we took a vaccine. How many of them they have a reaction at the site, local application. So initially you say that when you took it, is there any erythema, itching? And later also you sacrifice, you go for a histopathology. So all parental. Now it is very interesting. How do you look at ocular toxicity study? You give topical application. So if you say that we usually use a rabbit, you say you give the drug, rabbit have a redness of eye. What does it mean? It means it is irritant to the vessel. So you have a basic asking question, can it lose the sensitivity? So you look at the corneal reflex, light reflex. If there is an irritant, how about intraocular pressure? So intraocular pressure also diurnal variation. Maybe morning is more, evening is that. So you record the pressure. Okay, and then you establish the ocular kinetics. Like blood you take from, middle cubital vein. So there also you have a clock. You take it at 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Take out the aqueous humor. And the same time you take the blood also. So your question is, can you give topical and it goes to systemic circulation? Many of these beta blocker, it affect the heart when you use topical application. So you are going to establish a ocular kinetics. So this is how inhalation toxicity is done. All respiratory rate, bronchial lavas, and histopathological of respiratory function, allergogenicity. As I said, that you go for a lymph node, everything of this lymph node you are going to take Canidepic. Yesterday I've given an example. We know from the day one, phenytoin causes pseudolymphoma. Okay, we know from the day one. So this is how you're going to evaluate. So today, if you say that I met that person who are from South, Korea, he started with concept of pharmacometric and system pharmacology, and he said it took 8 years time to implement this concept, because when he had written a paper, he sent it to journal. Usually, it sent it to statistician, they rejected. Today, any drug you give, you say you do a PBPK modeling. Physiological based, pharmacokinetic and pharmacodynamic. You make a compartmental model. You do for a systemic, pharmacology. So this is how all pharmacodynamic and kinetic you do, and that's how it is very important, because if you look at the WHO list, how many drug can causes cardiac arrhythmia concomitantly, even food also. Okay, so that is why QT prolongation you have to look for that. So ultimately, you are narrating to the efficacy. Okay, but safety is very important. Then you look at that pharmaceutical of new chemical entity, how the drug is absorbed, how it is distributed, how it is metabolized and excreted. So this is how you have a risk and benefit. But one thing is that outside, when you develop a drug, if it is abuse potential, dependence, or it can be used in sport activity, they also inform the NADA, National Anti-Doping Agency, so that they will come up with a methodology. Okay, so you have a drug dependence relationship potential, but this information is very important, that what dose you are going to start in the human, and that's how you look at. So there's a guidance from the industry also. So when you talk about US, they have a 15722 form, and all the data you are required to put it. In India, we had a form 44 earlier under Schedule Y. Now it is Sugam portal, so you submit. So all these tests you see that then 3 times more you have to generate, and that's how we have a Schedule Y, but Schedule Y is replaced with endicity rule today, but similar principle is applied. So all this, if you see that how many times you have to generate the data, all this route. So in case of a IND application, all the preclinical data with the clinical protocol, with the biodata you have to say, but you have to see that any drug, when you give it to human, it has to be prepared under Schedule M, good manufacturing practice. And this Schedule M has been revised. Now there is a revised Schedule M you have to prepare. So all clinical protocol you have to give, and ultimately if you see that panel they evaluated. Earlier we have an IND committee, and this IND committee is headed by Secretary DHR. Now it has been become IND SAC. So if you look at that, in US they make an application. So they have a medical person, chemistry person, pharmacology, statistician. So earlier when I had gone to US FDA a couple of times, I asked how many you have pharmacokinetic person. So 10 years back they had 80 people. So you can create, you can think of it, imagine that how big structure if you go to Maryland, US FDA. So this is how we evaluated. So normally in US, you make an application, if you do not get any reply, within 30 days, it is presumed that it is approved. So with NDCT rule, same thing is applied. If you make an application and if you do not get any reply, so it will be considered that you are a happy man and a woman as an applicant, and that's how it is approved. So this is how we do it, but here it is important point that in India, we only allow IND application if the drug is discovered in India. So if you look at the 1980, we had only 1 or 2 applications. But today, in a month, we have a 5 applications because people are looking for a new drug after WTO signatory 1995. So people, industry is looking for a new drug. So I just conclude here, this is my website, and these are the book, and this book has been released now, and this is what. Yeah. So thank you very much. So any questions, I'll be happy to answer.
Just one simple question, sir.
Yeah.
What are the agency or company IND application except
All-
CDRL, other than CDRL?
all the major company, they make an application. But there are a lot of CRO also, like Dr. Reddy's at Origin. So they have a repeated application for oncology. You know, Zydus, they have a big R&D. So all these companies who have an R&D, they make an application. Yeah.
One of the job opportunities.
Yeah,
for
yeah, yeah.
Good morning, sir. Sir, as usual, we learnt a lot from your session. Just I wanted to know that we have 47 organs. So do we need to study all the organs, pharmacological and histological in a pre-clinical study, or we may do not need all the organs?
Yeah, because tomorrow some clinical effect comes, then you have to dig out the preclinical data. So most of the good lab, they have a SOP of taking out all the 47 organs.
It is mandatory, sir.
It is studied data.
Thank you, sir.
Yeah. Okay. So anything you wanted to learn for vaccine also? You have a time? Time nahi hai. Okay. I'll close it. I'll just close. इसको close कर. मैं निकाल लेता हूँ इसको. हाँ, तार भी दे दो. इनको ना प्रैक्टिकल डेमोन्स्ट्रेशन एक दे रहे ना कि जब एनिमल रिक्रूट करते हैं ना ऑनलाइन सॉफ्टवेयर से कि रेंडमाइजेशन कैसे करते हैं डिज़ाइन का ऊपर, क्योंकि जब भी कोई पेपर भेजते हैं ना ये सारा क्रिटिकली देखते हैं कि आपने किया नहीं तो वो पेपर को रिजेक्ट कर देते हैं. सो द मेथोडोलॉजी शुड बी वेरी क्लियर, यू नो, दैट आई फॉलो CCSA गाइडलाइन, आई फॉलो एराइव गाइडलाइन. सो यू आर गोइंग टू टॉक अबाउट एराइव गाइडलाइन. सो ये लिखना चाहिए.
Thank you so much, sir, for this insightful and enriching session. Now I request Professor Dr. Lalit Mohan, sir, to kindly felicitate Professor Dr. Vikas Mehdi, sir.
एक फोटो लेना है.
फोटो लिया आ जाओ. मैं पूछ ही रहा था कल से थैंक यू.
Thank you, sir. We now move to our next talk on how to calculate LD50. We are delighted to welcome Dr. Pramod Majhi, sir, Associate Professor, Department of Pharmacology, AIIMS, Patna.
जी सर. So, thank you for kind introduction. At the outset, I must congratulate and thank you organizing team for having me here. And good morning, one and all. So I request all of you to please open your laptop and we will do Excel, some work on Excel, and keep ready your notepad and pen. All have a laptop? No. Okay. So open your notepad and pen. Wi-Fi connected. Connected, huh? Okay. So, what we will do, as sir told, today we will calculate the LD10. So, I just revised my topic, how to calculate LD50. just let us revise how to calculate the dose which produces the response. How to predict the dose for response, either in the form of efficacy or toxicity. Okay, LD1 or ED1, ED50 or ED99, LD99, LD10. Okay, so today with this hands-on, we will just see how to calculate the any dose which is producing response either in the form of efficacy or this toxicity. Okay, so I will demonstrate only the LD10, but you will be we will be able, after this session we will be able to calculate any dose. So let us begin with the LD50. LD50 is also known as median lethal dose. ED50 is median effective dose. Okay, when it is given in a, we detect in a concentration, it is known as LC50. Okay, so LC50 is median lethal concentration. So what is difference between dose and concentration? Dose is what we give. A concentration, how we find? By taking the blood samples from the treated animals. Okay, so dose is, unit is milligram per kg, and concentration is microgram per ml or milligram per deciliter. Okay, so let us take an example of acute toxicity study having taking the dose of, इसको बड़ा कर सकते हैं क्या? इसको बड़ा कर सकते हैं? थोड़ा सा बड़ा कर दीजिए, ये दिखेगा. Okay, thank you. So let us take, we have dose, suppose 20, 40, 60, 80 and 100 milligram per kg. Okay, and this is for response, either toxicity or efficacy. Okay, so I am just we have to calculate motility, so I am taking response in the form of motility. Okay, so suppose there is 0 with this dose, then 3, 6, 9 and 10. So these are 5 trials in which we have given the 5 different doses, and the out of each of the this experimental group has 10 animals. Okay, so in 10 animals at the dose of 20 milligram per kg, there is a 0 death or mortality. 43 and 66. Okay, and 80 milligram per kg body weight produces 9 mortality, and at 100 milligram per kg body weight it produces all the animals is died. Okay, so this is simple by which simple in first in human dose what we do calculate the dose in animals, then we extrapolate for human beings. Okay, so dose is important, which dose is going to produce 1% response, 1% mortality. Okay, so by this simple exercise we can be able to calculate. So we have 2 methods of this calculation of any dose. Coming to my main topic, toxicity study, lethal dose. We have 2 types initially. One is called arithmetic method and second is graphical method. So arithmetic method is simple. We can do by a pen and paper. So you have pen and paper ready. So in this we do simply we have to calculate the dose difference. Okay. So arithmetical method is known as Carber's method of calculation. So dose difference is the dose difference between the 2 consecutive doses. Okay, 2 consecutive doses. So here it is not applicable for first. Second, what is the dose difference between here is 40 and difference minus 20, it is 20. So 60 minus 40, 20. 80 minus 60, again 20. So this is simplest example, and 100 minus 80, 20. Dose difference is clear to everyone? Is it clear? Dose difference between 2 consecutive doses? Clear hai? Now we have to calculate the mean mortality. What is the mean mortality? Okay, so LD50, as you know, it is the median lethal dose which produces the dose of a drug given to the which produces mortality in 50% of the treated animals, especially in most sensitive species. Okay, so what is mean mortality? It is the again average of two consecutive doses. Okay, so here is 0, then here 1.5, next, say loudly, next, mean mortality, and last one, 9.5. Okay, so this is the mortality. We calculated from this data, mortality data, we calculated the mean mortality. यहाँ तक clear है सबको? Simple dose difference and mean mortality is the difference between the dose difference between the two consecutive doses, and mean mortality is the average of the two consecutive doses. Okay, clear hai? Now the formula is, we have to calculate LD50. So formula is LD50 equals LD100 minus sum of this multiplication of dose difference and mean mortality divided by total number of animals. Okay, so first what we have to do, we have to calculate this, the product of dose difference and mean mortality. Okay, so let us take help of this one into this cell and drag down, all it come, and we can also auto sum 460. Okay, so the sum of dose difference and mean mortality is 460. And what is the total number of animals in each group? What is the total number of animals in each group? 10. Okay, so what will be this quotient? Dose difference divided by 10, 460 divided by 10, 46, 460 divided by 10, 46, and what is the LD100? The dose which produces 100% mortality, or mortality to all. So what is here? It is dose 100. So what will be the LD50? LD50, simply calculate 100 minus 46, 44 milligram per kg. So when we give the dose in a 44 milligram per kg, there will be 50% mortality. Okay, and just you can see the data. See the data. 60 milligram पे कितना death हो रहा है? 6 out of 10. So it must be less than 60, है ना? So this is simple method of calculation, LD50. Okay, यहाँ तक clear है? This is arithmetical method known as Carber's method. Simple, but it is not reliable. Okay, let us take another method that is known as Carber's method. Okay, Carber's, not Carber's, it is graphical method known as graphical methods of Millers and Tenters. Okay, so or also known as profit analysis method. Okay, so let us take the same example. Same example is there, so let us highlight this one. Okay, so again we have to begin with the same data, dose mortality. So what we have to do? We have to calculate the for this probit analysis method, we have to convert the dose in a log dose form, okay, and we have to plot a graph between log dose and percentage mortality, okay. So for this we need percent mortality, okay. So first just calculate this dose into a log dose. So how to calculate dose in a log dose? We have to write equals, then log, take the values, close the bracket, enter. So this is the log dose of dose 20, sorry, and just drag, all values will come. No, it is not come. Okay, so log 10, dose of 10, log 100 is equal to 2. So this is the log dose value. Now we have to calculate the percent mortality. Okay, so how to calculate? Very simple. Number of dead or mortality divided by total number of animals into 100. Simple calculation. So परसेंट मोर्टेलिटी, आप इसको नोटपैड पे भी कर सकते हो. मोर्टेलिटी कितना है फर्स्ट वाले में, कितना होगा 0/10 इंटू 100, 0. सेकेंड में क्या होगा 3/10 इंटू 100, क्या होगा 3/10 इंटू 100, 30%. 6/10 इंटू 100, मिडिल रो थर्ड बेंच. मैडम आप फॉलो कर रही हैं? हाँ नहीं, आपके बगल में मोबाइल देख रहे हैं. सर आप फॉलो कर रहे हैं? व्हाट टाइम, इसको समझ पा रहे हैं? अच्छा नेक्स्ट बताइए, परसेंटेज मोर्टेलिटी क्या होगा 9 का, 9 मोर्टेलिटी का कितना परसेंटेज होगा बताइए. दिस इज वर्कशॉप ना, सो यू शुड डू सम हैंड्स ऑन. 9 मोर्टेलिटी हुआ आउट ऑफ 10, कितना परसेंट होगा आप बताइए. 9/10 इंटू 100, 90%. नेक्स्ट बता दीजिए 10/10, 100%. So we have two type of two data which shows the 0% mortality and 100% mortality. So as I told, it is known as probit analysis method. Probit is a type of regression analysis, okay. So we have to convert this in when we see the we have to convert this mortality into probit value. So for that mortality we need, for 0 there is no probit value, so we need to convert this percent, 0% mortality and 100% mortality to corrected percentage. So next what we do, we do this percent corrected, okay. So we do for 0 and 100% mortality, okay. Other rest percentage will be same. So for 0% mortality, for corrected percentage, we have formula, just I am writing. For 0% we have formula. What is the formula? This 100 into 0.25 divided by n. N is the total number of animals in each group, okay. So what is the answer for 0%? क्या होगा आप बताओ. परसेंट करेक्शन फॉर क्या होगा, क्या होगा एक्सेलेंट. सो इट विल बी 2.5 और रेस्ट का क्या रहेगा, सेम रहेगा 30, 60%, 90%. And again for 100% mortality, for percent corrected this mortality is, we have a different formula, okay. So for 100% we have formula 100 into कोई बताएगा? n माइनस 0.25 डिवाइडेड बाई n, इसको कैलकुलेट कीजिए, बताइए कितना आ रहा है? कैलकुलेट कीजिए इसको, n इज इक्वल टू 10, कैलकुलेट कीजिए। 75% नहीं आ रहा, 75 नहीं आएगा, 97.5 आएगा, 90, excellent. So it will become 97.5. So this is the corrected percentage or percent corrected mortality. This is the data. Now from the mortality, we collected the percent mortality, then converted it to percent corrected mortality, because we need a probit value. So from where we can get probit value? We have a table that is called Finnish table of percent mortality to probit value. You can Google it and see. Just Google it and see. मोबाइल में होगा आप लोगों का, देख लीजिए, एक बार ओपन कीजिए. लैपटॉप जिनके पास है वो कैन सर्च बाय गूगल. सो आई कैन ऑल्सो सर्च बाय गूगल एंड जस्ट पेस्ट हियर फॉर योर रेफरेंस. मेरा टाइम कितने बजे स्टार्ट हुआ था? जस्ट 5 मिनट्स पहले बता देना, क्योंकि मेरे को जामोबी भी बताना तो वो बंद कर देंगे, ये एटलीस्ट बता देंगे. सो गूगल इट, probit टेबल, Finnish टेबल ऑफ दिस परसेंटेज corrected mortality to probit value. Google it. Otherwise I have here, so we can just copy paste. We are on the sheet 4. Paste. So this is the table that is called Finnish table of transformation of percent mortality to probit value, because we have to plot a graph of log dose versus this percent mortality in the form of probits. Okay. So can anybody tell the values of 2.5%? This is the percentage. So we have to know the values of probit values of 2.5. So 2.5 will be the between 2 and 3. Okay. So what is the value of 2? 2.95 and 3, 3.12. So the average of these two values will be the probit value. Are you able to get? क्या होगा बताइए? 3.114 और 17? 3.04 होना चाहिए. देखिए आप कैलकुलेट कीजिए मोबाइल से दोनों का कितना हो रहा है. हाँ, तो ये तो पेन पेड से कर सकते हैं ना. तो हम लोग यहाँ पे वैल्यू क्या रखेंगे? 3.04. ठीक है. ये हाउ टू रीड द probit table also you should know. नेक्स्ट परसेंट करेक्शन इज 30%. 30% का कितना probit वैल्यू है बताइए. यहाँ देखिए 30% probit वैल्यू इज 4.48. 4.48. नेक्स्ट क्या है? 60%. क्या probit वैल्यू है? 5.25. 90%? 6 point? Excellent. Then for 97.5%, again we have to calculate the average of 97 and 98. Okay, क्या होगा बताइए? 6.56. और कोई दूसरा कोई कंफर्म करा है? 6.56 और 6.96. Excellent. 6.96. Okay. So this we got. Now what we have to do? So the the use of probit is, we finished. Okay. Now, so why I have converted this 0 and 100%? When you look into this table, there is no value for 0 and 100%. That is why percent correction is needed. Okay, so percent correction, I have converted the value percent mortality 0% and 100% to corrected percentage. Okay, now let us plot a graph between the किसके बीच करना है ग्राफ डोज रेस्पॉन्स का आप लोग पढ़े होंगे ना लॉग डोज एंड रेस्पॉन्स तो यहाँ रेस्पॉन्स क्या है इन द फॉर्म ऑफ वी कन्वर्टेड परसेंट मोर्टेलिटी इनटू प्रॉबिट वैल्यू ओके सो लेट अस प्लॉट अ ग्राफ ऑफ log dose and probit value. Achha, oh sorry, 9.6 should be there. 6.96. Okay. So let us plot a graph between this value, insert a graph. So let us see the recommended chart. I will use the probit. So this is the graph now. So by this graph, this is the x-axis is log dose and y-axis is the क्या है y-axis is the probit value. Okay, probit value. So probit value for 50% क्या होगा 50% mortality का probit value क्या है 50% mortality का probit value क्या होगा 5. So 5 represents the 50% mortality. Let us insert a trend line equation, linear, and also we have to so I have taken the trend line, a straight line, and I have to give the equation for this trend line. Okay. Ideally it should be a plus point here, but it is not looking. Add chart element, trend line, more trend line option. So display this equation on the chart, it is needed. So we got this value. This is very important. Okay, can anybody write this equation? And can anybody just, I am enlarging this one or not able to. What is the equation? Can anybody tell? What is the equation? ये बड़ा नहीं हो रहा है कहाँ चला गया Control C, Command V. No, this one is Control Z. What is the equation? आप बताइए दिख रहा है यहाँ पे equation है not visible इसको थोड़ा बड़ा करना है So you write y equal to 5 plus 5 247. Y equal to 5.5247 into minus 4.2831. Just write this equation, trend line equation. This is equation for trend line. y equal to 5.5247, just write, into minus 4.2831. I don't know why it is not expanding. ये बड़ा ही नहीं हो रहा है. देखो अब दिख रहा है ना? Not is visible. So this is the equation, trend line equation. Now we can calculate the LD50 value. So for LD50 value, what should be the y is the probit value. So y for 50% mortality, what should be the I? 5. Finish table में देखें ना 50% के लिए क्या था, y का वैल्यू 5. Okay, so 5 equal to 5.5247 into x. What is x? x क्या है? x एक्सिस पे क्या था? log dose. Okay, minus 4.2831. इसका आंसर निकाला. व्हाट इज द वैल्यू ऑफ x? x इज इक्वल टू क्या होगा? 9.2831 इक्वल हो जाएगा 9.2831 डिवाइडेड बाई 5.5247. क्या वैल्यू आया? सबका आया? कैलकुलेशन पेन पेपर भी कर सकते हैं. आया 1.68. सो व्हाट इज दैट वैल्यू? एक्स वैल्यू. दिस इज द वैल्यू ऑफ एक्स. एक्स रिप्रेजेंटिंग क्या रिप्रेजेंट कर रहा है? एक्स लॉग डोज है ना. लॉग डोज, दिस इज द लॉग डोज. नाउ व्हाट वी हैव टू डू? वी हैव टू कन्वर्ट इन अ टेक इट अ एंटी लॉग टू कन्वर्ट इन अ डोज. सो हाउ इट कैन बी कन्वर्टेड? Is equal to 10 so this is the anti-log value of 1.68. So it is 47.89 milligram per kg body weight, producing 50% motility. So by this way we can calculate the LD50. Suppose I wanted to calculate the LD99. So how it can be calculated? What will be the value of y? LD99 के लिए हम लोगों को y का वैल्यू क्या होगा? प्रॉबिट एनालिसिस, प्रॉबिट टेबल में जाओ, देखो उसका y का वैल्यू क्या है 99% के लिए. यू कैन कैलकुलेट द LD99 वैल्यू. उसका ये लेकिन डोज आएगा लॉग डोज में. यू हैव टू टेक द एंटी लॉग. तो पहले वाले में कितना आया था? अरिथमेटिकल मेथड में कितना आया था? व्हाट वी गॉट? 54 आया था. मिलीग्राम पर केजी इज गोइंग टू प्रोड्यूस 50% मोर्टेलिटी. हियर कितना आ रहा है? 47.89 मिलीग्राम पर केजी बॉडी वेट गोइंग टू प्रोड्यूस. इसी तरह से आप LD99, LD10 और LD1 भी कैलकुलेट कर सकते हो. यदि आपका आउटकम वेरिएबल्स इफिकेसी में है, सो अगेन यू कैन सेलेक्ट एंड कैलकुलेट. सो माई टॉपिक नाउ इज रिवाइज टू हाउ टू कैलकुलेट द डोज फॉर अ रिस्पॉन्स by this simple method, graphical method. And so by putting the log dose and taking the probit value, we can calculate the any dose required for a response. Okay, so what we are doing, we are predicting the value for that particular response, 50% response, 10% response or 20% response, either in the form of mortality or efficacy we can calculate. Now what I explored yesterday, just we can take probit is a method of regression analysis. So we can do by Jamovi software also. So we can do, this data can be extrapolated on the Jamovi software to predict the dose for percent mortality LD50. So if we have time, we can go to the Jamovi software and I can demonstrate. हम लोगों के पास टाइम है, क्योंकि बॉस को हमने प्रॉमिस किया, बॉस कहा है कि आधा घंटा से पहले कंप्लीट करना है. लास्ट ईयर वी एक्सटेंडेड टू मच टाइम, सो मैंने थोड़ा इस बार नया भी किया और ट्राई किया कि इसको आपको बताएं, क्योंकि एमएन घोष में जो दिया हुआ है ना ग्राफिकल मेथड थोड़ा सा डिफिकल्ट है टू अंडरस्टैंड. सो और जो मैंने बुक में भी ये एब्स्ट्रैक्ट है उसमें भी थोड़ा सा मिस्टेक है, आप लोग नहीं ऑब्जर्व करोगे, लेकिन मुझे लगा कि थोड़ा सा नेक्स्ट टाइम में रिवाइज कर पाएंगे. So we can do this analysis by Jamovi software. Linear regression model से we can calculate the dose. So if time permits, I can demonstrate. If all are agree, I can demonstrate the this method by Jamovi software also. वो भी सिंपल है, Jamovi software से कैलकुलेशन बहुत आसान है, उसका एनालिसिस भी आप कर सकते हो, वो भी बता दें कैसे एनालिसिस को इंटरप्रिटेट करना है. वेरी सिंपल. आर यू रेडी? यहाँ तक अब इसको हम थोड़ा सा सॉर्ट कर ले. कोई कलर इसको दे देते हैं, दिस वन. ये मेथड हो गया, दैट इज कॉल्ड मिलर एंड टेंटर्स मेथड और ग्राफिकल मेथड ऑफ LD50 कैलकुलेशन और एनी डोज कैलकुलेशन फॉर अ पार्टिकुलर परसेंटेज ऑफ रेस्पॉन्स. ठीक है. नाउ मूव टू द जामोवी. है हम लोगों के पास टाइम? यहाँ तक किसी को पूछना है? उसका बेस्ट उपाय है कि आप जाओ, मेरा जो उसमें एब्स्ट्रैक्ट में जो एग्जाम्पल दिया हुआ है, सिंपलेस्ट एग्जाम्पल है, आप उसको करके अपना एक्सेल पे करो. ठीक है. नहीं आया तो मेरे से कांटेक्ट करो. मैंने अपना डेमो का जो है ना ऑर्गेनाइजिंग टीम मेल पे डाल दिया है, मनीष बॉस को भेजा है और साजिद को भी, डॉक्टर साजिद को भी मेल किया है. तो उनसे आप लेके एक्सेल का जो मैंने किया है ना, एक्सेल का आप देख सकते हो. आप बोलो उनको कि हमको शेयर कर देने के लिए, आप लोगों का मेल मेरे पास नहीं है. सो आप उसको देख के प्रैक्टिस कर सकते हो, बिकॉज इट इज़ इंपॉर्टेंट इन फार्मेकोकाइनेटिक्स. क्लिनिकल फार्मेकोकाइनेटिक्स का कैलकुलेशन में भी बहुत इंपॉर्टेंट है ना. ये वेरी मच इंपॉर्टेंट, ये जो एक्सरसाइज है वेरी मच इंपॉर्टेंट फॉर कैलकुलेटिंग डोज फॉर अ पर्टिकुलर रिस्पॉन्स. ठीक है. सो लेट अस मूव ऑन टू जामोवी फॉर जस्ट नोइंग दिस कैलकुलेटिंग द LD50. सो आई टेक बस 5 मिनट. हाँ, जस्ट आई विल शो हाउ टू टेक दिस डेटा. सो लेट मी ओपन द जामोवी. सो फर्स्ट लेट मी टेक द command C. So this is the dose. Now we have motility, command C. Command V. Okay. So this is first A is the no. We have to take the log dose and probit value, not this simply dose and value. Okay. So I am doing mistake here. So regression analysis is not done by simple this data. We have to take the converted data. Okay. So here is the. So we have to take the log dose, command C. Dose is dependent variable or independent variable? It is a dependent or independent? Independent. Excellent. And what is the dependent variable here? Is a response or probit value. Okay. Command V. So now, so this is A is the log dose and B is the percent motility in the form of probit value. So let us take the analysis. So we have to do the regression analysis, linear regression. So dependent variable is this B, na? B, probit value. So we'll take, and covariates is our independent variable. Okay, let's see what is the result. So you just, दिख रहा? You just, let me expand it. So you can see here, what is the value of intercept? So हम लोग स्ट्रेट लाइन में y is equal to mx plus c जो फॉर्मूला होता है, उसमें y is the response or motility on y axis, x is the log dose value. What is the m? M is the intercept. Intercept क्या होता है? It is the, क्या होता है intercept? The value when the x is 0, तो क्या होगा? y पे एक टच करेगा ना लाइन जो स्ट्रेट लाइन था. So that line is called intercept. When the value of x is 0, it touches and go beyond the, वो माइनस में होगा. आप इमेजिन करो. So intercept is minus 4 point, intercept is minus 4.28, and A is, what is A? Intercept is not M. Y is equal to mx plus c. C is the intercept. M is slope. Okay, so what is the value of M? It is given as a. A is a independent variable or predictor. A is 5.52. So by again these two value we can calculate, putting the same value in the trend line equation, y is equal to mx plus c, same result will come. Just see what is the result previous, what is the value of, क्या आया था उसका mx plus c में, देखो m का वैल्यू क्या आया था, c का वैल्यू क्या आया था, सेम आया था. देखो, गो टू द बैक, क्या आया था इसमें, सेम आया था ना वैल्यू 5.524 and 4.2831, same value. So we can calculate again the value of x predictor, or what dose going to produce such effect, 50% effect. So by Jamobi we can also calculate the this LD50 or even any dose which is for desired response in the form of efficacy or motility. So that's all. You can read the abstract book. Various sources are available. You can read and do yourself practice. Without practice it is not possible. So Jamobi regression हम लोग सीख लिए. Now just we can see the what is the interpretation of that equation. Okay, आप उसको भी देख सकते हो. So sheet 2, this is the result. I have just taken a snapshot for your reference. And sheet 3, this is the interpretation of your value intercept, minus 4.28. When predictor A is 0, the predicted value of the independent variable y is minus 4.28. And the intercept is statistically significant. I will not go in detail, indicating it is different from 0. And predictor is the log dose, which predicts the response. So for each 1 unit of increase in A or X, the dependent variable increases by 5.52 mx, है ना, 5.52 on average. T value, forget this. So this is regression equation for by Jamobi, minus 4.28 plus 5.52 A, or just mx plus c. Okay, y is equal to mx plus c. C का वैल्यू यहाँ माइनस में था पहले वाले ग्राफिकल मेथड से. अगेन सेम हियर इज द इक्वेशन, y is equal to minus 4.28 plus 5.52. Okay, so that's all about how to calculate any dose, not LD50, by a experimental given a dose and calculating the response in the form of either number, percentage, or this toxicity or safety. So that's all from my end. Any question I will be happy to answer, and I hope today we are before time or on time at least. So आप लोगों को लैपटॉप लेके आना था ना, वर्कशॉप था, लैपटॉप लेके आना था. लैपटॉप ये सब हैंड्स ऑन होना है ना, वो तो केवल थ्योरी तो होते ही रहता है. फिर जाके आप करेंगे नहीं, मुझे पता है 90% लोग नहीं करेंगे, फिर भूल जाएंगे। एंड हैप्पी टू सी दैट लास्ट ईयर से ज़्यादा कुछ न्यू फेसेस है। मुझे लगा कि कहीं लास्ट ईयर वाला ही पार्टिसिपेंट नहीं रहेंगे, है ना, और कुछ नया भी हुआ, है ना। एनी क्वेश्चन, एनी क्वेरीज? नहीं? ठीक है, वंस अगेन थैंक यू।
Thank you, sir, for your clear and practical explanation of LD50 calculation. I now request Professor Dr. Manish Kumar, sir, to felicitate Dr. Pramod Maji, sir, HOD, Department of Pharmacology, AIMS, Patna.
A very good morning to everyone. I am Dr. Trisha Priyadarshini, GR1 in the Department of Pharmacology, IGIMS Patna, feeling so grateful continuing the session forward. So now moving ahead, I would like to invite Dr. Ramesh Kumar Nirala sir, Associate Professor, Department of Veterinary Pharmacology and Toxicology, Bihar Veterinary College, Patna, to come on the stage and share his valuable inputs about ARRIVE guidelines.
Very good morning to everyone. Are you audible? So, very good morning to everyone. Thank you for organizing team to giving me opportunity to deliver a talk on ARRIVE guideline. So, question is that what is ARRIVE guideline? What is the main theme? I think is somebody are confused with CPSA guideline or ARRIVE guideline. So, anybody have idea what is difference between CPSA guideline or ARRIVE guideline? Okay. So, what is ARRIVE guideline? ARRIVE, that is the full form, Animal Research Reporting in Vivo Experiment. As we know that there are two type of experiment protocol, in vitro experiment protocol and in vivo experiment protocol. So, in animal research reporting in vivo experiment on the base of 3R concept, that is known as ARRIVE guideline. Clear है? किसी को कोई दिक्कत हो तो आप हिंदी में भी पूछ सकते हैं, नो इशू, ठीक। सो दिस इज द मेन फाउंडेशन ऑफ ARRIVE guideline is 3R concept. 3R, first replacement, refinement and reduction. So let's we cover on this talk what is the history behind ARRIVE guideline and foundation of 3R concept earlier told, goal of ARRIVE guideline, how can you use ARRIVE guideline and what are the scope of ARRIVE guideline. So in history this ARRIVE guideline is, let's introduce in University of Federation for Animal Welfare, United Kingdom in 1959. So this ARRIVE guideline based on all 3R concept introduced by this, by scientists William Russell and Birch. So these 3R what is the core purpose of 3R concept? Replacement, use of alternative to animals, cell culture, simulations and other bioinformatic tools. एनिमल्स रिसर्च का कोई अल्टरनेटिव है हमारे पास क्या? अभी नाउ इट इज देर आर सो मेनी एक्सपेरिमेंटल फार्माकोलॉजी हैज बीन डन ऑन सेल कल्चर मेथड, बायोइन्फॉर्मेटिक टूल्स, इन सिल्को टेक्निक भी ड्रग डेवलपमेंट में खुद यूज कर रहे हैं, बायोइन्फॉर्मेटिक्स भी कर रहे हैं, बट वेदर इट इज अल्टरनेटिव ऑफ एनिमल रिसर्च, सम ड्रग डेवलपमेंट्स में है, चूंकि एज पर अराइव गाइडलाइन और CPSA गाइडलाइन इट clears that ki you can use alternative of animal, but it is practically not possible. Why? Suppose we develop a drug designing, we can use a in silico method, but whether I want to develop new drug on the basis of therapeutic purpose or clinical uses, it is not possible. Whether in cell culture method we can perform pharmacokinetic studies, not possible. सिर्फ only drug designing and development. So there is no alternative of animal research. Refinement, if we can perform research and use of experimental animals, we should have to refine or minimize the pain and suffering distress to animals. It means कि जो भी हम animals को use कर रहे हैं, अब एक तो है कि पहले इसका alternative use करना है, अल्टरनेटिव यूज अगर नहीं करना है, सपोज दैट हमको वही एनिमल यूज करना है, देन हमको उसमें रिफाइनमेंट की जरूरत है. फर्स्ट स्टेप कवर के बाद ही सेकेंड स्टेप. अगर यूज ही नहीं करना है तो कोई सुने, देन यूज कर रहे हैं तो फिर हमको रिफाइनमेंट पे आना है. रिफाइनमेंट में हमको यूज करना है कि उसको मिनिमम इन्वेसिव पेन हो, डिस्ट्रेस हो, डिस्कम्फर्ट हो, फील नहीं होना है, ठीक है. और उसके बाद जो है रिडक्शन, यूज ऑफ मिनिमम नंबर ऑफ, सपोज दैट कि बहुत सारा कोई डाटा बनाते हैं ना, कोई भी, जैसे अर्लियर विकास में दिस टोल्ड कि आप ह्यूज नंबर ऑफ, मान लीजिए स्पेशल टॉक्सिसिटी, ऑर्गन टॉक्सिसिटी पे बात कर रहे हो, लेकिन कुछ ऐसा स्टडी है ना, हमको एनिमल्स कितना यूज करना है. जैसे बीइंग ए वेटनरी प्रोफेशनल्स, ह्यूज नंबर ऑफ एनिमल्स, जैसे अभी क्या है, हम अगर सपोज दैट कि आप वाइल्ड लाइफ में जाओगे, तो वाइल्ड लाइफ में अगर हमको टाइगर को रिस्ट्रेन करना है, तो हम उसका काइनेटिक स्टडी कैसे कर सकते हैं? काइनेटिक स्टडी करने के लिए इतना पॉसिबल नहीं है कि हम टाइगर का ब्लड कलेक्शन कर लें, पॉसिबल ही नहीं है. तो उस तरीके से सबका एक प्रोटोकॉल बना है कि आप जिस ग्रुप में है, आइदर टाइगर्स या फिर कंसिडर फेलाइन ग्रुप, तो हम जो भी फेलाइन स्पीसीज के एनिमल्स हैं उसको हम यूज करेंगे एज ए एक्सपेरिमेंटल पर्पस, और उसके डोज को डिसाइड करके उस पर काइनेटिक कर करके फिर उसका डाटा एक्सट्रापोर्ट करके फिर हम उसमें देंगे. दिस इज द प्रैक्टिकल थिंग. ये कोई कह दे कि एकदम अचानक से हर एक चीज पे रिसर्च हो, नहीं, हर एक एनिमल पे भी रिसर्च नहीं हो ना, चूंकि CPSA और अराइव गाइडलाइन भी आपको स्पीसीज वेरिएशन देता है कि आप कौन सा स्पीसीज यूज कर रहे हो, ये बहुत इंपॉर्टेंट है. अदरवाइज आप जैसे सपोज दैट कि मान लीजिए कोई कैटल बफेलो या फिर रैबिट, हैमस्टर, गूज, ठीक है ना, बहुत सारा स्पीसीज है डिफरेंट डिफरेंट बेसिस पे, आप कोई भी नहीं यूज कर सकते. ज़्यादातर केसेस में रैट माइस यूज होता है, एल्बिनो यूज करें, विस्टार यूज करें, दैट इज द मेन थिंग. तो आप जो एनिमल यूज कर रहे हो उसका रिडक्शन, इट्स की मिनिमम नंबर यूज करना है. अगर आपका डाटा वैलिडेशंस के लिए जितने एनिमल्स चाहिए, सपोज दैट कि 10 एनिमल्स को एक ग्रुप बना रहे हैं, अगर ये 6 एनिमल्स है, मिनिमम 6 एनिमल्स है, तो चूंकि अगर हम अराइव गाइडलाइन की बात कर रहे हैं और आप लोग सब लोग इथिकल क्लियरेंस के बारे में पता है, इथिकल क्लियरेंस में CPSA कहता है कि अगर मान लीजिए 6 एनिमल्स अगर एक ग्रुप में रख रहे हैं या फिर 10 एनिमल्स रख रहे हैं फॉर प्रॉपर डाटा वैलिडेशंस, तो आपको वो मिनिमम ही लेना है. ये नहीं कि हम 50 पे कर लिए और वो चलेगा. दिस इज चूंकि वो इथिकली अनअप्रूव्ड हो जाएगा. इंस्टीट्यूशनल तो हम लोग कर देते हैं, एज पर CPSA कभी बड़ी लेवल पे टीम आती है तो उसमें प्रॉब्लम होता है, आप जस्टिफाई नहीं कर पाओगे. सो ये मेन क्वेश्चन इज कि अराइव गाइडलाइन पे कि पुअर क्वालिटी रिसर्च इज वेस्टेज रिसर्च, ठीक है ना. एक स्लाइड है, इसमें 3-4 पॉइंट लिखा है, देखो, क्वेश्चंस, मेथड्स, डाटा एंड रिजल्ट्स. हम कोई भी रिसर्च करते हैं, जैसे हम लोग पर्पस क्या है, फार्माकोलॉजी पढ़ रहे हैं, ठीक है, तो पर्पस क्या है रिसर्च करने का, सब क्लियर है ना हिंदी में. पर्पस है रिसर्च करने का कि हम कोई भी रिसर्च कर रहे हैं तो उसका एक प्रॉपर रिपोर्टिंग हो, फाइनल उसका कुछ कंक्लूजन निकले, उसका अल्टीमेटली गोल क्या है? फॉर क्लिनिकल एंड थेरेपेटिक पर्पस, न्यू ड्रग डेवलपमेंट हम कर पाएँ। हमारे ही रिसर्च के बेसिस पे जो हमारा रेफरेंस जो एक डॉक्यूमेंटेशन होगा, उसी के बेसिस पे जो डिफरेंट फार्मा कंपनी है, जो मल्टीनेशनल कंपनी है, चाहे जो भी सेक्टर्स है, जो भी ड्रग मैन्युफैक्चरिंग या फिर फार्मेसी वाले मिलके करते हैं, उसी के बेसिस पे करेंगे। अगर वो डॉक्यूमेंटेशन ही प्रॉपर नहीं है तो जो भी हम ड्रग डेवलपमेंट की बात कर रहे हैं, जिसे टॉक्सिसिटी की बात कर रहे थे, अगर प्रॉपर डिजाइनिंग स्टडी डिजाइन ही ना हो, उसके रिजल्ट ही सही नहीं आएंगे। फिर हम पता चलेगा कि टॉक्सिसिटी किसी और कारण से हो रहा है और हम ब्लेम उस ड्रग को दे रहे हैं कि उसकी वजह से आ रहा है। तो एक है क्या कि क्वेश्चन मीन्स रिसर्च प्रॉब्लम। इट केप्स इन माइंड कि हम कोई भी कर रहे हैं फाइंडिंग, तो उसके पीछे का क्वेश्चन क्या होगा, एक माइंड आएगा कि हम क्यों कर रहे हैं ये चीज़, हमारे रिसर्च करने के पीछे पर्पस क्या है। जैसे हम लोग भी डिफरेंट लेवल पे रिसर्च कर रहे हैं, एंटीबायोटिक पे, AMR पे, वन हेल्थ पे बहुत सारा बात चल रहा है, ठीक है, लेकिन उसका पर्पस क्या? पर्पस है फॉर बेनिफिट ऑफ सोसाइटी। सोसाइटी को बेनिफिट होना चाहिए, चाहे वो ह्यूमन हेल्थ से हो, एनिमल हेल्थ से हो, ये सारा चीज़ें। क्योंकि अभी भी बहुत सारा केसेस है ना, एक अपर लेवल पे जब चले जाएंगे, ठीक है, डेविएशंस है वेटनरी में, लेकिन जैसे ही आप रिसर्च विंग में जाते हो ना, तो वहाँ पे आपको ये चीज़ें एकदम कॉमनली आ जाती है कि बहुत सारा ऐसा ड्रग है जो वेटनरी साइंस में यूज कर रहे हैं हम लोग, उसके एंटीबायोटिक रेसिड्यू आज के डेट में भी मिल्क में। कोई ऐसा बंदा होगा, सिर्फ नॉनवेज की बात अगर हम करें कि हम नॉनवेज खाएंगे तभी हमको उससे कोई एंटीबायोटिक प्रॉब्लम या अदर कुछ टॉक्सिसिटी हो सकता है, ऐसा नहीं है। आप अगर मिल्क खाओगे, कोई वेजिटेरियन है, उस मिल्क में भी आएगा, मीट में तो आएगा ही, और डिफरेंट, चाहे वो मिल्क फॉर्म में, अदर वो फूड प्रोडक्ट्स हो, पनीर हो, कुछ भी हो, तो किसी भी फॉर्म में, चूंकि उसकी प्रॉपर टेस्टिंग नहीं हो रही ना, प्रॉपर गवर्नमेंट ऑफ इंडिया ने मॉनिटरिंग प्रोग्राम चला रखा है AMR पे कि ये बहुत, क्योंकि बहुत सारा ऐसा केसेस मिल रहे हैं। WHO ने भी वार्न कर दिया है कि 2030 तक जो है कि आई थिंक लगता है मोर देन 50 लाख से भी ऊपर जो है ना, वो पर्सन जो है AMR से मतलब सफरिंग हो रहे हैं, बिलियन डेथ हो सकता है 50। तो एक है क्या कि आप इरेलीवेंट जो इनकोरेंट क्वेश्चंस है उसको ध्यान में रखें कि हमको रिसर्च करना क्या है, मतलब कि डिसाइडिंग रिसर्च प्रॉब्लम। सेकेंड वन, मेथडोलॉजी। अगर कोई भी रिसर्च कर रहे हैं तो उसका हम प्रॉपर मेथडोलॉजी नहीं है डिफाइंड, तो वो भी रिसर्च का कोई मतलब नहीं है। और जब मेथडोलॉजी नहीं है तो ऑब्वियसली उसके डाटा जो है बेटर रिप्रोड्यूसिबिलिटी नहीं होगी, और जब डाटा नहीं है तो रिजल्ट नहीं, अल्टीमेटली जो भी आपका रिसर्च है वो अनयूजेबल है। अब मैक्सिमम लोग रिसर्च ऐसे ही कर रहे हैं, क्यों? बी प्रैक्टिकल, क्योंकि हम आउट ऑफ वे जाके बता रहे हैं, क्योंकि आपकी कैरियर होती है, आप सोचते हो हम कुछ रिसर्च कर ले, कुछ फाइंडिंग कर ले और एक डॉक्यूमेंटेशन बना करके कुछ पेपर पब्लिश कर ले, हमारी कहीं जॉब लग जाए, दैट इज द मेन थिंग। बट ऐसा नहीं है, आप ये नहीं समझ रहे हो कि जो आप रिसर्च प्रॉब्लम डिसाइड करके जो एक प्रॉपर रिसर्च को एक डॉक्यूमेंटेशन फॉर्म में डाल रहे हो, उसका रेफरेंस लेकर के आप आने वाले फ्यूचर रिसर्च को जो है ना हैम्पर कर रहे हो। ये बहुत बड़ा थ्रेट है ये, मतलब इवन इसकी मेडिकल साइंस या जो भी साइंस के लिए बोल, इसको हमको समझना बहुत जरूरी है। सो व्हाट आर द मेन एम टू अराइव गाइडलाइन? अराइव गाइडलाइन कहता है कि जो भी आप रिसर्च करें, ठीक है, ट्रांसपेरेंट हो, एक्यूरेट हो, कंसाइज हो, कॉम्प्रिहेंसिव, लॉजिकल एंड वेल रिटन, ठीक है, ये अराइव गाइडलाइन है। CPSA गाइडलाइन कहता है कि यू शुड हैव टू यूज ऑफ एनिमल इन प्रॉपर मैनर। CPSA guideline is established on the basis of Prevention to Animal Cruelty Act 1960, ठीक है, सबको कंसेप्ट क्लियर हो रहा है। CPSA से क्रुएल्टी एक्ट की बात करता है कि अगर आप एनिमल में रिसर्च कर रहे हो, कोई भी एक्सपेरिमेंटल एनिमल यूज कर रहे हो, तो उसको क्रुएल्टी एक्ट के तहत उसको करना, मतलब एक क्राइम है। अगर उसको आप अच्छे से रहने के लिए प्रॉपर हाउसिंग नहीं है, प्रॉपर उसका हेल्थ केयर एंड मैनेजमेंट नहीं है, प्रॉपर सुपरविजन नहीं है, तो एक क्राइम है, उसके तहत आपको परमिशन नहीं मिलेगा। लेकिन फॉर द बेनिफिट ऑफ सोसाइटी कर रहे हैं तो उसके लिए आपको इवेंट्स की लार्ज एनिमल तक की भी परमिशन है। लेकिन द डिफरेंस क्या है अराइव गाइडलाइन में? अराइव गाइडलाइन में डिफरेंस क्या है कि आप रिसर्च जब कर रहे हो ना, रिसर्च करने से पहले और रिसर्च करने के बाद ये प्रॉपर डॉक्यूमेंटेशन चाहिए। इट मीन्स कि अगर आप रिसर्च कर रहे हैं तो रिसर्च किस मैनर पे कर रहे हैं, किस प्रॉब्लम पे कर रहे हैं, क्या मेथडोलॉजी अपना रहे हैं। एक्सपेरिमेंटल एनिमल्स और सीपीएसए गाइडलाइन इंक्लूडेड अंडर एराइव गाइडलाइंस, बट आप उसको जो रिसर्च कर रहे हो ना, और उसका रिसर्च के बाद प्रॉपर फाइंडिंग, और फाइंडिंग के बाद उसका वेल रिटेन डॉक्यूमेंटेशन इन द फॉर्म ऑफ पब्लिकेशन, ये पूरा कंप्लीट इंटायर प्रोसेस इज कम्स अंडर एराइव गाइडलाइन। क्लियर है? कहीं से किसी को कोई कंफ्यूजन नहीं होगी, क्योंकि बहुत देर से सुन रहे होंगे कि एराइव गाइडलाइन होता है, सीपीएसए गाइडलाइन होता है, तो वो डिफरेंसेस बहुत जरूरी है जानना। सो एराइव गाइडलाइन स्टेट्स, वही एनिमल रिसर्च रिपोर्टिंग इन विवो एक्सपेरिमेंट, इन विवो की बात करें, इन विट्रो की बात नहीं कर रहे हैं, ठीक है। इट वाज ओरिजिनली डेवलप्ड इन 2010 टू इम्प्रूव द रिपोर्टिंग ऑफ एनिमल रिसर्च, ठीक है। दे कंसिस्ट चेकलिस्ट of information to includes publication describing in vivo experiment to enable other scrutinized work. It means कि आप कोई भी रिसर्च कर रहे हो, एनिमल रिसर्च कर रहे हो, सेल कल्चर रिसर्च कर रहे हो, कुछ भी कर रहे हो, ये सिर्फ एनिमल एराइव गाइडलाइन फॉलो नहीं कर रहा है, ओवरऑल सेल कल्चर की भी बात कर रहा है, क्योंकि यहाँ पे ये भी बात कर रहे हैं कि आप जो रिसर्च प्रॉब्लम जो डिसाइड कर रहे हो उसका बेसिस क्या है, ठीक है ना, क्योंकि वो अल्टरनेटिव की भी बात कर रहा है ना, रिप्लेसमेंट की भी बात कर रहा है, जो हमारा एराइव गाइडलाइन 3 है। तो हमारा एक प्रॉपर चेकलिस्ट होना चाहिए। इससे कोई भी एक रिसर्च करने से पहले एक दिमाग में आएगा ना कि हम ये रिसर्च करने जा रहे हैं, तो उसके पीछे का कुछ रेफरेंसेस कलेक्ट करते हैं, कहीं पे इस टाइप का रिसर्च हुआ है नहीं हुआ है, क्या फाइंडिंग है, क्या बेसिस है। अगर ये पूरा रेफरेंसेस अगर नहीं है तो हम ऐसे कोई भी एक प्रॉब्लम लेकर के सिर्फ एक पेपर पब्लिकेशन के लिए रिसर्च कर लें, वो दिस इज नॉट गुड। So why good reporting is important? गुड रिपोर्टिंग क्यों जरूरी है? इसे एराइव गाइडलाइन में कहते हैं ना कि एनिमल रिसर्च रिपोर्टिंग। अगर गुड रिपोर्टिंग नहीं होगा तो क्या होगा? गुड रिपोर्टिंग जरूरी है फॉर बेटर रिप्रोड्यूसिबिलिटी के लिए। रिप्रोड्यूस मतलब फाइंडिंग रिजल्ट। तो अगर रिपोर्टिंग ही सही नहीं है तो सोचो कितना बड़ा इसका इम्पैक्ट पड़ने वाला है। जो भी हम लोग क्लिनिकल फार्माकोलॉजी, थेरेपेटिक्स, जो भी वट एवर हम कर रहे हैं, किसी जो भी ट्रीटमेंट पार्ट में यूज कर रहे हैं, उसका कितना बड़ा ग्रेट इम्पैक्ट होने वाला है। पुअर रिप्रोड्यूसिबिलिटी होगा, फ्लॉ स्टडी डिजाइन क्यों हो सकता है? हमारा कोई उसका स्टडी डिजाइन नहीं है, हमारा सैंपल साइज क्लियर नहीं है, कुछ भी क्लियरेंस नहीं है, तो अल्टीमेटली जो है हमारा रिप्रोड्यूसिबिलिटी वो नहीं होगा। और जब रिप्रोड्यूसिबिलिटी बेटर नहीं होगा तो हमारा गुड रिपोर्टिंग नहीं होगा। गुड रिपोर्टिंग हम लोग एराइव गाइडलाइन में रिपोर्टिंग कैसे करेंगे? इन द फॉर्म ऑफ चेकलिस्ट और पब्लिकेशन। रिपोर्टिंग का तो यही मेथड है ना। एक रिपोर्टिंग में आप लोग जब लिखते होंगे मैन्युस्क्रिप्ट वगैरह तो डिस्कशन पार्ट आता है। कोई बता सकता है एनीबॉडी कि डिस्कशन होता क्या है? एनीवन? इंटरप्रिटेशन कैसे? मतलब वही हम जानना चाह रहे हैं कि डिस्कशन क्या होता है। इन द लाइट ऑफ प्रीवियस स्टडी, ठीक है ना, वेरी गुड। तो वो डिस्कशन में जो भी हम डाटा इंटरप्रिटेट करते हैं वो एक पेपर ही एक पेपर से बात करता है। वी आर नॉट, हम लोग पब्लिकेशन में क्या करते हैं, उसके रेफरेंसेस देते हैं जो प्रीवियस स्टडी हुए, उसके डाटा के साथ कोरिलेट करते हैं और कहते हैं कि अगर ये हम स्टडी किए कोई पार्ट और कह रहे हैं कि ये माइक जो है ये 5 इंच या 10 इंच लंबी है, ठीक है ना, या फिर ब्लैक कलर का है, तो कितने स्टडीज हुए जिसने कि ये कहा? बहुत लोगों को कम क्लियर होता है, लोग चूंकि उस लेवल पे जाते नहीं है। कितने लोगों ने कहा कि ये माइक जो है सही में 10 इंच या फिर 5 इंच है और ब्लैक है। और जब स्टैटिकल एनालिसिस की बात करें, कोई भी डाटा इंटरप्रिटेशन या बेटर रिपोर्टेबिलिटी की बात कर रहे हैं कि गुड रिपोर्टिंग हो, तो वो डाटा इंटरप्रिटेशन कैसे करते हैं? डाटा इंटरप्रिटेशन गुड रिपोर्टिंग का एक बेटर पार्ट है। अगर मान लीजिए बोलते हैं ना लोग कि लेवल ऑफ सिग्निफिकेंस, पता है स्टैट्स में पढ़े होंगे, स्टैटिकल भी है, एराइव गाइडलाइन में इसका पार्ट है। लेवल ऑफ सिग्निफिकेंस जैसे बोलते हैं ना 1% है या फिर 5% है, पता है सबको? ये क्या इंडिकेट करता है? 1%, 5% क्या इंडिकेट करता है? पी वैल्यू बोलते हैं ना, पी वैल्यू इज 0.05 और 0.01, 1% एंड क्या कहते हैं 5%। तो क्या होता है मतलब? नहीं क्लियर हुआ मेरे को? मैं क्लियर कर दूंगा, आप जो जानते हो बताओ मेरे को, दम रीजनल लैंग्वेज में जैसे बोलना है, इंग्लिश हिंदी वाट एवर, आई डोंट केयर, लेकिन सबको क्लियर होना चाहिए, क्योंकि ये इतना इंपॉर्टेंट क्वेश्चन है। मैं एक बार गया था वैसे ही, अभी रायपुर से आ रहे थे, एक टॉक था, ऐसे ही पूछ रहे थे कि ये क्या पर्पस क्या है 1% और 5% का। हाँ, उन्हें बाई चांस तो चलो हटाओ, ये ठीक है कि 95 1% आया तो 99%। सबको क्लियर है ना? किसी को और कोई कंफ्यूजन है? बस यही चीज है जो बोल रहा है ना, सेम चीज है। इसको ऐसे क्या समझ सकते हैं कि अगर हम इसको 100 टाइम्स मेजर कर रहे हैं, 100 टाइम्स मेजर कर रहे हैं, तो 95 टाइम्स जो इसके रिजल्ट है वो मोर और लेस वही होंगे जो सबके हैं। इट मीन्स कि देर आर नॉन सिग्निफिकेंट डिफरेंस। नॉन सिग्निफिकेंट सिग्निफिकेंट क्लियर है? हम मान लीजिए ये कह रहा है कि हाँ ये है, इस तरीके से 99 टाइम्स जो है वो बोल रहे हैं क्या कि नहीं ये 8 इंची है, कोई बोल रहा है 7 है, कोई बोल रहा है 7.5 है, ठीक है ना, 7.5। तो ये इसका मतलब है कि 7.5 और 8 देर आर नॉन सिग्निफिकेंट डिफरेंस। स्टैटिकल डिफरेंस थोड़ा अलग होता है। तो वो जब डाटा एनालिसिस करते हैं, चाहे वो एनालिसिस ऑफ वेरिएंस लगाएंगे, चाहे व्हाटएवर जो भी आप टी टेस्ट लगाओ, वहां पे ये कह रहा है कि दिस इज नॉन सिग्निफिकेंट, मतलब कि आपका जो रिजल्ट है उस फाइंडिंग को आप और भी स्टडी उसको सपोर्ट कर रहा है ऑन द बेसिस ऑफ स्टैटिस्टिकल एनालिसिस, ठीक है। तो अगर 90, तो इसमें आप कोई आदमी जैसा लगाना है, कोई 1% लगा रहा है या कोई, इसमें पूछता है जब एनालिसिस करोगे तो आप 1% लगा रहे हो या 5% लगा रहे हो। तो 5% लगा रहे हो तो 95 टाइम्स आपका रिजल्ट, 1% लगा रहे हो तो ये चीज। तो डिस्कशंस जब हम लोग करते हैं तो उसमें यही कहते हैं कि हमारा जो भी पार्ट है आप अपने रिसर्च को किसी और के साथ सपोर्ट। सपोज दैट कि कोई रिसर्च प्रॉब्लम डिसाइड कर लिया, कोई हमारा आ गया रिपोर्टिंग, उस रिपोर्टिंग के बाद हम देख रहे हैं कि हमारे रेफरेंस नहीं मिलते। कुछ ऐसे भी रिसर्च होते हैं जहाँ पे कि अब क्वेश्चन आ सकता है ना कि अगर सर मान लीजिए आप कोई प्रॉब्लम बता रहे हो, इस पर करने जा रहे हैं रिसर्च, जैसे स्पेशल कोई नया ड्रग डिजाइनिंग हो रहा है, कुछ नया डिस्कवरी हो रहा है, तो उस पर रेफरेंसेज ही नहीं है, क्योंकि उसके रेफरेंसेज नहीं मतलब कि पब्लिकेशन नहीं है। पब्लिकेशन नहीं है मतलब गुड रिपोर्टिंग नहीं है, ठीक है ना। तो जब गुड रिपोर्टिंग नहीं है तो वो तो तुमको जब रिसर्च प्रॉब्लम डिसाइड करके जो तुम प्रोटोकॉल अपनाने जा रहे हो उसमें प्रॉब्लम आएगी, क्लियर है ना। तो जब वहां पे प्रॉब्लम आ गई तो तुम कैसे वहां पे रिसर्च परफॉर्म करोगे, क्योंकि एवरीवेज नोज कि हाउ यू कैन चूज दिस टॉपिक एंड व्हाट आर द मेथोडोलॉजी। जैसे अभी लास्ट टाइम में भी एक पेपर भेजा था आईजीपी में, उसमें यही क्वेरी आया था कि भाई आप जो मेथड वैलिडेशन है उसका टोटल मेथोडोलॉजी का वैलिडेशन जरूरी है। आपके उस तरीके के पब्लिकेशंस प्रीवियस है कोई ऐसा रिसर्च जिसमें कि यही मेथड अडॉप्ट किया हो? हाउ यू कैन वैलिडेट दिस मेथोडोलॉजी? खुद से तो नहीं कर लेंगे ना, कहीं से कुछ ना कुछ तो रेफरेंसेस होगा। तो उसको हम मेथोडोलॉजी, इसलिए प्रॉपर मेथोडोलॉजी को अडॉप्ट करते हुए ही हमको रिसर्च प्रॉब्लम डिसाइड करना है। तो उसके बेसिस पे हमारा रिपोर्टिंग कितना इंपॉर्टेंट हो जाता है। और रिपोर्टिंग इंपॉर्टेंट तभी होगा ना, अच्छा होगा, जब हमारा पूरा का पूरा, अभी आगे देखते हैं, स्टडी डिजाइन प्रोटोकॉल एकदम क्लियर डिफाइंड हो विथ वैलिडेशन। So animal research play a critical role in therapeutic drug development, as we all know, because it provides insight that cannot be fully obtained from cell culture or computer model. वही कह रहे हैं कि कोई सेल कल्चर और कंप्यूटर मॉडल दैट इज बायोइन्फॉर्मेटिक और इन सिल्को से हर एक प्रॉब्लम का सोल्यूशन नहीं हो पाएगा, ठीक है ना। सो एनिमल रिसर्च इज गुड केस इन पॉइंट वेयर द पुअर रिपोर्टिंग डाटा फाइंडिंग इम्पैक्ट ऑन डेवलपमेंट ऑफ थेरेपेटिक ट्रायल्स। सेम चीज़ है, ये तो वही है। एनिमल हैंडलिंग एंड वेलफेयर, दैट इज द मेन थिंग। अब सपोज दैट कि हम कोई रिसर्च कर रहे हैं, उसमें एनिमल का हैंडलिंग और उसका वेलफेयर बहुत इंपॉर्टेंट है, अदर वो अराइव गाइडलाइन हो और CPSA गाइडलाइन। सपोज दैट कि एनिमल्स स्ट्रेस में है, कोई हम उसका हेमेटोलॉजिकल पैरामीटर्स ले रहे हैं, वेरी कर जाएगा। स्ट्रेस एक इंपॉर्टेंट फैक्टर है। सपोज दैट हम वहाँ कहीं से एनिमल्स या तो तुम्हारे पास ब्रीडिंग सेंटर है या फिर कहीं से परचेज कर रहे हैं, तो अगर प्रॉपर क्वारंटाइन पीरियड भी फॉलो नहीं करें, इट ऑल्सो अफेक्ट्स योर डाटा, ठीक है ना। इसलिए बोलते हैं कि कभी भी एनिमल्स को ला रहे हैं तो उसके लिए एक क्वारंटाइन फेज, क्वारंटाइन रूम, मतलब उसको स्ट्रेस फ्री रखना है, ठीक है ना। एनिमल हैंडलिंग परफॉर्म बाय वेल ट्रेन स्किल्ड पर्सन आर प्रोफेशनल, जो मतलब जिसके लिए ट्रेनिंग होती है बहुत सारा लेबोरेटरी एनिमल्स पे, जो स्किल्ड पर्सन, उसको पता चलेगा कि एनिमल हैंडलिंग पे वर्कशॉप कराया गया होगा कभी कोई लास्ट टाइम में किया। अब किसी को सपोज दैट कि माइस पकड़ना हो, ठीक है, तो कोई ऐसे पूछ पकड़े हुए, ठीक है, उलट के उसको मतलब ऐसे, आपको पता नहीं है, ब्लड कलेक्शन करना है, मैक्सिमम लोग बोलते हैं हम टेल वेन से ब्लड निकाल लेते हैं। एनीबॉडी हैंडल एक्सपेरिमेंटल एनिमल फॉर ब्लड कलेक्शन पर्पस? है टेल वेन से पॉसिबल है? हाउ मच यू हैव कलेक्टेड फ्रॉम टेल वेन? बस वो पेपर में लिखने के लिए। टेल वेन से आप जब कलेक्ट करोगे ना तो बड़ी स्मॉल क्वांटिटी, बिल्कुल। तो ज़्यादातर केसेस में क्या करते हैं कि हम लोग रेट्रो ऑर्बिटल प्लेक्सस यूज करते हैं, जो ट्यूब होता है कैपिलरी ट्यूब से वही निकालते हैं ना इनर कैंथर से, क्योंकि जैसे ही हम करेंगे तो या तो निडिल चोक हो जाएगा, मतलब प्रैक्टिकल पॉसिबल नहीं है। बीइंग ए वेटनरियन हम बता रहे हैं हमसे पॉसिबल नहीं, निकालने का ऐसा नहीं कि ब्लड नहीं निकलना है, लेकिन अगर आपको क्वांटिटी चाहिए तो वो टेल वेन से नहीं पॉसिबल है, ठीक है ना। बट आप माइनर कुछ 0.1 ml 1 ml तक आप बहुत ज़्यादा निकाल सकते हो, लेकिन अगर मान लीजिए कि मोर देन 1 ml से ज़्यादा चाहिए, है ना, 0.5 से 1 ml तो बहुत हो गया, 0.5 से 1 ml। दूसरा चीज़ क्या है, ये जेंटल रिस्टेनर। जैसे एनिमल हैंडलिंग की बात कर रहे थे, तो जब ब्लड कलेक्शन करेंगे तो हम लोग कैसे उसको कर देते हैं, रिस्टेनर यूज करना है ऑन द बेसिस ऑफ स्पीसीज। मान लीजिए सपोज दैट कि अल्बिनो माइस या वेस्टर रेट कुछ भी यूज कर रहे हैं, तो रिस्टेनर देखे हो सब लोग, होगा ही कहीं पे। तो रिस्टेनर देखेंगे तो क्या होगा, एनिमल को बहुत ज़्यादा स्ट्रेस फील नहीं होगा, वो आराम से वो केज में चला जाएगा, ठीक है, आप उसको लॉक हो गया, वहाँ से आप उसको ब्लड कलेक्शन कर लेंगे। सिलेक्शन ऑफ स्पीसीज, ये बहुत इंपॉर्टेंट है कि भाई आप पूछता है ना क्वेश्चन कि वाई यू हैव टेकन एल्बिनो माइस और विस्टर रैट और गूज और हैम्स्टर और व्हाट एवर, आप यही क्यों ले रहे हैं और कोई नहीं क्यों नहीं ले रहे हैं, है ना जवाब कि भाई आप ज़्यादातर केसेस में लेबोरेटरी एनिमल्स में यही यूज हो रहा है, माइस, रैट्स, ठीक है ना, गूज। लेकिन वहाँ पे क्या है कि ऐसा नहीं है, जैसे अभी बताया ना सर कि रैट एंड माइस में वॉमिशन सेंटर नहीं होता है, तो आपके स्टडी के हिसाब से ही आपको एनिमल सेलेक्ट करना है कि आपका डिजाइनिंग क्या है, आप मेन आपका ऑब्जेक्टिव क्या है रिसर्च फाइंडिंग का। सो एज पर प्रॉपर जस्टिफिकेशन एक्सपेरिमेंटल प्रोटोकॉल फॉल ऑन पर्टिकुलर स्पीसीज। हाउसिंग एंड एनवायरमेंट एज पर CPSA गाइडलाइन और अराइव गाइडलाइन एसो डिक्लेयर कि भाई उसका टेम्परेचर, ह्यूमिडिटी और रूम कंडीशंस मेंटेन होना चाहिए। जैसे सपोज दैट कि मान लीजिए बहुत सारे एनिमल हाउसेस हैं जहाँ पे कि प्रॉपर एयर कंडीशन नहीं है, आप उसको ऐसे ही रखे हो, तो CPSA वाले आते हैं, मॉनिटर करते हैं। अभी तो जैसे चल ही रहा है सब जगह, यहाँ तो बहुत अच्छा एनिमल हाउस डेवलप हो गया है। यहाँ एनिमल हाउस जब डेवलप हुआ था ना आज से पहले, तो मैं ये सब सारा डिजाइनिंग हमारे ही समय का मैंने ही करवाया था, उसमें देसी शर्तें था। क्योंकि आप जब रिसर्च प्रोसेस में बढ़ेंगे ना आगे, तो CPSA अप्रूव ही नहीं करेगी जब तक कि आपके पास प्रॉपर एनिमल हाउस नहीं हो, ठीक है। और अगर एक प्रॉपर एनिमल हाउस रहेगा तो आप कोई भी रिसर्च को प्रॉपर टेक्नीशियन के साथ, तो आपको रिसर्च परफॉर्म करने में ज़्यादा दिक्कत नहीं आएगी। नहीं तो अगर उसको सोच रहे हैं ना, क्रुएल्टी एक्ट यही कहता है, एनिमल उठाए, ब्लड कलेक्शन की, यूथेनाइज कर दिए, फेंक दिए, तुरंत जो है आपका रिसर्च जो है उस डाटा के साथ, अगर CPSA नॉमिनी बहुत इंपॉर्टेंट होता है, अगर आपके रिसर्च पे क्लेम कर देता है तो आपका पूरा रिपोर्टिंग बेकार हो जाता है। जनरली करते नहीं हैं, लाइन अप रहता है कि भाई चलो रिसर्च प्रोटोकॉल में थोड़ा सा स्कार्सिटी और लैकुना की वजह से हम लोग परफॉर्म कर रहे हैं, बट सेटिस्फाइड होना चाहिए कि आपने क्रुएल्टी एक्ट का वायलेशन नहीं किया, ठीक है। यूथेनेसिया का भी प्रोटोकॉल है, रिसर्च करने के बाद एनिमल्स को क्या करेंगे, गाइडलाइन में है, आप उस एनिमल को करोगे क्या, यूथेनाइज कर दोगे, है ना, सब लोग करते हैं ना। मान लीजिए मोर देन 50-60 रैट ले आए, रिसर्च करने के बाद उसको क्या करेंगे? मान लीजिए सपोज दैट कि कहीं यहाँ पे ब्रीडिंग का अप्रूवल है, तो ठीक है, आप उसको या तो रीयूज करेंगे, यूथेनाइज करेंगे, तो कैसे करेंगे? ऐसे कहीं से नहीं करना है आपको। कर सकते हैं, लिखते हैं ना हम लोग कि फॉर अंडर ग्रेजुएट प्रैक्टिकल डिमोस्ट्रेशन के लिए उसको रीयूज कर लिए या फिर व्हाटएवर। तो अगर उस एनिमल्स को आप रीयूज नहीं कर रहे हैं, ऐसे ही वर्क करने के बाद उसको अगर डिस्कार्ड कर दे रहे हैं, यूथेनाइज कर दे रहे हैं, तो ये सब क्रुएल्टी एक्ट है, ये सब CPCA गाइडलाइन देखता है। इसलिए अराइव गाइडलाइन तो एक जनरलाइज थीम है, बट CPSC गाइडलाइन इज ए एक्ट, इसमें यू आर ए अंडर पनिशेबल जोन। पता है ना एक्ट कितना खतरनाक चीज होता है। अभी वो एक्ट में अगर आपको चाहे तो आपके इंस्टीट्यूट का लाइसेंस रद्द कर सकता है फॉर एनिमल एक्सपेरिमेंटेशन। कोई भी एक्ट, जैसे हम लोग चाहे वो हमारे डेवलपमेंट की बात हो या एनिमल की बात हो, एक्ट जब बन जाता है ना तो उस एक्ट के प्रोविजन को मानना। इसलिए CPSCA और अराइव गाइडलाइन ये एकदम क्लियर कर रहे हैं, क्योंकि दोनों में डिफरेंसेस कहाँ कहाँ आ सकते हैं। ठीक है, दूसरा क्या, फंक्शनल एरिया। ठीक है ना, एक और कहता है कि जब कोई भी रिसर्च परफॉर्म कर रहे हो तो पार्टिकुलरली उसका फंक्शनल एरिया होना चाहिए। आप कहाँ पे कर रहे हो? एक छोटा सा रूम है, बहुत जगह पे एनिमल हाउस हैं, वहाँ पे प्रॉपर उसके फंक्शनल एरिया नहीं है, क्वारंटाइन रूम नहीं है, एक्सपेरिमेंटल रूम नहीं है, फीड और पिलेट्स को आप स्टोर कर रहे हो। सपोज दैट कि मान लीजिए हम फीड एंड फॉडर्स को स्टोर कर रहे हैं, मेंटेन नहीं कर रहे हैं, तो वहाँ पे जहाँ मॉइस्चर लेवल बढ़ेगा तो उसमें टॉक्सिन डेवलप होगा। टॉक्सिन डेवलप होगा तो फिर वो अगर मान लीजिए अफ्लाटॉक्सिन वगैरह डेवलप हो गए, ऑन दैट केसेस ये फीडिंग उसको रैट एंड माइट्स को होगा, फिर उसमें हम जो पैरामीटर्स देखना चाह रहे हैं वो उसका नहीं आएगा, उसकी अलग से टॉक्सिसिटी का इफेक्ट आ जाएगा। तो हम बोल देंगे कोई ऑर्गन टॉक्सिसिटी हो गया, स्पेशल टॉक्सिसिटी हो गया, कुछ भी हो सकता है, हेपेटोटॉक्सिसिटी आ जाएगा अफ्लाटॉक्सिन से। तो आपको प्रॉपर ये सारा चीज जो भी है ना उसके हिसाब से करना है, दैट इज कम्स अंडर अराइव गाइडलाइन। स्टोरेज, उसके बाद क्या, वाशिंग एरिया, सब कॉमन चीज़ है, स्टेरिलाइजेशन और यूथेनाइसिया रूम, रिकॉर्ड रूम। क्योंकि आप जो भी रिसर्च फाइंडिंग कर रहे हैं तो प्रॉपर प्रोटोकॉल के तहत करना और रिकॉर्ड मेंटेन करना है, बट टेम्परेचर से लेके एवरीथिंग। हेल्थ मॉनिटरिंग एक बहुत ज़रूरी है। अब जैसे हम लोग एक्सपेरिमेंटल हाउस में क्या करते हैं, एनिमल हाउस में कि रख लिए, लेकिन हम लोग रेगुलर चेकअप वगैरह नहीं करते हैं। कितने लोग जा रहे हैं वहाँ पे कि कभी देखे होगे, यहाँ भी शायद हो सकता है ना हो, ब्लड प्रेशर मॉनिटरिंग का कुछ भी नहीं होगा, उसका BP कितना है, उसका टेम्परेचर है नहीं है। इसलिए रेगुलर सुपरविजन होते रहना है। जैसे हम लोग हॉस्पिटल्स में ह्यूमन के प्रॉपर मॉनिटरिंग होते हैं, तो उस तरीके से वो एनिमल्स की प्रॉपर मॉनिटरिंग होती रहनी चाहिए कि वो एक गुड और हेल्दी कंडीशन में है या नहीं है। क्योंकि अगर वो गुड और हेल्दी कंडीशंस में नहीं होगा तो अल्टीमेटली उसका इम्पैक्ट कितना पड़ेगा, उसका इम्पैक्ट पड़ेगा कि वो उसके जो हीमेटोलॉजिकल पैरामीटर्स हैं, प्रोफाइल है, वो चेंजेज हो जाएंगे। आप जो ड्रग ट्रायल लगा रहे हो उस ट्रायल के हिसाब से भी कुछ चेंजेज होने हैं, तो पूरा का पूरा आपका डाटा ओवरलैप हो जाएगा। और डाटा ओवरलैप होने के बाद जो फाइंडिंग आया आप उसको चाहोगे कि पब्लिकेशन के फॉर्म में दे दें, फिर जो भी कंपनी चाहेगी कि हाँ ये हमने बोल दिया कि इसका ऑर्गन टॉक्सिसिटी है, इस पे दे लीजिए, या फिर ये इम्यूनो इन्हांसर है, व्हाटएवर जो भी है, तो वो जो रेफरेंस है ना उसके लिए एप्लीकेबल। इसलिए कोई एक रिसर्च पे कोई न्यू ड्रग डेवलपमेंट नहीं हो जाता। क्योंकि मान लीजिए एक ह्यूमन एरर है, कभी किसी वजह से हो गया, लेकिन मोर और लेस अगर एक ही ट्रेंड में रिसर्च हो रहा है और एक स्टैटिक फाइंडिंग आ रहा है, उसके बाद भी बहुत सारी अच्छी कंपनी खुद की अपनी R&D सेक्टर रखती है, खुद से ट्रायल करती है, खुद का एनिमल हाउस भी होता है कि आपके, क्योंकि पता है ना कि सिस्टम कैसा चल रहा है, आप जो डाटा दिए हो वो उसके लिए बेनिफिशियल है, हेल्पफुल है, बट वो वैलिडेशन करते हैं। दिस लेक्चर इज ओनली प्रैक्टिकल ओरिएंटेड कि होता क्या है। ठीक है, तो इस चीज को देखना है। दूसरा चीज क्या है कि एनेस्थेसिया एनाल्जेसिया। सपोज दैट कि ब्लड कलेक्शन हम लोग करने जाते हैं, रेस्ट टेनर वगैरह नहीं है किसी के पास, छोटे बहुत सारे जैसे महावीर कैंसर में है या फिर और भी बहुत जगह पे एनिमल हाउस है, इवेंट्स की इथिकल क्लियरेंस ये भी ले रखा है, वुमेंस कॉलेज में भी हम गए थे, तो इस तरीके से बहुत सारे, एन कॉलेज भी ले रखा है, सब मतलब ऐसे लग रहा है ले रखा है। लेकिन आप रिसर्च बोल रहे हो, रियल में क्या गुड रिसर्च हो रहा है क्या? GCMS की बात करता है लोग, बड़े बड़े एकदम रियल टाइम PCR इक्विपमेंट की बात कर रहा है, लेकिन हम तो बोले कि इसका प्रोटोकॉल ही नहीं पता है। हम तो कई यूनिवर्सिटी में जाते रहते हैं ना, देखते हैं कि भाई आप जो रिसर्च कर रहे हो ना उसका फाइंडिंग क्या है, कुछ है नहीं, और डाटा आप बना रहे हैं, डाटा बना रहे हैं और उसको पब्लिकेशन के फॉर्म में भी दे रहे हैं, तो आप एक क्राइम कर रहे हो, इन माय ओपिनियन मिसगाइड कर रहे हो उस फाइंडिंग का, ये डॉक्यूमेंटेशन का रेफरेंसेस जो अदर पर्सन लेंगे। अगर सपोज दैट कि जो क्लियर कट रिव्यू नहीं हो रहा आपके रिपोर्टिंग का, उस केस में इसने कहा सपोज दैट कि इसका रिपोर्टिंग मान लीजिए इसका डाटा कोई 5% आया है मोर्टेलिटी या वाटेवर जो भी है, आप कह रहे हो कि नहीं मोर्टेलिटी है ही नहीं, कोई कह रहा है कि नहीं 90% है, तो इतना इन वेरिएशन। या फिर क्या करोगे, आप अपनी डिग्री लेने के लिए बोलोगे नहीं इसने 5% का है, मैं भी 4.5% कर देता हूँ, 4.5 कर देता हूँ, कोई मैं भी 6 कर देता हूँ, मतलब मोर और लेस जो है ना। ज़्यादातर केसेस में क्या आते हैं कि जो उसके पब्लिकेशन डॉक्यूमेंटेशन होते हैं उसी के इर्द गिर्द आप अपने ही डाटा को रखने लगोगे। रीज़न क्या हो सकता है कि आप रिसर्च प्रोटोकॉल ज़्यादा अच्छे से किए हों, लेकिन अल्टीमेटली जो बहुत प्रॉपर अगर अराइव गाइडलाइन को फॉलो नहीं किया, सीपीएसए गाइडलाइन को फॉलो नहीं किया, तो उस कंडीशन में उसके पैरामीटर्स वेरी करेंगे। जब पैरामीटर्स वेरी करेंगे तो आप सोच रहे हो कि मतलब खुद में कॉन्फिडेंस नहीं है कि हम जो बोल रहे हैं या फिर जो भी रिसर्च फाइंडिंग हमारा है सही है या गलत है। नहीं नहीं, उनका तो उतना ही आया था 5%, तो हम भी थोड़ा सा 4.5 ही रखते हैं ताकि रेफरेंस के लिए सही रहेगा। यही हो रहा है आज के डेट में रिसर्च। इसलिए ये सब अराइव गाइडलाइन और सीपीएसए गाइडलाइन जो है डिक्लेयर करता है कि आप कोई भी रिसर्च फाइंडिंग करो प्रॉपर प्रॉब्लम के साथ, प्रॉपर डॉक्यूमेंटेशन के साथ, प्रॉपर सैंपल साइज के साथ, प्रॉपर सैम्पलिंग स्टडी ऑफ डिजाइन के बेसिस पे, ठीक है। अब मान लीजिए एनेस्थेसिया वगैरह यूज करना रहता है कभी किसी को, तो स्टेनर वगैरह नहीं है तो कैसे यूज करते हो? कोई बोलता है कि हम लोग उसको इंजेक्टेबल, कभी कोई किया हो? सब जगह पे है ये स्टेनर वगैरह, कैसे ब्लड कलेक्शन करेंगे? कोई किए ब्लड कलेक्शन? तो कैसे करते हैं वो कि एकदम लाइव रेट रहता है, मूव करते रहता है, पॉसिबल है? कर लेते हो ऐसे पकड़ करके? हमें बताओ, मैं तो जानना चाहता हूँ। रिस्टेनर में डाल के करते हैं, रिस्टेनर मान लीजिए रिस्टेनर नहीं है, एनेस्थेसिया देके, गुड, कहाँ कौन बोला? अच्छा, कौन सा एनेस्थेसिया देते हैं और उसको कैसे देते हैं? अगर आइदर इंजेक्टेबल और इनहेलेशन, हाँ इंट्रापेरिटोनियल देते हैं, तो एनेस्थेसिया क्या पैरामीटर्स को वेरी करेगा? तो अल्टीमेटली जो रिपोर्टिंग हुआ आपका कैसा हुआ, वेरी करेगा। तो एक जो साइंटिफिक वैलिडेशन होना चाहिए वो नहीं हो पाएगा। नो डाउट है आप जो कर रहे हो करते हैं, ऐसा नहीं, आईपी देते हैं, सारा चीज़ करते हैं, आईपी ही आपको केटामिन दे चाहे जो भी है, फेनोजुलाम दे, ठीक है, या फिर बहुत जगह पे आपका जो डिगैसर वगैरह आता है तो उसको आप इनहेलेशन भी दे करके, ठीक है ना। जैसे अभी आयुर्वेदिक कॉलेज में गए थे तो वहाँ डिगैसर रखा था, उसमें डाला आदमी इथर, और थोड़ा देर के लिए जैसे ही उसको स्टेज 1 थोड़ा सा हिप्नोटाइज हो रहा है, सेडेटिव फॉर्म में आया, तो उसको मतलब वो पूरी तरीके से वो गया नहीं है, अब उसको हल्का सा भी सेडेशन फील हो रहा है, बस उसको उतना देर में ब्लड पिक करके निकालेगा। बट ये सब क्वेश्चन है कि वेरिएशंस तो आपके आ रहे हैं, ठीक है ना, लेकिन अब डिपेंड करता है कि सर ये वेरिएशन है तो फिर रिसर्च का कोई मतलब रहा? नहीं, मतलब रहा, क्यों रहा कि आपका वेरिएशन अप टू द मार्क है या नहीं है। जैसे बोले ना 99% और 95% की बात कर रहे हैं, 100% तो नहीं बोल रहे। तो आपका जो प्रॉब्लम है और आपका ऑब्जेक्टिव है वो क्या है, वेदर you have to perform a CNS activity or not, particularly कोई ऑब्जेक्टिव ले रहे हैं, कोई ड्रग का हम चाह रहे हैं कि इफेक्ट देखना CNS पे, तो वो तो वहाँ से नहीं ले रहे हैं ना, ठीक है, तो वो चीज़ के बेसिस पे वो चलता है, दैट इज द मेन पैटर्न। सो एक्सपेरिमेंटल डिजाइन वही है कि आपका एक्सपेरिमेंटल डिजाइन प्रॉपर होना चाहिए, स्टडी डिजाइन। हाँ करते हैं, क्यों? हाँ क्यों करते हैं कि आपको करना नहीं है, मैं बता रहा हूँ। आपने पूछा करते हैं तो मैं बताया करते हैं, करना जनरली ही करते हैं, नहीं करना चाहिए। अगर वेल एस्टेब्लिश आपका रिसर्च प्रोटोकॉल है तो आपको नहीं करना है। आप वेल स्किल्ड पर्सन, वेल प्रोफेशनल, आप स्टेनर से आप उसको लॉक कर करके आप उससे ब्लड कलेक्शन जो प्रोफेशनल होते हैं वो निकाले तो बेटर है। बहुत ऐसे रहते हैं जो कि उसको हार्ट पंचर से भी निकाल लेगा ब्लड, प्रोफेशनल्स हैं, वो डे टू डे वो हैंडल कर रहे हैं एनिमल, लेकिन वो नहीं करना है, एज प्रोटोकॉल वो नहीं करना है। लेकिन हम लोग जनरली इसलिए बोलते हैं कि करते हैं, करना नहीं चाहिए। देखो स्टेटमेंट को समझो, करना नहीं है, लेकिन जनरली करते क्यों है कि अगर हमको ब्लड कलेक्शन करना है तो भाई अगर रैट को देखो ना, कभी मान लीजिए 150 या फिर 200 250 का भी स्टार रैट है, तो आप उसको नॉर्मली ऐसे पकड़ोगे ना, वो तुरंत बाइट कर लेगा कहीं ना कहीं, ठीक है। और आप प्रॉपर स्टेप मान लीजिए नहीं है उस तरीके से सिस्टम में बना हुआ स्टेनर, सबके पास स्टेनर नहीं होगा, मान लीजिए रहा तो रेस्टेनर नहीं है तो वो रेस्टेन कैसे होगा, ठीक है। नॉर्मली अगर हम उसको एक सपोज दैट कि किसी भी कपड़े से या फिर जैसे बोले ना अभी कि सेडेशंस में डिगैसर में उसको थोड़ा सा इनहेल करा दिया एनेस्थेसिया, इथर वगैरह कुछ भी डाल करके या क्लोरोफॉर्म, और उसके बाद से वो जैसे ही एक स्टेज हम तो चूंकि ग्लास का देखे हो डिगैसर, एक ग्लास का एक जार होता है उसमें हल्का सा डाल दें उसको और उस पर जैसे ऑटोमेटिकली उसका मूवमेंट हम बाज कर रहे हैं, देख रहे हैं कि वो हल्का सा भी उसमें सेडेशन फील हो रहा है, उस पिक में आप उसको निकाल करके आप उसको कर सकते हो, ठीक है ना। लेकिन ये इथिकली ये सही नहीं है। इथिकली वही है कि आप रीस्टेनर यूज करो, हेल्दी रेट से निकालिए, ठीक है। और फिर यही स्टडीज यानी में आप जो भी प्रोटोकॉल बना रहे हो वो कंट्रोल रख रहे हो। अब जैसे कंट्रोल बहुत लोग रखते हैं क्या ना कि जब हमारा रिसर्च प्रोटोकॉल कर रहे हैं तो उसमें पॉजिटिव और नेगेटिव ये दोनों कंट्रोल रखना पड़ेगा। मान लीजिए 2-3 ग्रुप बना रहे हैं, सपोज दैट कि कोई मेथनॉलिक एक्सट्रैक्ट देख रहे हो चाहे कुछ भी देख रहे हो, तो आप डिफरेंट कंसंट्रेशन का को यूज कर रहा है या फिर डिफरेंट ग्रुप का यूज कर रहा है, तो आपको कंट्रोल रखना पड़ेगा। अब कंट्रोल में 2 तरीके का, एक तो होता है कि हम नॉर्मल हेल्दी कोई कभी कभी कंट्रोल बना के रख लेता है, लेकिन नहीं, जैसे मान लीजिए सपोज दैट कि इम्यूनो मॉलिक्यूलर स्टडी कर रहे हैं, इम्यूनोलॉजिकल स्टडी कर रहे हैं, इम्यूनो इन्हांसर या इम्यूनो मॉड्यूलेटर स्टडी कर रहे हैं, तो वहाँ पे हमको पॉजिटिव कंट्रोल ऑलवेज रखना है कि एक नॉर्मल हेल्दी है सपोज दैट रैट, हम उसका कंपेयर कर रहे हैं किसी एक्सट्रैक्ट का इम्यूनोलॉजी के साथ में, तो वहाँ पे हो सकता है कि वो नॉर्मली हेल्दी हो तो उसका खुद का भी तो इम्यून सिस्टम डे बाय डे ठीक है, लेकिन आप अगर मान लीजिए वहाँ पे सपोज दैट कि लेवामिजोल वगैरह यूज करो एज ए इम्यूनोमॉड्यूलेटर और उससे कंपेयर करोगे तो फिर पॉजिटिव कंट्रोल और नेगेटिव कंट्रोल के साथ ये करेंगे ना तो आपके डाटा, मतलब ये कहता है गाइडलाइन अराइव कि आपका जो स्टडी डिजाइन है ना वो पूरा वेल डिफाइन होना चाहिए, ठीक है, विथ वैलिडेशन के साथ में, और उसके बाद जो डॉक्यूमेंटेशन होगा ना तभी बोलते हैं कि क्वालिटी ऑफ रिसर्च जो है ना क्वालिटी ऑफ जर्नल में पब्लिश होता है। सैंपल साइज आप कितना सैंपल रख रहे हो उसके हिसाब से डिपेंड करता है, और इथिकल क्लियरेंस, इथिकल क्लियरेंस तो जब एनिमल एक्सपेरिमेंट बात करेंगे तो एकदम मस्ट है, क्योंकि अभी तो आपके इथिकल क्लियरेंस के कहीं लिख दिए कि IACA नंबर से हमारे, IACA कुछ नहीं है। देखो IACA बोलते ना इंस्टीट्यूशनल एनिमल इथिकल कमेटी, बेसिकली इट इज ए पार्ट ऑफ CPSC। हमारा जो CPSC क्या है वही प्रिवेंशन क्रुएल्टी एक्ट जो बता रहे हैं ऐसे जोड़ो, वो उस एक्ट का ही पार्ट है ये। चूंकि जैसे स्टेट लेवल पे कोई भी इंस्टीट्यूट लेवल पे कमिटी बना करके आपको एनिमल एक्सपेरिमेंटल फैसिलिटी के लिए कराना, लेकिन IACA में तो ऑटोमेटिकली CPSC के मेंबर आते हैं, वो जब तक एथिकली अप्रूव नहीं करेंगे तब तक आपका रिसर्च कहीं पर भी क्वालिटी ऑफ जर्नल में पब्लिश नहीं होंगे। रिसर्च आप कर लो, बहुत सारे जर्नल्स तो अभी कॉमन आ गए, लेकिन अगर आप चाह रहे हो कि बहुत अच्छे नेचर में पब्लिश करें चाहे कहीं और पे करें तो पॉसिबल नहीं है। So thank you. Any query? So if I have no any questions, so thank you. Nikal. Yeah.
It's related to sir topic. So first of all, I congratulate sir for nice presentation discussing all the challenges and how it can be handled, okay, practically. But I have few doubts regarding the few procedures with the animals. Suppose for MDA students, 5 things at least must be known for them. One is for demonstration of marginal withdrawal of blood from marginal ear vein, rat tail vein, subcutaneous injection, intraperitoneal injection, intragastric feeding. 5 things must be there. So for drawing the blood of rat tail vein or marginal ear vein, do we need anesthetize mice or rat, or we can simply handle beautifully with nape of the neck and we can take the blood? No need of a re-strainer. Okay?
No, from tail vein, you no need of re-strainer. I think beneficial for
okay
from tail vein, but no anesthesia should be used when you
anesthesia
collect it
should
from
not-
tail vein or ear vein. But when you will use you collect from retroorbital plexus, it might be.
Okay. So I saw very beautifully these 5 procedures are done by MD students during my recent visit to MD examination at Orissa. Okay, so no need of anesthesia. Very beautifully they hold, they draw the blood, demonstrated. So you should also know. Yesterday I hope this was the session for these all 5 things. So you should confident about this. And next thing I wanted to share that I have a proposal. Nisi is there or not? Nisi? Okay. My PG student doing DM here. So where she is? Okay. So what was the proposal? Just I wanted to share. Sir, just I share my PG. You can also share that the proposal was, just I wanted to share, the title is a cross-sectional descriptive study to critically appraise animal research published in a Medline Index journal using reporting in vivo experiments arrive guidelines. What I wanted to know that how many articles are published on the animal study, and I wanted to assess that how many of them are adhering the arrive guidelines. This was my concept. Okay, what will happen when I did the literature research? I did not find any appropriate number of articles so that I can complete this project. So this project is still not completed. Why? Because the data is not available. Okay. So I have a concept in my mind. I just wanted to see how many of animal research adhering these arrive guideline, and I did not find too much adequate number of. सब में कुछ ना कुछ problem था, so that I can't be able to report these. Still few authors have been reported, but don't know how. Still I am struggling. I given this assignment to my 2 PG. They passed out. Still I shared Dr. Saurik. You can share to your group. I think you must have a group of these participants. So you share, and also we have a arrive guideline. You share a PDF is there for 2 page. You just see how many points are there. There are 10 main headings, and you have to adhere. Everyone who do this preclinical study, animal study, may adhere with all the guidelines. So for you reporting, whether they are adhering or not, you have data. So it was not there. So this is the challenge. So we do the quality work, okay? Not only the for just time being, we do quality work. So again, thank you, sir, for excellent presentation and emphasizing all the things which is important for this animal research. Thank you so much.
Okay, thank you so much.
Thank you, sir. That was great listening to you. Now, I would like to request Dr. Pramod Kumar Majhi, sir, to come forward and felicitate Dr. Ramesh Kumar Nirala, sir. Let's continue the remaining sessions forward. We are so pleased to have Mrs. Kunjan Arora, Director, Infocart India Private Limited, New Delhi, to share her informative insights on MyCal Pharma software.
Morning, everyone. I hope I'm audible to everyone and also visible to everyone. So thank you so much, IGIMS Patna, Lalit sir, Manish sir, to give me a chance to demonstrate our software. This is MyCal Pharm animal simulated software in pharmacology. We are already in tie-up with IGIMS Patna. All the students are using this particular software. This is a combination of pharmacy or say pharmacology with the technology part. What all the animal experiments you are performing on the live animals right now, torturing them or taking out blood from them or giving them shocks or having so many experiments. All these experiments we have done virtually now. So you do not have to play with the lives of the animals just to do the experiments, especially for the education part. Research, everything is fine, which is we have to do. But when we are coming to the education part, examination part, how these experiments will be performed, what all the students will be learning out of it, LD50, everything these can be done in our software. Be it dose response curve, be it bioassays, be it PA2, PD2, live animal experiments, and many other like collection of samples are there. Then we have workshops are there. All these we have included in our software. Give me some time. I'm just sharing my screen. Just let me know if my screen is visible to everyone, so I can just start with the demonstration of my CalPharm. Okay, I think my screen is visible and getting here structure, so I'm just starting with the demonstration now. Not taking much of your time, just to show what exactly we are doing. We have two veterans of our industry, which cannot be escaped. Everyone knows about them. Dr. Ravindran from JIPMAT, his achievement in the medical line, in the pharmacy line, cannot be ignored. Everyone knows him. Then we have Patil sir, Dr. C.R. Patil from Shirpur, Maharashtra. Before this particular experiment was conducted, Michael Farm, before we had CDs which Ravindran sir distributed in some conference to all the students. Even today, those particular CDs are being used by many colleges. So that those data in these CDs are into the virtual experiments now, and the very much updated version is there. But it is the same experiments which we have there. Same experiments are still here. So one more thing which I just want you to know, that out of 21 AIMS which we have in India, 14 AIMS have already procured MyCalPharm. They are already working on it. And to add feather in our cap, we have AIMS Delhi now with us. Even they are working on MyCalPharm. They have procured it. So now out of 21, 14 aims are there with us. We are also trying rest remaining aims to come. So if aims Delhi or other aims have purchased, I think you can see what is actually the strength of my child farm is, or what is actually the quality which we are giving. These are the few images of our portal. Will not show you all the experiments now, just overview of it. That's it. So after this, I'm just going into the login part so that you can just see what exactly we are doing here. Login is there by simple email ID and password. So this will be the dashboard. What all experiments are there, how many experiments have been performed, how many, which students are doing, what experiments are being done in a week, in a month, what all the best of the 6 experiments are there. Going to the experiment part, these are the list of the experiments which we have. Rabbit eye is there, bioassay of histamine, effect of drug on the ciliary muscles of the frog, esophagus, effect of drug on BP and HR, bioassay of histamine, or kuch basic experiments like route of drug administration, then collection of biological sample. Just before mine, the sir was explaining where exactly the collection of the sample will be taken. So this is the complete experiment of the things, how we can just take the blood sample. Like here we can see how the rats are there. अभी सर ने बताया अगर हम उसमें से टेल से निकालेंगे तो बहुत थोड़ा सा ही निकलेगा. But here we are just showing you what exactly will happen here. The actual videos, since it is a medical college, so you people are doing the animals, you are already performing the experiments on animals, but still just to show you how things are being done. Next experiment, next one. This is again second part. कैसे हम इसको blood samples we can just take it, see. You can see the actual videos which we have here. This is again a vein from which we are taking jugular veins. Sorry. Next experiment, next one. This is a marginal ear vein. Another, this is the cardiac puncture if you did it. Going back now, not taking much of your time, going to the dashboard again. We can see the list here, which all experiments are there with us, just showing you what all the list are there, dose response, dose calculation is there in the experimental pharmacology. आज सुबह जितने भी experiment perform हुए for the cal lab, आगे जो होंगे, all the experiments आप यहाँ पे perform कर सकते हैं. Study of drug induced catatonia, stereotype, commonly used instruments are there. हमारे pharmacology में, pharmacy में जो हमारे इंस्ट्रूमेंट्स लगते हैं ऑल दिस आर देयर प्लस इसकी इंफॉर्मेशन रोटारोट एपरेटर्स एक्ट ऑफ फोटोमीटर एडीज हॉट प्लेट एलिवेटेड प्लस में इलेक्ट्रोकन्वर्जोमीटर प्लस दिस इज दिस सेटअप लाइक फ्रॉग डायरेक्टस एब्डोमिनस मसल्स फिर उसके आगे के एपरेटर्स व्हाट ऑल वी हैव all the information is there.
2. Simple sideway writing lever.
Voice is there.
For recording isotonic
You
contractions
can just
of the
see,
isolated
listen.
tissues. The wrist 3. Starling's heart lever and protein universal lever 4. Gimbal lever. The friction between contractions. Isotonic contractions.
Not listening to everything
Contractions.
going on fast.
Isometric contractions. In this type, there is change in the force of contraction rather than change in the length when the tissue contracts. Cook's ball apparatus. Cook's ball
Cook's ball
apparatus is
apparatus.
used to condition the rats to auditory and visual stimuli to escape from the noxious food shocks. This apparatus
Guinea
has a
pig
floor grid
setup.
guinea pig ideal setup. The transducer is connected to an interface which helps in reduction of noise in the signal sent from the student physiograph and digital data acquisition system. These data acquisition systems in association with
I'm muting it. Very. Either you can see you can hear my voice or his voice. So taking to the next one. This is the organ bath. Few information for the organ bath. Their outer jacket, organ tube, glass coil, everything is there. This is the reservoir. These are all the definitions are there. So this is one thing. These are all the commonly used apparatus. Not seeing everything, information for all the apparatus was there. Then here we have your experiment on the isolated tissues, like we have dose response curve. So these are the 5 experiments on the dose response curve. Then we have the PA2 experiments. Here again we have a list of 5 experiments. Serotonin, ACH, chill plot method, atropine, prazosin, all these are being boosted. इसके बाद आई एम जस्ट शोइंग यू दी बायोएसेस. सो ये हमारे 5 एक्सपेरिमेंट्स हैं बायोएसेस के. सेरोटोनिन, ऑक्सीटोसिन, एड्रेनालिन, एट्रोपिन, ACH. Must cell stabilization assay, right helium 4 point assays. Then we have the experiment on the whole animals. So ये हमारे whole animals के हैं जिसमें हम लोग यूज कर रहे हैं एटोफोटोमीटर, एलिवेटेड प्लस्मेस, इलेक्ट्रोकन्वल्जोमीटर, CNS पेप्रिसेंट रोटर रॉड, एडीज हॉट प्लेट यूज करके एक्सपेरिमेंट है. देन वी हैव द पायरोजन टेस्टिंग. Then we have shy method pyrolysis ligation is there. Good. Then LD50 skin irritation, frog intestine, saline purgator. Every now and then we keep on adding the number of the drugs. We keep on adding the number of the experiments. अभी हमारे पास 45 experiments हैं. We keep on adding them. In case another you think that something is missing from the some experiment is not there or some drug is not there or it should happen the other way around. कुछ भी calculation में इसको ऐसे नहीं ऐसे करते. So this is the suggestion and the feedback form. You can just go here, write whatever you feel like. This is for every student also. Write their name, write their number, write the information or the feedback, whatever you are saying. And after writing this, just submit it. We will make sure that your suggestion, your feedback is incorporated into it. Faculty accounts, we are always, how many number of the faculties you have, we can make your accounts. All the faculty accounts can be made. Student account, unlimited usage of all the experiment, unlimited number of the students can access to it. जितने भी आपके MBBS के स्टूडेंट्स हैं, MBBS, Pharmacology, anywhere you can just use it. They are not restricting to anything now. Exam mode is there. You can just schedule exam is there. First is the practice exam. All the practice exam are open. Any student can log in. They can just use the practice exam. आप उसको रन करके देख सकते हैं कैसा होता है, क्या होता है उसमें प्रैक्टिस एग्जाम में. जैसे अगर हम लोग रैपिड टाइप करते हैं तो उसके एग्जाम में क्या होगा, एवरीवन कैन सी हियर. अननोन है तो अननोन कैसे हैं, अननोन को हम लोग कैसे आइडेंटिफाई करेंगे, ऑल दिस थिंग्स कैन बी शोन. एक ही एक्सपेरिमेंट है लाइक इफेक्ट ऑफ ड्रग ऑन डॉग PPHR. Not showing you the complete experiment, just showing you like the equipment which we have. This is the procedure. Going to the procedure now. This is the supine position जिसमें हमने experiment perform करा है. This is the setup. Experiment कैसे हुआ था. These are the actual images of the dog. Now this particular experiment, dog BPHR, is completely banned in India. So we did this experiment. We took the actual pictures of this particular experiment when it was performed. Tips are there. आपको समझने के लिए easy रहेगा कि क्या है, कैसे उसको एड्रेनालिन देना है, क्या करना है, उसका BP और HR पे क्या इंटरैक्शन रहेगा, agonist, antagonist, everything is there. These are the actual images. You can see the clarity. If we are going to the experiment part, मैं आपको एक बार दिखा देती हूँ इसमें list of drugs क्या हैं. Like we have the carotid occlusion, central vagus, peripheral vagus, epinephrine, norepinephrine, isoprenaline. Plus इसमें agonist और antagonist like we have propanol, atropine. So all these things are there. You can see ephedrine, phentolamine, myrapine. Let me add one. Isoprenaline injecting. This is the dose to be injected. I'm taking it as 3. Dose को बढ़ा भी सकते हैं, कम भी कर सकते हैं। रिकमेंडेड डोज यहाँ पे लिखी आएगी आपके पास। दिस इज एक्चुअली अ कॉम्प्लेक्स experiment. It's not that easy. So here we have given you all the basic information. If you will go to this question mark, yellow color question mark, all the information whatever it is, कि हम अगर आइसोप्रिनालाइन देंगे तब इसका बीपीएचआर क्या होगा, और अगर एंटागोनिस्ट के साथ देंगे तब क्या होगा। सो अभी आइसोप्रिनालाइन के बाद द बेसल बीपीएनएचआर वाज, heart rate was one was 150, mean VP was 120, let's say. अब isoprenaline के बाद we have seen the VP will come seriously down at 50, and here we can see the heart rate has shoot up, and slowly and normally it will just come back to the normal. Let me add one, let's say propranolol antagonist, as we all know. इंजेक्टिंग इसकी डोज हमने यहाँ पे रखी है 1000 mg, 1000 mg/mg, इंजेक्टिंग दैट। प्रोपेनोल इंजेक्ट करने की भी एक लिमिट है, सबकी एक लिमिट होती है ड्रग की। तो जैसे हम इसकी भी एक लिमिट है। अगर मैंने अभी 1000 इंजेक्ट करा तो वी कैन सी बीपी एंड एचआर बोथ हैज fallen down severely. HR has come down to 110. BP has come down to 70 of 1000. Adding it again, एक बार और डाल देते हैं 1000 propranolol. Severely gone down again. BP and HR both. इसके बाद तो the dog will die. Gone down to BP, gone down to 50, HR gone down to 100. इसीलिए बैन है ये एक्सपेरिमेंट. You can't do all these things to a dog. So let me add isoprenaline just to show you the effect of antagonist on agonist. Injecting the same dose 3 mg/mg. As we all know, इसका जो इफेक्ट रहता है आफ्टर प्रोपेनोल, आइसोप्रिनालाइन का इफेक्ट इज कैंसल्ड. HR and BP both will be normal there. No effect of isoprenaline on propranolol. तो इसका थोड़ा सा डिटेल मैं आपको यहाँ पे दे देती हूँ. दिस इज इन डिटेल BP और HR का कौन से ड्रग पे क्या रहेगा. एक रिमूव, अगर हमने कोई रिमूव करना है, जैसे मैंने अभी 1000 डाला था, प्रोपेनोल वाज 2000. So after some time the ratio of the propranolol in the dog's body will decrease. So right now it is 1941, और थोड़े टाइम बाद हम अगर देखेंगे it comes out to be 1903. After some time it will be 1800 something. So after every some time, after every 2 minutes or so, some percentage of drug decreases. That means the effect of propranolol will keep on decreasing. अभी कितना डिक्रीज होता है, ये ड्रग का इफेक्ट क्या रहता है, दिस इज रिटन हियर. वी हैव गिवन यू अ डॉक्यूमेंट जस्ट फॉर योर इजीनेस, ताकि आपको पता लगे कि क्या करना है. प्रैक्टिकली इज फाइन, बट हियर यू शुड नो कि विंटोलामाइन प्रोपेनोल ऐड करेंगे तो बीपी और एचआर पे क्या डिफरेंस रहेगा ऑन एवरी ड्रग. लाइक हियर यू हैव टेकन सेंट्रल वेगस, तो इस पे एट्रोपिन, विंटोलामाइन और प्रोपेनोल का इफेक्ट. Similarly, we have taken peripheral vagus, epinephrine. So all these documentation is there where you can see the effect of antagonist on agonist. Complete details. Just for students, उनके लिए help है. नहीं तो ये practical तो it is already there. एक और अगर प्रोपेनोल डाला तो डॉग विल डाई. राइट नाउ द अमाउंट इज 1865. Now I'm just going to the observation part, taking it very fast. जो भी हम लोग यहाँ पे डालेंगे, let's say we've added isoprenoline, इसका mean BP HR और इसका mean BP HR, we will be just writing it here. Right now I'm just taking a random value. The marks जो भी student ने लिखने हैं, they will be writing it here. Propanol, again isoprenoline. जो भी उनकी sequence रहेगी, so the faculty will come to know exactly what they have done. Just taking it normal now, not exact values, but tell students to enter their the exact values. वो इधर से देख के यहाँ पे उसको लिखेंगे. Then for every experiment, a set of basic MCQs and a written set of questions are there. 10 to 15 MCQs are there. जब स्टूडेंट्स यहाँ तक आए हैं कि वो अपना परफॉर्म करेंगे, अपना एक्सपेरिमेंट परफॉर्म कर रहे हैं, दैट मीन्स ऑल दीज क्वेश्चंस, द ब्लड प्रेशर इज मेजर्ड, इज, ये तो बहुत बेसिक है. आई मीन दीज थिंग्स द स्टूडेंट शुड नो राइट नाउ, नॉट टेकिंग मच टाइम, आई एम जस्ट मेकिंग इट एज ए. अगर स्टूडेंट यहाँ तक पहुंचे हैं एक्सपेरिमेंट परफॉर्म करने के लिए, तो दे हैव टू नो दीज वेरी सिंपल क्वेश्चंस. Anesthetic agent uses, parameters measured is, so all these things questions student has to know. Which point is measured, so whatever is the correct answers, the software will be giving that also. तो स्टूडेंट्स ने लिखा वो भी शो होगा, और जो इसका करेक्ट आंसर है वो भी रहेगा. Then we have a set of written answers in question. For every experiment, we are giving you a set of 10 to 15 written set of questions जो student इसमें लिखेंगे. Why does BP increases when the carotid arteries there? Then जो भी हम यहाँ पे लिखेंगे, the student has to just submit it. And the report is there. For every experiment, a separate PDF report will be generated. Here we can see a separate report is there for every questions. For every experiment, we can see the report here. जो भी हमने वहां पे परफॉर्म करा विद स्टूडेंट नेम, एक्सपेरिमेंट नेम, ये सारी चीजें उसमें जाएंगी. जो भी आपने ग्राफ बनाया स्टूडेंट ने, ये सब जाएगा. प्लस उनका जो लॉग है, एक्चुअली स्टूडेंट ने क्या परफॉर्म करा, कौन से टाइम पे, तो फैकल्टी को ये सब पता रहेगा. MCQs, रिटन आंसर्स सब रहेगा. In this short time, I cannot explain you all the experiments, which is simply not possible. ये मैं आपको एक बार दिखा रही थी कुक्स पोल, जस्ट टू शो यू ये कैसे रहेगा. आप एक्सपेरिमेंट, everyone here who all are the participants of this particular conference, आपको login ID इसका मिला है complimentary for 1 month. You can perform any experiment here. All the experiments are open to you. We have made you as a faculty, so you are having everything, all the access to all the experiment, access to exam mode, experiment, everything is open to you. Here we can see the effect here, the light is open. अभी अगर हम लोग इसमें buzzer on करते हैं, sound you can see, sound is there. Effect of light, effect of buzzer, we can see, we have to note it down. Stop. This is the effect of antipsychotic cell. This is the effect we can see here. This is another the effect of the minor tranquilizer, let's say sedatives also. We can see the effect, क्या effect रहता है rats पे. स्टूडेंट हैज टू नोट द इफेक्ट, टाइम उनका नोट करेंगे कि ड्रग्स के बाद क्या इफेक्ट है और नॉर्मल क्या इफेक्ट है, बजर पे क्या इफेक्ट रहेगा उन पे। दिस इज शॉक पार्ट। For every experiment, names of the scientists is there, उनकी क्या क्या कंट्रीब्यूशन है वो आपको मिलेगा। Is it there now, please, ma'am? साइंटिस्ट का आपको डिटेल मिलेगा, फ्यू इंपॉर्टेंट टर्म्स का आपको डिटेल मिलेगा in this experiment. So everything is there. You can just see what exactly we are just giving you. This is the skin part. Skin experiment is there. I'm not performing the experiment right now. Just showing you this setup. कि इसको कैसा हमने बनाया है या कैसा ये एक्सपेरिमेंट परफॉर्म करेंगे तो क्या होगा। मैं आपको इसकी डायरेक्ट रिपोर्ट शो कर रही हूँ, व्हाट exactly the report will be like. So here I am not showing you the experiment now. I mean, it is a very large experiment, not possible for me to show you every experiment. So we are always here. कोई भी आपको प्रॉब्लम है, कुछ भी है, एनी एक्सपेरिमेंट यू आर फेसिंग एनी काइंड ऑफ कंफ्यूजन, आप यहाँ पे इसको लिख दीजिए सजेशन में। वी विल बी देयर टू assist you. Personally, you will be getting a call from our customer team. We are available 24/7, WhatsApp, phone, email. So we are always there. आप कभी भी हमें कॉल कर सकते हैं. Our numbers are there. So thank you so much. I think बहुत लंबा हो गया है ये. And a very happy Diwali to everyone. Thank you so much IGIMS Patna for giving me this opportunity कि मैं आपको थोड़ा explain कर पाऊँ कि हमने इसमें क्या करा है, how tech is being combined with the pharmacy thing, with the pharmacology, with the help of our two main veterans, our authors. So any confusion is there, anything is there, any questions anybody wants to ask, we're please open to ask.
Thank you, ma'am, for sharing your valuable inputs. So now we will facilitate her online since it was an online session. Moving forward towards other sessions of our workshop, we will have a short tea break of half an hour ahead, and it will be followed by the demonstration of stations divided into 4 groups as it was done yesterday. And then we will have our lunch, which will be followed by valedictory function and certificate distribution. I hope you are enjoying the session with immense zeal and enthusiasm. Thank you so much.
Recording stopped.
So they will be, so kindly inform everybody out there. Thank you so much.
हेलो चेक चेक हेलो चेक उठ रहा है हेलो चेक हेलो
Recording in progress.
Group D. So, very good afternoon. Myself, Dr. Keshav. I am Senior Resident Academic, DM Clinical Pharmacology, second year. So, I will be discussing about the demonstration of oxalate extraction and other related apparatus. Before going to demonstration, these are the apparatus. I will give the brief introduction of the extraction process. Pointer. So, I will discuss in the following headings: important terminology, selection of plant materials, solvents of extraction, extraction methods including success extraction, concentration of extracts and its preservation, fractionation and purification, and then identification and characterization of phytoconstituents. So, coming to the terminology, so what are the primary plant constituents? These are the mainly nutritional components of plants such as common sugar, amino acids, proteins and chlorophylls. These have no medicinal properties, so these are not of our interest for purpose of drug development. While the secondary plant constituents are of our interest, these consist of alkaloids, terpenoids, saponins, phenolic compounds, flavonoids and tannins. So these are the compounds which we are interested in, and these are responsible for biological and pharmacological electrons. So basically we are concerned with the secondary plant constituent, not the primary one. Now coming to selection of plant material, so what are the basis of selection? How will decide I will decide which material I have to select? So these give the clue. Very first is the traditional claims. So idea comes from the tradition. This particular plant material or this particular plant is having some medicinal property. For example, say leaf or root or stem or bark. So any part of plant can be used for. So this idea comes from the traditional claim, which is used very much prevalent in Chinese practice. Now availability, then authentication of plant materials. So once you identified that कि कौन सा part जो है useful है, then we have to identify. It should be identified some botanist and taxonomist. Once the plant part is identified, its specimen must be preserved into your institute or any herbarium for future reference. So parts to be used, generally the same part which has been claimed to have medicinal property should be used. For example, if the leaf is having medicinal property, then you have to use the leaf only. Now coming to processing of plant material, so ideally we should use fresh plant material, whether it is leaf or flower or root, it should be fresh. But in some cases we can use the dried, but if you dry the plant, ideally it should be dried in open space away from the direct sunlight, because sunlight exposure may degrade the phytoconstituents. So this is image showing, I have used an example of Clerodendron infortunatum, where this is left side is the live plant and right side is the dried plant material which has been coarsely powdered, okay, which I have kept here. Okay. So this is the Clerodendron infortunatum plant. This is called, in vernacular language it is called vart, which is very much prevalent in our country, called vart. Okay. Now coming to which solvent we will use extraction. For extraction we need some kind of solvents. So the same principle, like dissolve like, here like extract, since we are studying about the extraction process, so here principle apply, like extract like, means if you want to extract polar compounds you need polar solvents, if you want to extract non-polar solvents you need non-polar. So what are the polar and non-polar solvent, we will see. Here we can see the hexane is the least polar compound and water is the most polar solvent. So for extraction we need some solvent. That solvent, which type of solvent? If you are interested in the polar compounds, we need polar solvent. If you are interested in non-polar, we need non-polar solvent. But usually in practice, any plants have a spectrum of phytoconstituents. Many phytoconstituents are present in plant. So if you want to extract all those, we need to a mixture of non-polar and polar. For example, if you want to extract from this plant, so we can use water mixed with methanol or any organic. So if we mix two solvent, it will widen the spectrum of extraction. Okay, most of the phytoconstituents present in the plant will be extracted. So these are few important solvents that we usually use in case of extraction process. So right from the top we can see that the N-hexane has the least polarity and the water has the maximum polarity of 1. Now coming the parts to be considered in selecting solvent of extraction. So what are the factors? What are the factors for selecting solvents? So factors are selectivity. Obviously the solvent which will extract the most polar will extract the polar constituent. So this is the selectivity. Okay. Now safety. Ideally the solvent should be non-toxic and non-flammable. Obviously we will need a cheap solvent for our extraction process. Then reactivity. The extraction and reaction is quite different thing. In extraction process, the solvent doesn't react with the phytoconstituent. It extract, doesn't react. Reaction is another thing. Reaction means one compound react with another compound and give the third one. Here we are not giving the reaction. Okay. Here we are extracting the plant material in the same chemical constitution that is originally available in plants. So just taking it out. Okay. Now coming to recovery. So once we have extracted, it's ideally the solvent should be ऐसा होना चाहिए कि जो extract भी कर लिया, once I want to separate them, it should be easily separated. Okay, extract कर लिया, again we have to separate it. So it should be easily recoverable. Then viscosity should be less. अगर viscosity ज़्यादा होगा तो it will not go through. We'll see there later on. Okay, so if the solvent is viscous, it will not go through the plant material. It will stick to the plant material. It won't cause the extraction process easy. So it should have low viscosity. Ideally, the boiling temperature of solvent should be low. Why low? Because if boiling temperature will be high, high temperature will be required, and high temperature will destroy the phytoconstituents. Now coming to properties of solvents. So these are the important, these are not that much important. We just see water has the maximum polarity. Okay. So it has some advantage and disadvantage that you can go through your booklet, it is available. We should not waste our time in this. So then is alcohol, these are the advantage and disadvantage. Then chloroform and ether compound. So there are plethora of solvent we can use, but basically we use water, ethanol, even acetone, then ether, and every has some quality and some disadvantage also. Coming to the method of extraction. So basically for the extraction process we have many method of extraction, like we will start with the maceration. This is called cold extraction process. What do we mean by cold and hot extraction? One, where is heat is required for extraction, that is called hot extraction process. Where there is no requirement of heat, that is called cold extraction process. So this is cold extraction process. Here the plant material we mix with the solvent and keep it as such without heating it. So it is cold extraction process. So what we will do? We will do a plant material, okay. We will then place into a conical flask, okay. You can see here the solvent is being poured into the conical flask, then it is capped, okay. So plant material mixed with the solvent is kept for few hours. Then once extraction process is completed, we filter it using some cone, and we can see this is the extract, okay. Next is the digestion. Before moving to this, I would like to introduce these important terminology. I think we have missed it. What is medicinal plant? Okay, medicinal plant refers to plant containing active ingredients. Then comes to menstruum. Menstruum is a liquid or suitable solvent. So what solvent we are using for extraction process is called menstruum. Okay. Then another is the mark. Mark is insoluble. While we are doing extraction process, some leftover material is left after extraction that is not of use. It's called mark. Okay. And menstruum is solvent, and mark is the material that is left over. Okay. Then micelle is the mixer. So mixture of plant material and solvent is called micelle. Menstruum is called solvent, and mark is called the leftover material. So then I will correlate, say the same thing. So this is, what is this? Mixture. Once we have filtered it, this is extract. What is the leftover? Mark. Okay. I mean it's clear now. Okay. Next is the digestion process. Digestion process, here moderate heat is required. Maceration, cold process, there is no requirement of heat. This one is a moderate heat is required. The same thing is done. Mixture is kept for few hours and heated for about 50 degrees, and then it is kept for few hours. Then we filter it and separate the extract. Next is another is digestion, maceration, then decoction. Decoction is hot extraction process. Hot means heat will be required. Okay. Here again we mix the plant material with the solvent, and we can see here the solvent is poured into the plant material contained in any dish. Okay. You can see, then we are doing heating is done. Okay. By using any water bath we can use, or we have special heating mantle. This is called heating mantle. Okay. You can see mantle like material. So this device is called heating mantle. We can use water bath also. So once heating is completed, then we filter it. The same thing, only we are giving heat up to 50 degrees Celsius. Another one is a percolation. Percolation is a special process. Here we need a device, okay, that is called percolator. Percolator, this is schematic diagram. Here we can see the bottom is perforated. So what we will do? We will use the mixture और माइस क्या था अभी हमारे पास जो मिक्सचर था, मिक्सचर को हम इसमें प्लेस करेंगे, and then here there is tap. Okay, the tap is closed, mixture is placed, and then solvent is poured till it gets saturated. What do you mean by saturation? We start giving solvent till it stop further percolation. Okay, it won't take further solvent. Okay, once it is saturated, we keep it for few hours, up to 72 hours. Once extraction process is completed, we open the tap and take the extract out. So here there is tap. Okay, what is purpose? This filter, this perforated base acts as a filter. In the previous process, we see there is a requirement of filter. Here is no requirement of filter because this base acts as a filter. Okay. So here we can see we are opening the tap and we are taking the extract out. Next is the SOxLess extraction process, okay, and then microwave assisted extraction, ultrasound assisted extraction, okay. So today we are mainly focused on the SOxLess extraction process that we will demonstrate over there. Now these are the factors we consider while choosing extraction methods. So ideally the solvent should be heat stable, nature of solvent, obviously for polar we need polar solvent, cost, and then duration of extraction, final volume required, okay. Now coming to SOxLess extraction process. For SOxLess extraction we need an apparatus. So that apparatus consists of basically three parts. One is the round bottom flask, then is the extraction chamber, then condenser. So at the bottom there is round bottom flask, then extraction chamber, and at the top is the condenser. There we can see these three, okay. So this is the SOxLess apparatus. There is assembly of three apparatus, okay, we can see, okay. This SOxLess extraction process is different from the other processes discussed so far. How this is different? This is a continuous process. इससे पहले क्या था? One, we have started extraction process. We go in one run. Okay, we have to repeat this again. If you want to do again, we have to do right from the beginning. Okay, but this is a completely continuous process. The extraction keep on going. That we will see there. Okay, so this is continuous. Again, heat is required, so it is hot process. Clear? This is continuous process because this work in a cycle. Okay, repeated extraction occurs and heat is required, so it is called hot extraction. So SOxLess extraction is continuous hot process. What is the cold extraction process? Which was the cold extraction? Maceration by the cold extraction process. No heat was required. So these are the assembly. We have given the image. This upper one is the hot water inlet that we will see there. Okay. Cold water is let to come into the condenser, and then water will come out through the outlet in condenser. This condenser, the entire assembly is called a line condenser. Okay. Then the middle one is called extraction chamber. Okay. Extraction chamber has two tubes. One is the side or evaporation tube, another is a siphon. So middle process has two tubes, or extraction chamber has two tubes. One is the side tube, another is the siphon tube. And the bottom here is the round bottom. So basically SOxLess extraction apparatus has three parts. Okay. So in that we will see. For extraction we use the plant material is kept in a bag. Okay. So this is called thimble. In extraction chamber, there we can see in the middle one there is extraction chamber. In extraction chamber the plant material is kept in a tube or a bag. The bag is commercially available in market, or we can also make by using filter paper or some paper or chart paper. Okay. So ideal is a filter paper. So we can make also, or we can purchase it. So this plant material is packed in the thimble, and this thimble is placed into the extraction chamber. How it is placed, how it is done, we can see. Okay. So the extraction, once the extraction is start, it take one cycle of extraction. We will see that we will put the solvent from the top, and then it will come to the round bottom flask, and then we start the heating. Then it will evaporate, the solvent will evaporate, it will come again and go through that we will demonstrate. Okay. Go through the plant material and it will extract the phytoconstituents. This entire process is called one cycle, and this will keep on going. Okay. So what are the various phytoconstituents that we can use, and what are the solvents that you use for different phytoconstituents that we have mentioned here. Once the extraction has completed, we need to extract or separate the extract. Ultimately, we have to separate the solvent and phytoconstituents, because we are interested in phytoconstituent. We have to separate the solvent out. Once the phytoconstituents is separated, we get the phytoconstituent in the form of a semi-solid material or crystals depending upon the phytoconstituents. This is the entire apparatus that we will demonstrate. Then once the extraction process is complete and we have separated the phytoconstituent, now we need to identify that. So there is 3 steps. One is extraction, then it is separation, and third one is the identification. Ultimately, we are interested which phytoconstituent is present in that particular plant. So 3 steps. We are mainly focused on the extraction process. After extraction, there is separation and then identification or chemical characterization, which functional group is present in that particular plant material. Now coming to demonstration part. Okay, so let's move. So this assembly is, what is this? Sock slit apparatus. It has got 3 parts. This is the round bottom flask. Okay. This is extraction chamber, and this one is, you should also remember, round bottom flask, extraction chamber and condenser, align condenser. Round bottom flask में क्या रहेगा? Solvent obviously. ये solvent कहाँ से? हम ऊपर से डालेंगे using this cone. Okay. Solvent में हम क्या use कर सकते हैं? Any solvent. I have used 20% of methanol and aqueous solution of methanol. Okay. इसमें हमने क्या किया? Distilled water 80 ml and 20 ml of methanol को mix किया. ठीक है. Mix करने के बाद I will use. So this is mixed one. Okay. हम यहाँ से I will place this. Okay. But before this, we need to put this plant material into the extraction chamber. Plant material किस में pack करना है? This is called thimble. This is available in market, but I have made it using chart paper. Okay. So once it is packed, so this is packed one. We have to open from here. So this is separatable. We can separate it from here and from here. So it will get separated in 3 parts, 1, 2, and 3. We can separate it from here. Then we have to place it into the extraction chamber. Once it is inside the extraction chamber, now we have to put this solvent using this. For example, I am putting this in this, okay, or this. So this is 20% methanolic solution. I have to put from here. You can see. Okay. So what is happening? Once the level comes up to this level, it gets drained. So what is this? This is evaporation. Heat से क्या होगा? Once we are heating, the heat converts the solvent into vapor. Vapors comes, rises up and go to the condenser, get condensed, okay, and again fall onto the plant material drop by drop. Okay. Once this level come up to this level, this is called siphon tube. This bigger bore tube is called side tube, and this is called siphon. This is for evaporation. Solvent come up, and this is for extraction. Okay. Siphon tube, the plant material along with the the solvent along with the phytoconstituent get drained. ये कब drain करेगा? जब तक ये level यहाँ तक नहीं आएगा, है? ये अब फिर rise करेगा जो हमको इसको दिखा भी सकते हैं demonstrate करके. Level rise हो रहा, कहाँ तक rise किया है? अभी तक नहीं हो रहा है ना. तो ये जब ये जो है एक्सट्रैक्ट इधर से होके इधर नीचे जब तक ये लेवल यहाँ तक नहीं आएगा, it won't drain. Once the level crosses this much, it will drain. The entire content will be drained into the round bottom flask. Again, it will evaporate. So the entire process, evaporation, condensation, then rising up to this level. This is called point of drain or point of return. Okay. तो ये entire process draining का होगा, तो वो one cycle कहलाता है. Entire process is called one cycle. Again, the same process will be repeated. So that is why this is called continuous extraction process. Okay. So हम यहाँ पे temperature यहाँ से set कर सकते हैं, ठीक है? ये समझ में आ गई बात ना सारी चीज़ें। टेम्परेचर यहाँ सेट कर सकते हैं और कितना रिक्वायरमेंट है दैट विल डिपेंड अपॉन द नेचर ऑफ सॉल्वेंट एंड नेचर ऑफ फाइटोकॉन्स्टिट्यूएंट या एंटीसिपेटेड फाइटोकॉन्स्टिट्यूएंट कि क्या हो सकता है इसमें या क्या हम एज्यूम कर रहे हैं, एंटिसिपेट कर रहे हैं। तो उसके हिसाब से उसका क्या हीट स्टेबिलिटी है वो हमको लिटरेचर से मिल जाएगा, अकॉर्डिंगली हम लोग यहाँ टेम्परेचर सेट करेंगे। इसको बॉइलिंग भी नहीं होना चाहिए, जस्ट वेपर बनना चाहिए, ठीक है। तो इस तरह से हम यहाँ एक्सट्रैक्शन देख सकते हैं। ये एक्सट्रैक्शन होने के बाद जो हमारे पास ये मटेरियल अवेलेबल होगा, ये एक्सट्रैक्शन में इनिशियली क्या होगा, इसका कलर जो होगा पेल येलो, काफ़ी लाइट होगा। क्यों? क्योंकि जो है सारे एक्सट्रैक्शन कंप्लीट नहीं हुए हैं। जब एक्सट्रैक्शन कंप्लीट होता रहेगा, बार बार एक्सट्रैक्शन होगा, तो द कलर विल डीपेन है। एक समय आएगा जिस जो कलर है मैक्सिमम हो जाएगा, ठीक है। और फिर उसके बाद जो है कलर क्या होगा, फिर से फेड होना। एक बार क्या होगा, शुरू में एक्सट्रैक्शन इनिशियल कम होगा, फिर एक्सट्रैक्शन बढ़ेगा और अल्टीमेटली जब कंप्लीट एक्सट्रैक्शन होगा फिर से कलर फेड अप हो जाएगा और कलर मिनिमम लिस्ट हो जाएगा। जैसे इसमें देख सकते हैं कलर मिनिमम हो गया है, ये इनिशियल प्रोसेस में है। यहाँ क्या हो गया, मिडल प्रोसेस में। यहाँ क्या एक्सट्रैक्शन कंप्लीट हो चुका है, ठीक है। ये अभी हमने स्टार्ट किया, ये मिडल में है और ये इसमें भी देख सकते हैं हम कलर मिनिमम है, इसमें भी कलर मिनिमम। एक समय आएगा जिसके बाद कलर चेंज, देयर इज नो फर्दर चेंज इन कलर, हम समझेंगे कि द एक्सट्रैक्शन इज कंप्लीटेड। अब फर्दर कितना भी सॉल्वेंट राउंड मतलब सर्कुलेट करते रहे, कितना भी ऊपर से अगर नीचे जाएगा, देयर इज नो फाइटोकॉन्स्टिट्यूएंट टू बी एक्सट्रैक्टेड फर्दर, ओके। तो ये फर्दर जब फर्दर चेंजेज नहीं आ रहा है कलर में, मीन्स द एक्सट्रैक्शन प्रोसेस इज कंप्लीट, वी हैव टू टेक इट आउट, ठीक है। तो ये क्या प्रोसेस कंप्लीट हुआ, दिस इज द एक्सट्रैक्शन। देन वी हैव टू मूव फॉर you have to move for separation. For separation, we have this entire assembly is called rotary evaporator. So rotary evaporator we use for type of material where the phytoconstituent is non-volatile and solvent is volatile. Then only we can use this device. Okay. So solvent, since the solvent is volatile, it will be evaporated, and the phytoconstituent is non-volatile, it will remain in the flask. Okay, so this way the solvent will be separated from the phytoconstituent. So how will use, you will dip in the water, so switch it on. Now here again there is condenser, okay. So we have to open the condenser, I mean inlet. This is inlet, this is outlet, okay. Here again we can see this is inlet pipe, okay. Inlet pipe, water come into the condenser. Here is the outlet pipe, water come out of the condenser. अगर हम ये नहीं करेंगे तो क्या होगा, कंडेंसेशन नहीं हो पाएगा क्या, क्योंकि ये पानी गर्म हो जाएगा। अगर कंटिन्यूस सर्कुलेशन पानी का नहीं करें, पानी गर्म हो जाएगा, इट वोंट कंडेंस द वेपर। इसलिए जो वाटर फ्लो सर्कुलेशन मेंटेन होना चाहिए। यहाँ पर भी हम क्या करेंगे, वाटर फ्लो, हमने वाटर ओपन कर दिया तो ये क्या हो रहा है, वाटर सर्कुलेट हो रहा है। अब यहाँ से हम ऑन करेंगे, देन वी हैव टू सेट द टेम्परेचर। कितना टेम्परेचर इसका वाटर का रखना, डिपेंडिंग अपॉन कितना सॉल्वेंट का क्या बॉइलिंग पॉइंट है। उस बॉइलिंग पॉइंट पर सपोज कर रहे हैं इसका अगर मान लीजिए 50 रखें तो हम यहाँ सेट कर सकते हैं, ठीक है। सेट टेम्परेचर, वी कैन एडजस्ट, ओके। यहाँ सेट टेम्परेचर, अगर इफ यू वांट टू डिक्रीज टेम्परेचर और इफ यू वांट टू इंक्रीज टेम्परेचर, वी सेट फ्रॉम हियर, ओके। तो हमने 50 सेट कर दिया, देन वी हैव टू एंटर, ओके। देन स्टार्ट, नाउ हीटिंग हैज स्टार्ट। व्हाट इज टेम्परेचर, current temperature of water. So this is the current temperature. What is written here? This is the temperature. What is set temperature? 50. We have set temperature to the 50, but current temperature is 38. Once the 38 has reached, it will auto cut off. Okay. So this process, this way. Now we have to rotate this. Okay. Why rotate? अगर रोटेट नहीं करते यूनिफॉर्म सर्कुलेशन, और रोटेशन से एक और फायदा होता है, जो अंदर में जो प्लांट मटेरियल है उसको सरफेस एरिया ज़्यादा मिलता, तो इट विल इवोपरेट इजीली। इट इज ऑल्सो कनेक्टेड विद अ पंप, हो गया, ओके, ठीक है। सो दिस इज वैक्यूम पंप। ये वैक्यूम पंप नेक्स्ट ग्रुप आ गया है क्या, ओके, ठीक है। तो मेरा 2-3 मिनट का, ठीक है। तो इवोपरेशन पंप, इसका क्या पर्पस है, इट विल हेल्प और फैसिलिटेट इवोपरेशन। इधर इसके अंदर क्या होगा, वैक्यूम क्रिएट करेगा, दिस इज वैक्यूम पंप। तो वैक्यूम क्रिएट करेगा तो उससे क्या होगा फायदा, ये इवोपरेशन जो और इजी हो जाएगा। किसी भी चैम्बर में अगर क्लोज चैम्बर है उसके अंदर का प्रेशर कम कर देते तो क्या होता है, उसके अंदर कोई भी चीज़ आना आसान हो जाता है, तो वही चीज़ होगा, है ना। तो सक्शन पंप का हमारा यही काम है कि ये फैसिलिटेट, जैसे हमने देखा है कि हमने जो लास्ट टाइम किया था, है ना, तो इसमें जो है सॉल्वेंट और जो यहाँ पे हमारे पास जो मिक्सचर था, हम एक्सट्रैक्ट जो है उसका कलर और जो सेपरेट हुआ है ना, उसका कलर काफ़ी डिफरेंट है। दिस इज एक्चुअल कलर ऑफ सॉल्वेंट। ओके, तो हम ये सारे सॉल्वेंट इधर जाए, अल्टीमेटली हमारे पास क्या बचेगा? अल्टीमेटली we will be left with this material only. So this is the semi solid material that we have extracted. Ultimately this much amount we extract from plant. Okay, now we have to preserve it. Okay, so we can preserve in this desiccator, vacuum desiccator. Okay, this is called desiccator. Okay, preserve करने के लिए what should be the ideal atmospheric condition? It should be air or air free. एयर फ्री, क्योंकि एयर में तो कंटामिनेंट्स आते हैं। एयर फ्री बनाने के लिए हम क्या करेंगे, ये प्रेशर डिवाइस यूज करेंगे। वी कैन यूज दिस। ओके, यहाँ से हवा निकाल रहे हैं, वी आर मेकिंग दिस एयर फ्री और वैक्यूम। ओके, इससे इवापोरेशन में भी हेल्प, अगर कुछ सॉल्वेंट रह भी गया हमें, दैट विल कम आउट। ओके, ठीक है, इस तरह से हम वैक्यूम कैसे हम चेक कर सकते हैं, देखा हमने कि वैक्यूम हुआ था, इस तरह से चेक कर सकते। अगर हमारे पास वैक्यूम पंप नहीं है तो वी कैन ऑल्सो यूज, आइडियली यहाँ से खुलता है बट वो टूट गया है। वैक्यूम पंप अगर नहीं है तो वी कैन यूज सम डेजिकेटर, यहाँ पर डेजिकेटर है ना, यूज कर सकते हैं। जैसे मैग्नीशियम सॉल्ट्स को यूज कर सकते हैं जो हाइग्रोस्कोपिक होता है, ठीक है। तो वो नीचे रख के उसके ऊपर रखेंगे तो जो भी इसमें एटमॉस्फेयर में जो भी मॉइस्चर्स होगा उसको एब्जॉर्ब कर लेगा। तो इस तरह से हम लोग क्या किया अभी तक, वी हैव डन एक्सट्रैक्शन, then separation, then preservation. We have not done which part? Identification and characterization. That we are not focused today. Okay. So any doubt about this? Please you can ask.
एक्सट्रैक्ट सेम है,
Depending upon what you are interested. अगर आपके पास 3 plant material है तो we can run all the 3 same at the same time. ये एडवांटेज इस असेंबली का, इसमें दूध कुछ और एक्सट्रैक्ट कर रहे हैं, इसमें कुछ और एक्सट्रैक्ट कर रहे हैं, इसमें कुछ और एक्सट्रैक्ट कर रहे हैं, ये भी कर सकते हैं। नहीं नहीं, बिल्कुल नहीं होगा, इंटरकनेक्टेड है ही नहीं, ये तो बस कंडेंसर इंटरकनेक्टेड है जिसमें कि कुछ भी बाहर का नहीं जा रहा। कंडेंसर का ये आउटर चैम्बर होता है जिसमें पानी जा रहा है। जो इसका इनर चैम्बर है दैट इज नॉट कनेक्टेड विद ईच अदर, ओनली आउटर चैम्बर थ्रू विच ओनली वाटर इज एंटरिंग एंड वाटर इज गोइंग आउट। देयर इज नो इंटरकनेक्शन एट ऑल। और कोई डाउट? कंडेंस होगा ऑब्वियसली, इसीलिए तो हमको कोल्ड वाटर दे रहे हैं, इसीलिए टैप वाटर जो है कोल्ड वाटर है, टैप वाटर दे रहे हैं। टैप वाटर है, इट इज इनसाइड, यू कैन सी, यू कैन सी द मूवमेंट ऑफ टैप वाटर। ठीक है, और कोई डाउट? सो थैंक यू ऑल।
Recording stopped.
So, good afternoon to offline and online delegates. In this session, we will be talking about demonstration of bioassay through computer assisted learning with the help of software MyCalPharm. So, starting with the definition of bioassay, as you all know that bioassay is a analytical method which is used to determine the concentration of a test solution with respect to dose response tracing of known or standard solution. Now, here in this experiment we will be performing bioassay by 3-point assay method. Now, what is this 3-point assay method? In 3-point assay method, which is an analytical method, we determine again the concentration of a test solution with respect to dose response tracing by taking 2 doses of standard solution and 1 dose of test solution. So, as the name suggests, 3-point assay in which we take 3 doses, 3 responses of 3 doses from standard solution and 1 dose response from test solution, and depending upon the dose response tracing we determine or calculate the concentration of the test solution. Now, here you can say the setup of bioassay which you have seen or you must be seeing at station number 1. The only difference in this setup is that we are having amplifier and display laptop screen in place of lever and chymograph which is there in the traditional bioassay setup. So, here you can see in the display there are 2 test tube, first and second. The first one is highlighted in red, both contains the drug acetylcholine. The first test tube contains the drug with known concentration which you can see in displays 20 microgram per ml. So, it is known as standard or known concentration. The next one is the drug acetylcholine with unknown concentration, hence it is known as test or unknown solution. So, to start with the experiment we have to take dose response tracing of the standard solution first, and we will start from the lowest dose, that is 0.01. You can see the range of doses here on the screen which starts from 0.01 to 1 ml. We will start with the lowest dose 0.01 to get the minimum response, and gradually we will double the dose 0.2, 0.4 and so on to reach 1 ml to get the maximum response. So, because of time constraint we are here demonstrating only 2 doses, that is 0.01 and 0.2, and this process 3 steps are repeated continuously, that is washing the tissue, taking the baseline recording and injecting the drug. Now, why washing is done? Washing is done to remove the thyroid solution from inner organ bath which contains the drug or the dose, and to refill the fresh thyroid solution from the reservoir. And why it is done? To remove or wash off the effect of previous dose of the drug. So, this is why washing is done. So, first we will wash the tissue, then we will click on baseline. Now, baseline recording is taken in which the chymograph is run for 45 seconds. Now, why baseline recording is taken? It is taken to measure the magnitude of response which we will be getting by the drug that is to be given. तो baseline हमने लिया, magnitude of response उसके context में हम लोग measure करते हैं, इसीलिए baseline recording लेते हैं. After taking the baseline recording, we will inject different doses of the drug ranging from 0.01 ml to 1 ml. So, after taking the all the responses of the doses from standard solution, that is acetylcholine, we will move towards taking the responses from the test solution in which the concentration is unknown. Now, you can see the highlight has moved towards this test tube. This means that we are taking doses from unknown or test solution. Again the same process is repeated. We will start from 0.01 and we will follow the process of wash, baseline, inject, wash, baseline, inject for all the doses till we reach 1 ml, which here where will we get the maximum response. So, we will perform both the experiment, both the solution, standard and test solution, all the processes will be repeated, and after completion of all the doses we will click on the observation button and we will get the graph where we will be seeing the responses of a standard solution and test solution of all the doses. You can see the instructions also being given in the footnote which we have to follow, that is wash, baseline and inject. So we will reach the third dose, that is 0.04. We will wash, that is we will remove the thyroid solution. The fresh thyroid solution is being refilled from the reservoir. Then baseline is taken for 45 seconds. Then we will inject the next or the higher dose and we will record the response. Now, both the solutions we have taken all the doses from 0.01 to 1 ml. All the recordings have been noted on the graph. Now, here you can see the responses which is gradually increasing, and this recording is for both. Till here it is the recording of the standard solution, and from here there is the recording of the test solution. Now, what we will do next is we will measure the amplitude of response with the help of a measuring scale for all the responses for all the doses, both for standard and test solution. एक एक करके हम लोग measure करेंगे, उसको note down करेंगे. Now, because of time constraint, what we have done beforehand, we have measured and noted each response, and accordingly we have entered the responses in the given table. So, this is the table. We got the responses, we measured with the help of measuring scale of the standard solution, and we have entered all the responses here. Simultaneously, accordingly, we measured all the responses from the test solution and we have entered all the values here just to save the time. Now, let me just explain this table of the standard solution, in which you can see there are 5 columns. In the table of standard solution, the first column here shows the concentration of acetylcholine. So, this is the known solution which was displayed there, that was 20 microgram per ml. Next is amount added to the organ bath. So, this amount represents the different doses that we took, ranging from 0.01 to 1 ml. So, this is the different doses. Next column represents amount which was added to organ tube, that is in organ bath. So, this is calculated by multiplying the concentration of known solution by the amount added to organ bath, that is 20 multiplied by 0.01, which equals to 0.2. The fourth column here represents concentration in the organ tube. Now, this is calculated by dividing the amount added to the organ tube by size of the test tube. The standard size of the test tube that was used was 10 ml. So, we will divide 0.2 divided by 10, which equals to 0.02. And the last, that is the fifth column, represents the responses that we measured with the help of a measuring scale for all the doses, which ranges from 4 to 50. So, this is the description of the table all over here. Now, both the tables are ready. Table number 1 is for the standard solution, table number 2 is for the test solution. Both the tables are ready. What we have to do next, we will be moving towards reaching the objective of this study, that is calculating concentration and potency. So, for calculating concentration and potency of the test solution, we need 3 parameters, 3 calculations: N1, N2, S1, S2 and 2T, small t and capital T. ये 6 parameters को हम लोगों को calculate करना है, determine करना है. First of all, we will be talking about N1, N2, S1, S2. So, from the table of a standard solution, we can determine N and S. Now, what denotes N and S? N denotes the dose of the standard solution. ठीक है, तो इस सारे कॉलम में डोज किस में बताया जा रहा है? सेकेंड कॉलम में. सो N हम लोग इस कॉलम से चूज करेंगे, एंड S डिनोट्स द रिस्पॉन्स ऑब्टेन, जो हमने मेजरिंग स्केल से मेजर किया, विच इज हियर इन द लास्ट कॉलम. सो वी विल मूव टुवर्ड्स कैलकुलेटिंग N1, N2, S1, S2. ये 4 पैरामीटर्स हम लोगों को कैलकुलेट करना है. नाउ फॉर कैलकुलेटिंग S1, S2, वी शुड नो कैसे कैलकुलेट करते हैं. तो जो स्टैंडर्ड सॉल्यूशन में हमें मैक्सिमम रिस्पॉन्स मिला है, उसका 25% और 75% हम लोग कैलकुलेट करेंगे. सो दिस इज द रिस्पॉन्स कॉलम. सो व्हाट इज द मैक्सिमम रिस्पॉन्स? 50. तो 50 का 25% हम लोग निकालेंगे, विच इज 12.5 mm. At the same time, we will calculate the 75% of this 50, which is 37.5. तो ये दो वैल्यूज हमारे पास आ गया, 12.5 and 37.5. Now, S1 and S2 जो रिस्पॉन्स हमें कैलकुलेट करना है, should fall between these two values. इसी के बीच में आना चाहिए. तो ये जो रिस्पॉन्स का कॉलम है, अब इसमें हम लोग देखेंगे कि 12.5 और 37.5 के बीच में कौन से वैल्यूज आ रहे हैं. सो here we get 3 values, 14, 22 and 33. ये 3 वैल्यूज आए जो 25% और 75% के बीच में है. अब इस 3 वैल्यूज में से हम लोग को 2 वैल्यूज चूज करना है, दैट इज S1 and S2. बट व्हाट टू रिमेंबर इज दोस 2 वैल्यूज शुड बी कंसेक्यूटिव, वो लगातार होना चाहिए. या तो हम लोग 14 and 22 ऑप्ट कर सकते हैं, या 22 and 33, बट नॉट 14 and 33. ठीक है, तो ये रिस्पॉन्स से हम लोग S डिटरमाइन कर रहे हैं, S1 and S2. तो वी ऑप्टेड 22 and 33. तो S1 बिकम्स 22 and S2 becomes 33. तो ये हमारा रिस्पॉन्स आ गया. उसी के साथ साथ हम लोग n कैलकुलेट करेंगे विच रिप्रेजेंट्स डोज। तो अब देखेंगे कि ये रिस्पॉन्स कितने डोज में मिला, तो 0.08। सो 0.08 डोज में मतलब ये हमारा N1 हो गया, हमें 22 mm का रिस्पॉन्स मिला, एंड साइमल्टेनियसली 0.1 विच इज N2, तो 0.1 ml में हमें 33 mm का रिस्पॉन्स मिला। सो फ्रॉम दिस टेबल वी कंक्लूडेड 4 पैरामीटर्स N1, N2, S1, S2। वी विल मूव टुवर्ड्स द टेस्ट सॉल्यूशन, टेबल ऑफ टेस्ट सॉल्यूशन। यहां से जो 2 पैरामीटर्स बच गया, स्मॉल t, कैपिटल T, वो हम लोग कैलकुलेट करेंगे। नाउ स्मॉल t रिप्रेजेंट्स द डोज ऑफ द टेस्ट सॉल्यूशन एंड कैपिटल T रिप्रेजेंट्स रिस्पॉन्स, कौन से डोज में कितना रिस्पॉन्स आया। सो दिस इज द कैपिटल T, दिस इज द स्मॉल t, ये कैलकुलेट करना है। कैपिटल T मतलब ये टेस्ट सॉल्यूशन का रिस्पॉन्स जो हमें निकालना है, दिस शुड फॉल बिटवीन द वैल्यू ऑफ S1 एंड S2। जो स्टैंडर्ड सॉल्यूशन का टेबल था हम लोग S1 S2 उसमें से निकाले, दैट वाज 22 एंड 33। तो अब इसमें देखेंगे कि 22 और 33 में कितने वैल्यूज हैं, तो वी गेट हियर 2 वैल्यूज, 29 एंड 33। तो ये 2 वैल्यूज हमारे पास इसमें आ रहे हैं, सॉरी 32, ये 2 वैल्यूज हमारे पास आ रहे हैं। वी विल ऑप्ट फॉर 29, ठीक है, 32 भी ऑप्ट कर सकते हैं, 29 हमने ऑप्ट किया। सो दिस 29 बिकम्स कैपिटल T, दैट इज रिस्पॉन्स ऑफ द टेस्ट सॉल्यूशन। और इसी के साथ हम किस डोज में ये रिस्पॉन्स मिला, दैट इज, सो दिस इज स्मॉल t। तो ये दोनों टेबल से हमारे पास 6 वैल्यूज आ गए, N1, N2, S1, S2, स्मॉल t, कैपिटल T, ये 6 वैल्यूज आ गए। ये टेबल के बाद वो वैल्यूज हम लोग इसमें पुटअप करेंगे जो हमारे रिस्पॉन्सेज मिला है। पुटअप करने के बाद वी विल कंटिन्यू द एक्सपेरिमेंट एंड वी विल मूव टू द नेक्स्ट पेज, दैट इज लैटिन स्क्वायर रैंडमाइजेशन। ये हमने 3 पॉइंट ऐसे कर लिया, 3 पॉइंट ऐसे से हमारे पास 6 पैरामीटर्स हमारे पास आ गए, एक एक्सपेरिमेंट कंप्लीट हो गया। इससे हम लोग पोटेंसी कैलकुलेट करते हैं, बट now we will do Latin square randomization. Now what is Latin square randomization? You must have read in your textbook. So basically it is a part of 3-point essay in which we average the 3 responses, standard solution, test solution, दोनों मिला के हम लोग 3 response लिए, 2 response हम लोग लिए S1, S2 standard से, और capital T हम लोग लिए किससे, test से। ये तीनों के वैल्यूज को हम लोग रैंडमाइज कर देते हैं या एवरेज निकाल देते हैं, दैट इज डन इन लैटिन स्क्वायर रैंडमाइजेशन। एंड व्हाई इट इज डन, इट इज डन टू मिनिमाइज द चांसेस ऑफ रैंडम एरर, इसलिए हम लोग ये करते हैं। और वी कैन ऑल्सो से दैट टू क्रॉस चेक द वैल्यूज ऑफ द 3-point essay मेथड वी डू लैटिन स्क्वायर रैंडमाइजेशन। जो वैल्यूज हमें 3-point essay से आए उसको एक तरीके से क्रॉस चेक करते हैं लैटिन स्क्वायर से। तो लैटिन स्क्वायर रैंडमाइजेशन में इन दिस सॉफ्टवेयर अगेन द प्रोसेस इज रिपीटेड, 2 डोज हम लोग लेंगे नोन से और 1 डोज लेंगे हम लोग टेस्ट से, एंड अगेन द सेम प्रोसेस इज रिपीटेड, वॉशिंग द टिश्यू, टेकिंग द बेसलाइन एंड इंजेक्टिंग 3 डोजेस ऑफ द ड्रग। ये करने के बाद फिर हमारे पास ग्राफ में रिस्पॉन्सेज आ जाएंगे। विद द हेल्प ऑफ मेजरिंग स्केल अगेन वी विल मेजर, नोट इट डाउन एंड वी विल एंटर द वैल्यूज इन द टेबल जो हमें रिस्पॉन्सेज आए। तो इस तरीके से हम लोग इसको मेजर करेंगे लैटिन स्क्वायर के बाद, और वो वैल्यूज को हम लोग उसमें पुटअप करेंगे। So this is the table, this table is the table of Latin square randomization. यहां हम लोग Latin square randomization करेंगे, मतलब तीनों response को average करेंगे। The only difference in this software is this, they are using N1, N2 small t instead of S1, S2 and capital T, which is written all in your textbook and what we are talking about. So we will assume that this row is S1, S2 and capital T and accordingly we will enter the values. तो हमें values आया था 22, 33, 29, वो values तीनों रो तीनों कॉलम में हमने एंटर कर दिया। We will click on the average button, मतलब Latin square randomization हमने किया and we get these 3 values again, 22, 33, 29. So we get exactly the same value that we got by 3-point essay method, ठीक है। Now because we are doing this in a software based study, so because we are getting exactly the same value, because the chances of random error in software based study is very minimum. ये हम लोग अगर ट्रेडिशनल बायो सेटअप पे करते तो हो सकता है थोड़ा सा डिफरेंस आता। तो हमने 3-point ऐसे मेथड किया, 6 वैल्यूज कैलकुलेट कर लिया, उन 6 वैल्यू को हमने रैंडमाइजेशन किया, क्रॉस चेक किया लैटिन स्क्वायर से, अल्टीमेटली वी गॉट 6 वैल्यूज। नाउ ऑन द बेसिस ऑफ दिस 6 वैल्यू, ऑन द बेसिस ऑफ ए फॉर्मूला एंड सिंपल मैथमेटिक कैलकुलेशन, वी विल रीच द ऑब्जेक्टिव ऑफ दिस एक्सपेरिमेंट, दैट इज कैलकुलेशन ऑफ potency and concentration of the test solution. So as you can see above here, there are 6 values are written, N1, N2, N1, N2, S1, S2, capital T, small t. Concentration जो हमें पता था that was 20 microgram per ml. Then the step 1, that is formula for calculating the relative potency, which is denoted by M. This is the formula t minus s1 divided by s2 minus s1 into log n2 by n1. अब जो वैल्यूज हमें मिले जो ऊपर लिखे हुए t s1 s2 सबको हम लोग यहाँ पुटअप कर देंगे, मल्टीप्लाई करेंगे, log लगा करके by simple calculation we get m that is 0.617 and we reach the first objective of this study, that is calculation of the potency. तो जो unknown concentration था उसका हमने potency calculate किया. Next we will calculate the concentration of the unknown solution or test solution, which is the main objective of this study, again on the given formula n1 by t into antilog of m, which is multiplied by concentration of the standard solution. तो हमने यहाँ पे एंटीलॉग को कैलकुलेट किया, विच इज 10 मल्टीप्लाइड बाय 0.617. ये 0.617 क्या है? पोटेंसी, जो अभी जस्ट हमने कैलकुलेट किया, रिप्रेजेंटेड बाय अल्फाबेट m. ठीक है, ये हमने निकाल लिया एंटीलॉग, ये वैल्यू आ गया हमारे पास 1.154. अब कंसंट्रेशन ऑफ स्टैंडर्ड सॉल्यूशन हमें पहले से मालूम है 20, जो फर्स्ट स्लाइड से हम लोग देखते आ रहे हैं. इस ये वैल्यूज को हमने इसमें पुटअप किया 0.08, 0.08. We will multiply and we get the value 23.08 microgram per ml, which is the concentration of the test solution. So we reached the objective of this experiment, that is we calculated potency, which is represented by m, and we calculated concentration both of the test solution. Standard solution का concentration हमें पता था, that was 20 microgram. Just now we calculated of the test solution, that is 23 microgram. That is all about this. Any questions?
Whole experiment, the concentration of the second is standard. Standard we have taken into concentration, na? So we have the concentration of the first standard, but we don't have. We have unknown concentration of second, na?
स्टैंडर्ड का हमारे पास कंसंट्रेशन पता है, नोन है 20. जो फर्स्ट टेस्ट ट्यूब था उसका हमें कंसंट्रेशन पता था कि 20 माइक्रोग्राम है. इतने सारे डोजेस थे, एक एक डोज लेके हमने परफॉर्म किया. दूसरे टेस्ट ट्यूब का कंसंट्रेशन नहीं पता है, वही निकालना है हमें. ठीक है, सारे डोजेस में देंगे, दैट इज द ऑब्जेक्टिव. वो और उसको कंपेयर कैसे करेंगे? दोनों का डोज रिस्पॉन्स ट्रेसिंग ले लिया, स्केल से मेजर किया, फॉर्मूला लगाया, लैटिन स्क्वायर किया, एंड देन ऑन सिंपल मैथमेटिक कैलकुलेशन we calculated potency and concentration. So that is all. Now the next topic is calculation of PD2 and PA2.
Okay, so why efficacy? There is use of efficacy in therapeutic clinical implications, that more effective drugs are to be chosen based on the benefit risk ratio. So what is the need of potency? If a 5 mg of a drug is getting same response as 20 mg, we can give 20 mg of other drug also. So suppose I am giving an example. You have to develop a drug, a statin, that is given through transdermal patch, and you have various lead compound, and you have to select one lead compound. What would you do? Would you choose most potent drug, or would you choose highly potent drug, or would you choose drug with low potency? High potency. Why high potency? Okay, because very less amount of the drug is absorbed through the skin, and so we need highly potent drug. So in case of oncology also, if in case of targeted drug delivery system, we have to choose the highly potent drug. So you have to compare the potency of various statins. What will you do? Would you take clinical LDL response, or would you take direct receptor action, that is HMG coenzyme inhibition assay? So more accurate will be direct receptor action. So in vitro study is very important. So that is the use. So as you all know, potency is inversely proportional to the dose. Okay. So we have the logarithmic, we plot the dose on the logarithmic scale. We have a log dose in the x axis and response on the y. So from that log dose we have to calculate the potency. So we take negative logarithm, as it will be now inversely proportional to the dose. So, what is the PD2? It is generally the negative logarithm of the EC50, that is the dose of the agonist which produces 50% response. So, why can't we plot the dose response curve of antagonist? Why we need agonist in this case? Anyone?
Because we have to compare potency.
Why not we can plot dose response curve of antagonist? Because antagonist has zero intrinsic activity, na? At receptor it will produce no response. If we have inverse agonist, then we can plot. So, we need agonist. So, how do you calculate the PA2 value? So, we have to take negative logarithm of the antagonist that is producing the double shift in the DRC of the agonist. Okay. So, in shield plot we plot log dose ratio minus 1 in the y axis and molar concentration of antagonist at the x axis. So, what is dose ratio? It is simple, AD50 in presence of antagonist divided by AD50 in absence of antagonist. So, if we have to get the two-fold shift, then dr should be 2, then dr minus 1 is equal to 1, then log dr minus 1 is log 1 is equal to 0. So, in y axis we have to choose, if the log dr minus 1 is plotted in the y axis, we have to choose 0. So, this is how this setup looks like. You have been demonstrated the cycle of wash, baseline and then injecting the dose in the bioassay. Okay, we are demonstrating the procedure. As you have the online delegates and the offline delegates have been provided the access to the MyCalform software for 1 month, so they can practice. The online delegates will receive online seminar in 3 to 4 days and you have got the book. Okay. So, now we are learning it. So, in this setup what is the difference? Apart from agonist we have antagonist also. So, we have obtained the tracing of this agonist, and what we have to do? We have to also take atropine, and after injecting atropine in the inner organ bath, we have to inject the agonist also. Okay. So, I am demonstrating here the PA2. PD2 is simple. This is the setup. So, by doing this, we got this table. Okay. Similar table as we have seen in the bioassay setup. This is in no internal connection. Why? So this is the PD2. You have seen the similar table in the bioassay. So this is the dose, this is the response. Okay, you can sit. कहाँ दिख रहा है? So this table you have seen in the bioassay, the dose is there, the response is there. Okay. Now we have plotted this dose response. Okay. Now from this 50% response, we have got the log molar concentration of acetylcholine, and negative of this log molar concentration is the PD2 value. That is, the more the PD2 value, the more will be the potency. Now coming back to this PA2 value. So in absence of atropine, we have got the table. Okay. In presence of atropine, 0.1 dose, we have got the dose response, and in presence of 0.2 ml of atropine, we have got the dose response. We have entered the maximum response and got the percent response. Now going to this graph. This graph has plotted the dose response curve of acetylcholine in absence, that is the blue graph. Okay. This is the blue graph. Now you just place at this 50% line. What is the ED50 of acetylcholine? Minus 0.75. Okay. Now this 50% line, place this in the red. The red is presence of 0.1 dose of acetylcholine. That is, the EC50 is minus 0.49, and the yellow tracing is 0.2, that is minus 0.43. So for calculating the PO2 value, what we are getting? We are obtaining the EC50 of acetylcholine in absence of antagonist and in the presence of increasing dose of antagonist. So from this tracing, what we got? We got these values. In absence of antagonist, minus 0.75. In presence of 0.1 ml of antagonist, that is minus 0.49, 0.2, minus 0.43 and 0.23. So we have put this value, and now what we have calculated? The log molar concentration we can calculate. Here the software has calculated it. This is the log molar concentration of atropine. Now this is the log AC50 values. This is the AC50 values from the log AC50 values. Now you can see this is my 0.324, and in your absence it was my 0.178. You can calculate it. You can divide 0.324 divided by 0.178. That is the dose ratio. In presence of antagonist divided by in absence. That is the DR is equal to, that the value will come here. This you will divide it by this, the value will come dose ratio. Now dose ratio minus 1 you get, and from dose ratio minus 1 you will get log dose ratio minus 1. Now we have got the log molar concentration of antagonist, we have got the log dose ratio minus 1. What we do? We create the shield plots, that is log dose ratio minus 1 on the y axis and the log molar concentration on the x axis. So if dr is equal to 2, dr minus 1 is equal to 1 and log dr minus 1 will be 0. So what we have to do, PA2 value is the negative log concentration of antagonists that produce the dose ratio of 2, two-fold shift in the that is log dr minus 1 is equal to 0. This line is there, just you put your mouse in the log dr minus 1 is equal to 0 line and you get the log antagonist concentration, that is minus 8.65 and negative of minus 1 minus 8.65, 8.65. So the PO2 is 8.65. So what we are doing to calculate the PD2? Simple. Plot log molar concentration of acetylcholine on the x axis and plot response on the y, and from the 50% line you can get the log PD2 value. For PA2 value you have to get the DRC of acetyl agonist and DRC of agonist at the increasing dose of antagonist, and from that you get the EC50 of agonist in absence and in presence of increasing dose of antagonist, and you get the dose ratio, you get the log dose ratio minus 1 and you plot it and you get the PA2 value. So in the drug development, if you want to develop a potent drug, so you can estimate the relative potency of that drug by through this method. So if the drug is having PD2 of 1, drug A is having PD2 of 1 and drug B is having the PD2 value of 2. So how much potent is drug A, drug B? 2 times or 10 times? Log, so anti-log will be 10 times. Okay. So this concept you should remember. Any question? So similar setup was there. Wash baseline and then injecting the drug, getting the dose and response and plotting it, okay, and calculating it. And then now you can practice, you have 1 month.
So for online delegates, we are taking a lunch break for 30 minutes and then we will resume for continuing the next sessions. Thank you.
ठीक है ना। तो जाके तो पोस्ट लंच कैसा लग रहा है, हाउ यू आर फीलिंग? अच्छा बढ़िया था, ओके। तो नाउ look at the software. I think this is being supplied to you also through the mail, okay, that MyCal Pharma, and I think for 1 month. It is 1 month.
But it's showing, sir, when we are logging, it's showing 1 July 2026.
26, yes, that's why I am saying it's nearly 8 months like that. It is there. Okay, so now look at the name of the experiment. So what is the name of the experiment? Okay, so if anybody is asking, so the name is the effect of drug on the blood pressure and the heart rate of dog in MyCal Pharma software. Okay, so that where you are displaying it or where you are doing it, so you have to add that name, because this is inbuilt in that MyCal Pharma. That's why that MyCal Pharma is absent. Okay, so one thing is there. Okay, now coming to the objectives here. So for this we are having the 2 objectives. First objective, okay, this one, the above one, with the arrow you can show it. Okay, so the first objective, that is the change in the blood pressure and the heart rate through the mechanical things. Okay, one is the carotid occlusion, carotid artery occlusion. So what will the effect? There is, you are blocking one side of the carotid artery, so you are producing ischemia, so there will be a sympathetic stimulation, so there will be rise in the heart rate and the blood pressure, that one will see. And then we are doing the electrical stimulation, okay, electrical stimulation of the central and the peripheral cut ends, okay, of the vagus nerve. So what the vagus is doing? It is decreasing the heart rate, okay. So when we are talking about the central cut, so that means the stimuli, electric stimuli we are giving to the upward side. Okay, so what will happen? We are stimulating the vagus. Vagus is having containing 2 types of fiber, afferent and the efferent there. Okay, so if it is through the afferent fibers, the signal will go to the hypothalamus. Okay, and then from the other second vagus, the other you can say the vagus, it will come to the heart. So ideally, the BP and heart rate should be decreased, okay, but in some dogs it is increasing, okay, and that is unknown phenomena that we don't know, okay. Then the peripheral stimulation, that means directly we are stimulating the nerve, that is the efferent fibers, okay, so we are stimulating the efferent fibers. So what will happen? There will be decrease in the vagus. What it is doing? It is decreasing the heart rate. Okay, so that effect one will find there. Then the second objective, please hold on, okay, is just to see what are the effect of the different drugs there. Okay, so these are 2 objectives. Now coming to the equipment there. Equipment first is the dog. Now which type of dog? Small, mid-size, big? So it mid-size, okay, weight should be means like that 15 to 20 kg. Okay, the smaller dogs, they are more sensitive, and the larger dog, they are having the better, you can say the cardiovascular stability. So we have to take the mid size of dog. Now which breed we are taking normally? So we are taking the mongrels. What is mongrel? That is the breed that you will find in these roadsides, okay, because that is mixed breed. Okay, so that is why we are taking it. Or the beagles, okay, that is a dog, one type of dog that is coming. Okay, so that is it. Then the anesthetic agent is the chlorelose. Why? What is chlorelose? It is alpha chlorelose. It is an anesthetic agent used in the animals there. Okay, IV agent there. So what different type of anesthetic agent do you people know? Ketamine. Propofol, thiopentone. Okay, so why we are not using them? Because they are causing the cardiovascular depression. Okay, whereas the chlorelose does not have, or it does not, you can say, the affect the cardiovascular stability. So that's why the chlorelose is being chosen. That is the reason. Okay. Then the materials is the pressure transducer, which is converting the mechanical signal into the electrical signal there.
Okay, then the data acquisition system, this data is coming to the machine, and then this is transmitting the data to the computer there. Okay, then the arterial cannula is there. Okay, the three is there. One is being inserted in the carotid artery. There. The second, sometimes if we want to, you can say give some drug or whatever is there. Okay, for that. Okay, normally that is not being used there. And then the third is where it is connected to the transducer, pressure transducer. Okay, so that is there. Then the venous cannula, I think everybody has seen the venous cannula. Where is it? Okay, so that is there. Then the electrical stimulator. So these are the, you can say, the instrument that stimulate the vagus nerve. For stimulation of the vagus nerve, we are using it. Then these are the drugs that are being used, okay, or that are present in the software. Okay. Now coming to the procedure there, the dog, this is the street dog or mongrel, ठीक है ना, वही use करते हैं. Next, so this is how the dog is being dissected there. There you can see the one of the this cannula. It is the trachea is being cannulated. Okay, so that respiration become easy. Or in case of some distress, we can, you can say, the joint this cannula to the respirator. Okay, so that is there. Next, okay, there you can see very easily. Okay, where the femoral vein, downward femoral vein. Okay, it is being dissected there, and this venous cannula is being inserted there, and through this we are giving the drugs, different drugs we are giving it. Okay, then whole setup you can see, it is there. Okay, then this is how the you can say the cannula is being put, all these things. So the software is with you. We are having the limited time, so we will go to this you can say directly to the experiment. Now these tips, go to the tips. These tips are very important. So try to go through the tips there. Okay. So like the low dose, this low dose of acetylcholine, it is when given intravenously will produce a tachycardia, whereas the large doses will produce the bradycardia there. Okay, because of the stimulation of the muscarinic receptors there. Okay, then this in whole setup we are measuring the mean arterial BP, which is also known as the mean BP. Okay, so why we are not taking the average BP into record? Average BP is systolic plus diastolic divided by 2. Okay, that is 120 by plus 80 divided by 2. That it will become 100 there. Okay, like as it is coming 100 here. So there, and then what is the mean arterial BP? What is the formula? Diastolic blood pressure plus 1/3 of pulse pressure. 1/3 of the pulse pressure. Okay, so why this is being taken? Because the heart is in the diastole for 2/3 of the time. Okay, in each beat, okay, from one contraction to the other contraction, it remains in the diastole for the 2/3 of the time there. Okay, so mean arterial BP, it mimics the physiology of the heart. That's why in the mean BP, the diastolic is having importance. Okay, diastolic pressure we are taking, so that's why it is there. Then some of the important point I will just go through here. Go. Down. Okay, so epinephrine will elicit which type of response on blood pressure? Blood pressure. It is biphasic response. Don't say increase. It is biphasic response will be there. Okay. So because of the alpha 1 and the beta 2 receptor. Then Sir Henry Dale has shown the Dale vasomotor reversal or the vasomotor reversal of Dale. Okay. So Sir Henry Dale has used which alpha blocker? No. It is written in a software. Okay, you can see. This is ergotamine, na? Ergotoxin. He has used the ergotoxin, and sometimes in the viva, the examiner is asking, and what you are answering, it is a phentolamine, as you have told. Okay, so it was the ergotoxin that is being used there. Okay, then this we had discussed there. So and expect come down, come up. Okay, so this one, an unexplained increase in BP and heart rate is noticed on the some occasions there. So that we will see also. Okay, come down. Carotid occlusion we had discussed due to a cerebral ischemia. Okay, there will be a sympathetic stimulation. Then come down. The blockers which we are using, like the propranolol, like the phentolamine, which is there in the experiment there. So they act for longer duration of time. Whereas the agonist, like the epinephrine or the adrenaline or the norepinephrine or the noradrenaline or the acetylcholine, they act for shorter duration of time. Okay, so if you are using the blockers, so they act for 6 to 8 hours. So you just give the one dose of the blocker, then this animal will remain blocked for that particular duration of the time. Okay, so from the 8 to 6 hours. Okay, that particular receptor will remain blocked. So that one thing one should put, means don't repeat the dose of the blockers one by one. Okay, again and again in quick succession. So one should not go for that there. Okay, then come for the experiment there. Now here on the red side, what is this red? In the red, what is written there? Heart rate in the red. Okay, then blue. Blue is mean BP. Okay, blue is the mean BP. There you can see there is one highest point in the mean BP. Okay, one above top point. Okay, it is like this. So the top point, okay, it is the peak, and the lower point it is the trough. So what does the top point it is representing? Systolic, and the lowest point diastolic. So okay, so near about in that, in the midway it will be the mean BP. Okay, like as the madam is showing. Okay, there is a scale. Okay, there with the pointer the scale will come. So there you have to write it in the observation. Just go to the observation there. Okay, so there you have to write in the observation, like if we are doing the, okay, upar kya hua hai, we are doing carotid occlusion, then the mean BP you can write, just put the point there, it will tell the reading, and then what will be the heart rate, that you will see, and then in the remarks there is increase in the blood pressure and the heart rate, whatever is there. Okay, then coming back to there, then go for the apply. Okay, now you can see there is heart rate and the mean BP, both have been increased there. Okay, then the second one, so ideally it has to decrease. Okay, the central vagus stimulation, it has to decrease the heart rate and the blood pressure there. Okay, not much action on the blood pressure, but the heart rate should be decreased there, but it has shown paradoxical increase there. Okay, and the peripheral vagus, now here you can appreciate the both heart rate and the blood pressure is being decreased there. Okay, so till now we had not used any drug there. Okay, now once we are using the drug there, then we have to go, okay, just put one drug there, like epinephrine. Okay, okay, after epinephrine the response madam will tell. Okay, but after the epinephrine we have to inject the saline there. Okay, that one button is there, put the cursor there, inject the saline. Okay, so that we have before the next drug there, so that the whatever the drug is remaining, we have to wash out that drug there. Okay, so now the madam will continue there.
mic.
Now I am showing about the epinephrine. Okay. So epinephrine acts on which receptors? Alpha 1, alpha 2, beta 1 and beta 2 receptors. So due to the alpha 1 receptor, it will increase the blood pressure. It causes vasoconstriction. Okay. And then due to the beta 2 receptor, it causes vasodilatation, decrease in the blood pressure. So this is a biphasic response, means two responses seen with the administration of epinephrine, and there will be an increase in the heart rate due to the beta 1 receptors. Okay. Now I am administering phentolamine. What is phentolamine? Non-selective alpha blockers. On administration of phentolamine, what will be the effect of heart rate and blood pressure? Heart rate increases and there will be the decrease in the blood pressure. Alpha receptor is blocked, and due to the reflex mechanism, there will be an increase in the heart rate. After administration of phentolamine, again I am administering epinephrine. Now what will be the response? अल्फा तो ब्लॉक हो गया है, तो देन विच रिसेप्टर लेफ्ट? बीटा रिसेप्टर, बीटा 2 receptors. So there will be a decrease in the blood pressure. Only decrease in blood pressure will be seen because of beta 2 receptor and increase in the heart rate. So what is this phenomena known as? Vasomotor reversal of Dale. Now I am administering norepinephrine. What will be the response? What is the receptor? Receptor of norepinephrine. On which receptor norepinephrine acts? Alpha 1, alpha 2 and beta 1. There is no beta 2 receptor, so there is no biphasic response. Biphasic response is seen only with epinephrine because it acts on both receptor, beta 2 as well as alpha 1. Due to the alpha 1 receptor, it causes vasoconstriction and there will be an increase in the blood pressure. And due to the reflex mechanism, there will be an decrease in the heart rate. Okay. Here reflex dominates over the direct action. Now I am administering isoprenaline. What will be the effect? Before administering any drug, you have to administer saline also. Okay, that's why. So isoprenaline acts on which receptors? No. Epinephrine acts on alpha 1, alpha 2, beta 1. Isoprenaline, beta 1, beta 2, beta 3 receptor only acts on beta receptors. Due to the beta 2 receptor, it decreases the blood pressure, okay, and due to the reflex mechanism, increases the heart rate, and as well as it acts on beta 1 receptor. From beta 1 receptor also it increases the heart rate, okay, both mechanism, reflex as well as direct. Okay, now I am administering acetylcholine. What is acetylcholine? What will be the effect of blood pressure on and heart rate? Increase? Decrease? No, there is no reflex mechanism. Acetylcholine causes vasodilatation, okay, due to the release of nitric oxide from endothelium derived relaxing factor. It decreases the heart rate. It has negative inotropic effect. negative chronotropic effect, negative dromotropic effect means decreases the force of contraction, decreases conduction velocity, decreases heart rate. Okay. At a dose of 5 microgram per kg. Now I am administering atropine. What is atropine? Atropine is muscarinic blocker. So there will be an increase in the heart rate, tachycardia, and on blood pressure. Why? Because on blood pressure there is no cholinergic innervations, there is only sympathetic supply. Okay, there is a muscarinic receptor, but there is no, they don't act because there is no cholinergic innervation. So they have no effect of blood pressure. Now I am administering acetylcholine at a dose of 5 microgram per kg. What will be the effect? Block हो गया है. There will be no effect. Okay. No effect.
If we inject saline first and then again we administer acetylcholine, then will it show up?
Then there will be an effect. Now I am increasing the dose with 100 microgram per kg of acetylcholine. Then you can increase the dose 5, 50, 75, 100. Then no change in blood pressure and heart rate. All receptors are blocked. Now I am increasing the dose by 200. Then देखो what is the response? Why? Acetylcholine acts on muscarinic receptor as well as nicotinic receptor. Atropine blocks only muscarinic receptor. There is a nicotinic receptor, okay, still acting. So at high dose, due to the nicotinic action, there will be an increase in the heart rate and the blood pressure. This is a nicotinic effect of acetylcholine, ganglionic stimulation of acetylcholine. Okay. Now I am injecting saline before administering the drug. Now I am injecting ephedrine. Ephedrine, on which receptors it acts? It is a mixed acting. It acts directly on the receptor also. It has also indirect action. Directly on the receptor on alpha as well as beta receptors, and indirect action, it releases norepinephrine stores. Okay. So there will be an increase in the heart rate as well as there will be an increase in the blood pressure. Again I am injecting ephedrine with a dose of 200 microgram per kg. Same dose I am injecting again. Now what is the response? See. Effect is decreasing. Okay, now I am again injecting 200 microgram per kg of ephedrine. Again effect is decreasing. Why is it so? Due to the tachyphylaxis. Okay, because norepinephrine का जो store है वो धीरे धीरे कम होते जा रहे हैं. Okay, तो this is a tachyphylaxis. Okay, next drug is histamine. Histamine, what will be the effect on heart rate and blood pressure? Decreases vasodilatation. and due to the reflex mechanism, there will be an increase in the heart rate. It acts on H1 as well as H2 receptor. So what is meperamine? Meperamine and cimetidine. Meperamine is H1 antihistaminic and cimetidine is H2 antihistaminic. Both, there will be no effect on heart rate and blood pressure. Okay. Okay, there will be no effect. On administration of cimetidine also, there will be no effect.
Blockers, they does not have any activity on their own. So they only block.
Okay, any questions?
People are in the group, okay, within the group, WhatsApp group. If any question is there, you can ask that question
Thank you, sir, for the session. Now, I'd like to request Professor Dr. Lalit Mohan, sir, to felicitate Professor Dr. Hitesh Mishra, sir. I request sir to felicitate Dr. Nishi. Thank you, sir.
You can see this side. हाँ मतलब जस्ट दिखाने के लिए कि कैसे आ रहा है. So your previous batches have done all these graphs. You will also do. And in between we are giving wash so that tissue remains viable. वाश के समय आप वाश के समय नहीं जाइएगा ना, पूरा निकालने दीजिए. So we need to give some rest to the tissue, let it be acclimatized for 3 to 4 minutes, and by then let us see the total setup. Okay. इधर से जाइए. So for different types of assay, for example, we are assaying some chemical substances. We have different types of assay methods. For example, chromatography, immune mechanism linked ELISA, radio assay, etc., etc. But all those assay needs some molecular in very pure form standards. We need to know the molecule first, and we need to have some standard to form the standard curve, and by extrapolation of that standard curve, by putting the unknown, we can deduce the concentration of the unknown. But for different biological active substance where we don't know the exact molecular structure, because molecule to molecule there might be variation according to the source, and the effect, biological effect might vary. In those cases, we cannot use the so-called chemical assay or RIA or ELISA or CLIA. In that case, we use this bioassay to measure either identification and then quantification. So today, we are showing you the quantification of a known biological active spasmogen. Two spasmogens are there, acetylcholine and histamine. And we are using this bioassay for quantification purpose, not identification purpose. Suppose you are given some secretagogue, then you would have taken some gland, particular gland sensitive to that secretagogue to assay that particular substance. We are known that we have to assay the histamine and acetylcholine. So we know the sensitive tissue might be guinea pig ileum or rat colon, or for bronchoconstrictor activity guinea pig trachea, and so on. We have taken, to bypass the ethics issue, we have taken chicken ileum. We have not sacrificed anything. We have just taken chicken ileum from the market immediately after they consumed it, and we have prepared the thyroid solution. You know the composition of thyroid solution, I am sure, the PSS, physical salt solution, and the warm thyroid solution flask. We have taken the tissue. The tissue is there, let me show you, and 3 to 4 centimeter pieces of tissue we have taken, and this is the tissue, and this is the tissue. We have taken long back, therefore it is contracted state. We have kept in PSS, warm PSS, and aeration is there. That is how we have procured my tissue. Number one thing is there. So for bioassay we have our sensitive tissue here. Then how to make the tissue viable, how to keep this tissue viable. For that purpose we have this total system. You know that this is called student's organ bath, right? It is student's organ bath. There is a outer perspex chamber, plastic type things, and a inner organ bath with specific volume. We have measured that volume and marked. There you can see a mark, red color mark. So that volume is 50 milliliter. So this inner organ bath glass, borosilicate glass made organ bath, this contains the everything for survival of the tissue. That means the pH is maintained, the water balance is there, electrolytes, all electrolytes are there, sodium, potassium, major electrolytes, buffer is there, bicarbonate buffer and dihydrogen phosphate buffer. You can see the composition of thyroid here, and sodium, potassium is main electrolyte, bicarbonate, diphosphate, these are buffer, glucose, nutrient, magnesium, dampening of the contraction, calcium for contraction, muscle contraction, aeration for oxygenation. So everything is there, plus what else? Maintenance of temperature. So here is your temperature maintenance system, this is your heater, this is your thermostat and the console. You would be you would be keeping the temperature 37 degree centigrade for chicken ileum as well as guinea pig ileum. And this is tire. So now coming to our Xbox system. This is the Xbox system. Very you can adjust anything, you can adjust its place, you can adjust its height, anything. Many times external examiner would ask you the Xbox system ko karke dikhao. So very easy thing. And this is your lever attachment system. When your muscle is contracting, that is transmitted to the kymograph by this lever. There are different types of levers. Here you can see two types of lever. One is this, another this. This has some frontal writing attachment, frontal writing stylus, and this should attach the kymograph from front like this, but this should touch your kymograph from tangent, from side. This is tangential lever we use for Frog's rectus abdominis skeletal muscle system, and this is a frontal writing lever we are using for ileum, that is smooth muscle system, guinea pig ileum or etc. Exotonic lever, heart lever, there are other types of levers, but what are the differences you can perceive? One is vertical graph response, another is curved response. So this is by this frontal writing lever, vertical, and this is Frog rectus abdominis tangential writing lever, curved. Curves are different. Now before at present you can see the attachment of the tissue and everything, but you cannot perceive one thing, that before starting this experiment we have done one thing. Here you can see this lever is not balanced, so we have to balance first. Before starting the experiment we have balanced the lever, putting some weight. Magnification is there. You can understand this is a first class lever, right? Because fulcrum is in between, power arm is this, load arm is this. So this is a first class lever. Now first class lever, this is the power arm and this is the load arm. we have kept the magnification, power arm is to load arm, approximately 1:4. There you can perceive this thing. But now question is, from where you can calculate the magnification, number one. Number two question is, what is this then? And number three question is, what is that in the load arm? You can see in the load arm there is some a plasticine block here, in the load arm, a small plasticine block. So the first question, can you try to answer? Number one, what is the magnification of this system? आप लोग को ये दिखा सकते हैं कि कहाँ से कहाँ, सपोज इधर से इधर एक फालक्रम से हम कैलकुलेट कर सकते हैं, या इधर से इधर कैलकुलेट कर सकते हैं, कहाँ से कहाँ कैलकुलेट करेंगे, कुछ गेस कीजिए. Magnification, measure the magnification. How can you measure the magnification of this liver system? So let me tell you, don't calculate from this end, because this end has no value. The attachment of the thread, here is the attachment of the thread, and from this end you need to calculate the magnification. That means this thread to this fulcrum approximately 7 centimeter, this is the power arm, and from this fulcrum to the stylus approximately 21 centimeter, this is the load arm. So magnification is approximately 1:5 or more. So this is your thing. Number two, what is this and what is that? This is nothing. This is just a weight to balance the liver. How much is the weight? I don't know. But this is 0.5 gram measured weight. This is called load. Why it is put? To stretch the muscle. Because you can see the muscle after handling and after taking, it is in a contracted state. So, but here your muscle, you can see avoiding parallax error, that it is stretched. By this load it is stretched. Now coming to our next part, that is the chymograph system. Now coming this chymograph system, this is the, this is the Sherrington's chymograph system. This is your motor, and motor has electrical system. This is your lever, this gear. This is your gear, and this is your clutch. So just like our motor vehicle, disengaging clutch and then adjusting your gear, then again engaging the clutch. This is the system. And this drum is movable, and this drum you can adjust at anywhere. Now we have put we have wrapped a paper around this drum. Now your external may ask you that this paper has two different surfaces. One is rough surface, another is smooth surface. Which one should be outwards? Very easy, the smooth surface would be outwards because of smooth gliding of the lever system. Otherwise it would be stuck. We have this rotator for smoking. We have put diesel or tarpon oil here, and we are smoking our this thing. So PSS we have prepared, and by this heater system, continuously PSS is being kept warm. And this is our aeration system. This is just a simple air pump, and this is the tissue holder cum aerator with X-box attachment. Tissue holder cum aerator, glass made, and you can perceive this swan neck. So this holds the tissue like this. In the inner organ bath, we place the tissue like this, and we keep the attachment. Now coming to our tissue system. So tissue system is there, viability is ensured. Now what you need, you know that some unknown concentration of histamine is given. So first you need some standard concentration of histamine. शकील जी किसी को बोलिए ओरिजिनल जो हिस्टामिन और एसिटाइलकोलिन फ्रीज से. So we have prepared the stock solution of histamine and acetylcholine here. So label, your external would notice the label what you have noted here. Date must be put, concentration must be taken, and proper labeling. So to prepare 1 milligram per milliliter stock solution, how much histamine or how much acetylcholine you should take? This is one question. Suppose you have your standard histamine or the histamine chloride or histamine dihydrochloride, this thing, salt. So how much would you take? ऐसे ही अंदाजे में बता दीजिए. Suppose ये 100 ml NS लिए थे हम लोग, 100 ml NS and 100 ml histamine हम लोग लिए थे. तो कैसे लेंगे? हमारे पास histamine का ये है, बॉटल है और प्योर फॉर्म histamine का बॉटल है. कैसे लेंगे ये बताइए. हाँ, तो 1 मिलीग्राम पर मिलीलीटर होने के लिए वही करना चाहिए. तो क्या लेंगे हम? क्वेश्चन है कि हम सॉल्ट क्या लेंगे और कितना लेंगे. So you keep thinking while we bring you the original this thing. This is our standard plate, standard tray. So serially diluted standards are there. This is 10 to the minus 1, this is 10 to the minus 2, this is 10 to the minus 3 and so on. How have we made it? From the stock solution by a volumetric pipette of 1000, we have taken 1 milliliter and put here along with 9 milliliter of NS. In each test tube we have put 9 milliliter of NS. Then 1 milliliter stock, that means 10 to the minus 1. Then from this thing we have taken 1 milliliter and put here 10 to the minus 2. Then from this thing we have taken 10 to the minus and so on. So this is serial dilution method. ठीक है. अभी ये देखिए आपका, इसको रेफ्रिजरेट करना पड़ेगा, इमीडिएटली हमको डालना पड़ेगा फ्रीज में. देख लीजिए ये आपका हाथ में दिया गया है. अब ये बताइए कि कितना इधर से लीजिएगा. ये तो आपका स्टैंडर्ड है. हाँ, डाइल्यूट मतलब कितना लीजिएगा, सीधा क्वेश्चन ये है कि 100 मिलीलीटर एनएस तो हम ले लिए, इससे कितना तोल के लेंगे. हाँ तो देख लीजिए, उधर दे दिए आपका हाथ में. हाँ, 0.1 ग्राम मतलब 0.1 ग्राम क्या होता है? 0.1 ग्राम व्हाट? So this is acetylcholine chloride, right? And you can see here in small font it is written this molecular weight. Its molecular weight is approximately 186.6. So the 186.6 milligram acetylcholine chloride salt would contain acetylcholine. How much? 186 minus 35.5. क्लोराइड मीन्स 35.5 माइनस कर दीजिए तो 146 पॉइंट समथिंग आएगा. तो ये 146 पॉइंट समथिंग दैट प्योर एसिटाइलकोलिन इज कंटेन्ड इन 186.6 milligram salt. You have to take 100 milligram pure acetylcholine. Unitary method, 184 divided by 146 into 100. And likewise, this is histamine dihydrochloride salt. It is written here. Molecular weight is 184 point something. So dihydrochloride means HCl, 36.5 into 2, 71 minus कर दीजिए तो 111 milligram of pure histamine is contained in this much 184 milligram of salt. तो ये करने के बाद वो आपको डाइल्यूट करना पड़ेगा 100 मिलीलीटर NS में. कहने का मतलब ये है 100 मिलीग्राम इससे नहीं लीजिएगा. नाउ फ्रीज में रख दीजिए. So your standard is there. Similarly, you have prepared the unknown dilution, serial dilution of unknown. So unknown stock was there, and this is unknown 10 to the minus 1, unknown 10 to the minus 2, serially up to unknown 10 to the minus 6. Always start with the lowest concentration of standard. Lowest concentration of standard you need to put to your tissue, expose your tissue. Otherwise tissue would not be viable till 4 to 6 hours, and gradually you need to increase means GP में geometric progression. Suppose 2 ml, 4 ml, 8 ml, 1.6, 16 ml and so on. For that we have our graduated pipette. But if you don't have your this pipette, then you have your tuberculin syringe. So 1 milliliter tuberculin syringe, 0.2, 0.4, 0.8, देखिए next concentration 0.2, 0.4, 0.8 ऐसे करके भी आप जुगाड़ लगा सकते हैं. तो वही हम करके आपको दिखाएं कि कैसे होता है. So we have our standard, we have our unknown concentration. Now we would be putting our tissue exposed to our gradual increasing dose of standard. Standard curve would be formed. Then gradually increasing dose of unknown. Unknown curve would be formed. Then what? Suppose you have your response prepared. Likewise, this type of response you would have. Your external examiner will just ask, what is this? ये जो आया है ये क्या है? हाँ. So never say this is DRC. ये क्या है? DRC sir. नहीं. This is graded dose response, क्योंकि ये तो आपका all on none phenomena नहीं है, graded है. तो graded dose response of smooth muscle preparation in chymographic tracing. So this is chymographic tracing of graded dose response. Now what? ये इसको लेके करेंगे क्या? अच्छा एक छोटा सा चीज बता देते हैं कि ये तो देख रहे हैं आप लोग कार्बन पार्टिकल्स है, तो इसको फिक्स कैसे किए? ये तो फिक्स्ड है, तो फिक्स कैसे किए? दिस इज द latex, lacca. So this latex is supersaturated in methanol solution, and this methanol solution is put in the tray, and just dip your this thing like this, and it will be fixed immediately. A very easy method. But then what to do with this thing? Fixation हो गया, सब हो गया, अभी करना क्या है? Suppose this is your पुराना ग्राफ देख लीजिए, एक एक लोग हाथ में ले लीजिए. Suppose this is your graded dose response. Now what to do with this? We have to form or prepare the DRC, dose response curve. For dose preparation of dose response curve, you have these two types of graph paper. ये arithmetic graph paper, ये क्या है? लॉग ही होगा ये, लेकिन क्या इसके नाम बताइए? अरिथमेटिक के ऑपोजिट वही होगा. क्या पेपर है ये? ये है सेमी लॉग ग्राफ पेपर. सेमी लॉग क्यों? एक साइड में देखिए अरिथमेटिक, एक साइड में लॉगरिथमिक, आधा लॉग. अगर लॉग पेपर होता तो दोनों साइड में लॉगरिथमिक होता. नाउ क्वेश्चन इज हाउ वुड यू प्रिपेयर दिस ग्राफ? You have your previous batches have done these things. You can take one each in your hand and then tell me how would you put. Suppose this is your this thing. एक एक कर लीजिए, बाद में कर लीजिएगा. So this is your log paper, this log thing. Now the question is, you can just measure these deflections, heights, and put in your y-axis. So here this is your y-axis, this is your y-axis, ऐसे पकड़ते हैं. This is your y-axis and this is your x-axis. So x-axis dose should be put in this along the logarithmic scale. Now dose बहुत सारे हैं, जैसे कि 1 से स्टार्ट करके 1012 तक डोज है. कैसे पुट कीजिएगा? तो मुझे यहाँ पे 0 कहाँ मार्क करेंगे? सपोज दिस इज 0, तो व्हाट वुड बी दिस? नो, दिस वुड बी 10. व्हाट वुड बी दिस? ना, 100. दिस 1000 and so on. So where would you put 64? हाथ दिखाइए. ठीक, तो ये 2 जो लिखा हुआ ये क्या होगा? दिस 2, मैं राइटिंग, ये 2 क्या होगा? इस 2 मतलब ये 2 3 मतलब क्या ना? ये 2 3 मतलब 2 3 है. और ये 2 मतलब क्या है 20, ये मतलब 30, अच्छा ये मतलब क्या है 200 and so on. So I am just summarizing 0, 2, 3, 4, 5, 6 etc etc 10, 20, 30 etc etc 100, 200, 300 etc etc. So where would you put 64? 64 would be in between 10 and 100, 6. Then where would you put 128? No, 100 and 100, 200, 100 and 200 just the second this thing, the second small square. And what would you put 1024? This is 1000, just adjacent to the 1000 line. So this is log dose relation, and you can see, you can perceive one thing, that all those curves, all those graphs are almost straight line, is that it? And suppose you have this arithmetic paper, could you place 100 to 2024 or 1024 in this graph paper? It would be very difficult, na? But in your log paper it is very easy. So these are differences between a log curve, log DRC vis-a-vis arithmetic DRC. Wide range of dose you can put, number 1, and number 2, linear relationship, almost linear relationship you can get. So from this linear relationship you choose 25% dose and 75% dose approximately, and you would be taken for your 3-point assay. Here is your 4-point or 3-point assay, you know the Latin square mechanism, S1 to S2 etc etc. So how can you choose? We would be choosing approximately 24%, 25%, and another is 75%. This is S1 and S2. Similarly T1 and T2, and you would be repeating this dose. So this is 3-point and 4-point this thing, but then and then we would be putting these into this formula. The capital S means the length deflection and small s means strength dose. So these are the these things. Now suppose you have your unknown concentration measured. What are the other parameters by which, suppose you have this concentration, but then what are the adjustment you need to do? The volume of the inner tube was something 50 ml, so that is a confounder here. So you need to adjust with the volume of the your things, this thing. If it is 30 ml, then you would be adjusting like this, and so on. So this is all about our measurement of concentration and bioassay. Bioassay means measuring the concentration of a known bioactive substance through this bioassay. Now what are your doubts? Please tell me, and after that you please do the next cycle hands on. Because probably many of you have not been exposed in your colleges to bioassay hands on, right? So what are your doubts? And ये करो क्या बोलते हैं वास्ट. Any doubts? Any questions regarding the whole procedure? And many times you are asked that this type of thing is probably obsolete, but still these are relevant. Where? What are the situation where bioassay is still relevant? इधर तो नहीं चाहिए, लेकिन कहाँ करना पड़ता है? और दीजिए प्लीज. हाँ. Suppose till date you have different types of monoclonal antibody. You have recombinant technology erythropoietin, recombinant technology newer insulin analogs. So all those things from the first day you cannot do chemical assay. So in those cases you have to do bioassay, and therefore you would be seeing that many biological substance you have unit. Suppose cholesterol method, you have unit, not milligram. Or DJ please. unit because these are assayed by biologically these are assayed. Therefore, instead of milligram they have used this unit method. One friction was there, means there was a hindrance, mechanical hindrance. So, any question or any doubt you have? तो अब हाथ से एक बार कोई एक कीजिए. Suppose we have tried 10 to the minus 3 up to 0.8. So you please take 10 to the minus 2, start from 0.2. कोई करना चाहते हैं या हम करके दिखाएं? करके दिखाते हैं. अच्छा, कॉन्सेंट्रेशन सिस्टम बहुत ही इजी है कि आप यहाँ एक स्टॉक सॉल्यूशन बना लिए. स्टॉक सॉल्यूशन कैसे बनाए हम जानते हैं. सपोज एसिटाइलकोलिन क्लोराइड है तो 146 मिलीग्राम एसिटाइलकोलिन क्लोराइड सॉल्ट लिए हैं, 100 मिलीलीटर NS लिए हैं, उसको डिसॉल्व किए हैं तो बन गया 1 मिलीग्राम पर मिलीलीटर, क्योंकि 146 मिलीग्राम एसिटाइलकोलिन सॉल्ट कंटेन्स 100 मिलीग्राम ऑफ प्योर एसिटाइलकोलिन, तो 1 मिलीग्राम पर मिलीलीटर बन गया. 1 मिलीग्राम पर मिलीलीटर से हम 1 मिलीलीटर लेके इसमें डाले हैं और 9 मिलीलीटर NS डाले हैं, तो हो गया 10 to minus 1. अभी इधर से ये 1 मिलीलीटर लेके यहाँ डाले हैं और 9 मिलीलीटर NS डाल दिए हैं, तो हो गया -10 to minus 2 एंड सो ऑन. सब जगह में पूरा 9 ml NS डाल दिए थे और एक एक करके इधर से इधर, इधर से इधर, इधर से इधर करके, तो सीरियल डाइल्यूशन हो गया. तो ये बहुत इजी है. मैं आपको नेक्स्ट एक ये करके दिखाता हूँ कि डिफ्लेक्शन. now suppose in your exam many times it may happen that your response won't come. response अगर नहीं आए तो क्या बोलिएगा? response नहीं भी आ सकता है, लेकिन response नहीं आए तो क्या बोलिएगा? मतलब एक्सटर्नल को तो बोलना पड़ेगा कि क्यों response नहीं आया, तो क्या बोलिएगा? 36, right? So we are taking the baseline, we are taking the volume, (30-second) contact started, एक छोटा सा प्रॉब्लम हो गया, इधर हिंड्रेंस हो रहा था तो मैं थोड़ा सा हटाया तो इसलिए डिटेस्ट हो गया था, कार्ब आपका गड़बड़ा गया. 30 सेकेंड हो गया, बंद करते हैं. इमीडिएटली wash means drain the fluid from inner organ bath, and just after that we would be replacing with fresh PSS, warm PSS. हाँ please. और कितना तक देंगे? जितना तक मार्क्ड है, एक रेड मार्क है उतना तक 50 ml हम लोग कैलकुलेट करके रखे हैं. और एक बार प्लीज. तो ये वॉश बार बार करके देना पड़ता है क्योंकि वो एसिटाइलकोलिन जो रह गया है वो तो डिटैच नहीं होता टिश्यू से, तो बार बार करके वॉश करना पड़ता है. और ये देखिए आपको पूछा जाएगा कि डिफ्लेक्शन कहाँ से मेजर कीजिएगा. जैसे कि आपको मेजर करना है ना, डिफ्लेक्शन कहाँ से मेजर कीजिएगा? ये जो कट पॉइंट है वहां से मेजर करना है, ऊपर से नहीं, क्योंकि owing to buoyancy the stylus has gone up, therefore this false notch has come. ये है. Any questions or any doubt? If not, then we would be calling it a day. Thank you.
Thank you, sir, for this session. Now, I'd like to request Professor Dr. Harrier Dixit, sir, to please felicitate Dr. Sukalyan Saharoy, sir. Thank you, everyone. Now, I request everyone to move forward to the lecture theatre for certificate distribution.
Recording in progress.
शुरू कर दें Suchi, ready? Start. Good afternoon, ladies and gentlemen. Thanks for still being glued with us. On behalf of the Department of Pharmacology, IGMS Patna, I extend my heartfelt gratitude to all our speakers, organizing committee members, and delegates for their enthusiasm and active participation. No event is truly complete without recognizing those who shape its success. So first, let us honor our judges with a certificate of appreciation, for which I call upon Professor Dr. Lalit Mohan Sir to present the certificate to our judges. Dr. Sunil Kumar Singh, Dr. Sanjeev Sir, Professor Dr. Hitesh Mishra. Please have a round of applause for them. Offline participation. And now, I call upon Dr. Professor Harihar Dikshit to please award the participants of offline oral presentation. So the first prize goes to Dr. Vinod Kumar Yadav. The second prize goes to Dr. Harsh Abhijit. The third prize to Dr. Atindra Bhushan. Online oral participation, the third prize goes to Dr. Shaista Parveen, second prize to Dr. Apurva Shaha, and first prize to Dr. Somya Vishwakarma, which will be given after 1 week. Now, for the oral and poster presentation participation, first, Dr. Shashi Kumar Rai, Mohammad Asif Iqbal, Dr. Shaila Wasim, Dr. Harsh Abhijit, नहीं है Dr. Vinod Kumar, ठीक है हाँ इसके बाद Dr. Atindra Bhushan, Dr. Jay Prakash Bhagat, संजीव सर का निकालें संजीव सर का निकाल लिया है ना तुम्हारा I please request Dr. Sanjeev sir to come on the stage. Now let's start with the certificate distribution for all the participants. I request Dr. Manish sir to come on stage and award the participants. Dr. Abhiruchi Priya, half उनको फिर half बाद में. Dr. Ankita Abhishek, Dr. Arka Mandal, Dr. Ayush Amrendra, Dr. Bazla Nazir, Dr. Brijeshwar Kumar, Dr. Dilip Kumar, Dr. Donna Naskar, जी सर, Ghazala Parveen, Dr. Harsh Abhijit, Janvi Kumari, नहीं आपका नहीं था. Thank you, Manish sir. Now I call Dr. Sukalyan Roy. So, Dr. Jitendra Kumar, Dr. Jaiprakash Bhagat, Dr. Kavyanshi Verma, Dr. Kriti Dubey, Dr. Kumar Harshit Raj. I request the audience to please keep clapping. Dr. Manoj Kumar, Dr. Mohammad Ahmed Reza, Dr. Mohammad Akhtar Jamali, Dr. Mohammad Asif Iqbal, thank you, sir. Now I request Professor Dr. Hitesh sir to please come on stage and award the certificates. Dr. Mohammad Nazibul Haq, Mohammad Wasim Fauzan, Dr. Mohammad Samiullah, Mohammad Vamik, Dr. Mohammad Bazid Hussain, Dr. Nadeem Ahmed, Nagma Sajad, Dr. Preeti Sahani, कट कर दिया, रचना कुमारी, Dr. Rajiv Ranjan, thank you, sir. Now I call upon Dr. Adil sir to come on stage and award. Ramsha Almaz, Ranjit Kumar, Rekha Kumari Gupta, Dr. Rohan, Dr. Sabah Ali Ahmed, Dr. Sahil Raj, Dr. Shaila Wasim, Shahnawaz Ansari, Dr. Sharat Ranjan, Dr. Shashi Kumar Rai, Dr. Shifat Naz, Dr. Shiv Shankar Pandey. Thank you, Adil sir. Now I request Dr. Sanjeev to come and present the certificates to the participants. Shivani Kumari, Shreya Rai, Dr. Saurik Shri, Dr. Survesh Podar, Dr. Trisha Priyadarshini, Dr. Vinod Kumar Yadav, Dr. Yadav Madhu Binod Kumar, Dr. Yasha Khan, Dr. Anand Kumar, thank you, sir. Now it's time for the final inspiring address. Now it's time for the final inspiring address that will formally conclude our workshop. For this, I call upon Dr. Professor Manish Kumar to deliver the valedictory speech. Sir, please come on stage.
So we are at the end of this two-day workshop. I want to take some feedback from your side. Anyone want to say something about the workshop? Come forward and say something. आप वहीं से बोलिए, कोई दिक्कत नहीं है. क्या अच्छा लगा, क्या होना चाहिए अलग? So give some feedbacks from your side. माइक दे दीजिए, माइक।
नई आइडिया तुम देना चाहते हो तो वो भी एक्सप्रेस करो।
सर 2 दिन का सेशन रहा, बहुत अच्छा रहा, बहुत नया कुछ सीखने को मिला, जैसे बायो से या लास्ट भी जो सेशन हुआ है प्रैक्टिस का, तो अगले साल फिर से अगर हो तो फिर से हम लोग पार्टिसिपेट करें। एज सच कोई नया सा उसमें कुछ कंप्लेन कुछ नहीं।
मैं अनाउंस कर रहा हूँ प्रोबेबली फरवरी या मार्च में नेताजी सुभाष मेडिकल कॉलेज एंड हॉस्पिटल अम्हारा में एक वर्कशॉप कराने जा रहे हैं अल्टरनेटिव टू दी अल्टरनेटिव मेथोडोलॉजी पर, इन सिलिको टॉक्सिकोलॉजी एंड ऑर्गेनोइड्स एंड ऑन सच। सो ये हम लोग करने जा रहे हैं, जिस पर वर्कशॉप अभी तक बिहार में तो नहीं हुआ है, पता नहीं और जगह हुआ है या नहीं, तो ये एक आइडिया हम लोग का है उस पर। और दूसरा है सोशल फार्माकोलॉजी पर, ये भी मैं कराने जा रहा हूँ।
और कोई? हाँ दीजिए माइक।
बायो से या मतलब बहुत अच्छा, या सर ऑर्गन बाथ बहुत अच्छे से समझ आया, साहा सर ने बहुत अच्छा समझाया और सर बहुत अच्छा सीखने को मिला।
क्लैपिंग फॉर सर। खाना पीना कैसा था?
हेलो, बहुत इंटरेक्टिव सेशन रहा और बहुत कुछ सीखने के लिए मिला। ओवरऑल बहुत इनसाइटफुल, बहुत अच्छा रहा। खाना पीना भी बहुत अच्छा था।
और हर एक स्टेशन का जो टाइमिंग था वो क्या एडिक्वेट था? उसको चेंज कर सकते हैं हम लोग, कम कर सकते हैं या ज़्यादा कर सकते हैं, ऐसा कुछ है? सफिशिएंट।
लेकिन इसके बावजूद भी कुछ लोग एब्सेंट हैं, जितना रजिस्टर्ड है उतने लोग नहीं हैं। क्या बात?
एग्ज़ाम्स वगैरह चल रहे हैं सर, तो बहुत लोग अपने एग्ज़ाम में बिजी। So I'm going to give this valedictory remarks. So good afternoon, distinguished guests, esteemed faculty members, delegates, and fellow organizers. As the organizing secretary of this 2-day workshop on animal handling and experimental pharmacology, I am truly honored to stand before you today. It has been a privilege to witness the convergence of minds and the exchange of ideas that have defined this event. First and foremost, I extend my heartfelt gratitude to all our distinguished speakers, Dr. Vikas Mehdi sir, U.S. Rao sir, and others, Arka Mandal, and all esteemed faculty members who led the various sessions with such generosity and depth. Their expertise has not only enriched our understanding but also sparked new avenues of thought and inquiry. To all our participants, thank you for your active engagement, curiosity, enthusiasm. Your presence and contributions have made this workshop a vibrant testament to the power of collaboration, dedication, and passion for advancing scientific research. I would like to sincerely thank our supporters, NSMCH Beta, TLS Group, AD Instruments, Michael Farm, and Gentech for their invaluable backing throughout this journey. A special acknowledgement goes to our organizing committee members and faculty members, Professor Emeritus, Professor Dr. Hariyar Dishi sir, Professor and Head Lalit Mohan sir, Professor Dr. Hitesh Mishra sir, Dr. Suklan Saha Roy, Dr. Adil Sakur, Scientist and Joint Organizing Secretary, Dr. Pankaj Prabhakar, our senior residents whose tireless efforts were instrumental, like Dr. Purnendu Arya, Dr. Roshan Ranjan, Dr. Mukesh Kumar, Dr. Nidhi, Dr. Amrendra Arya, Dr. Ravi Roshan, Dr. Sajid Hamid, Dr. Noor, Dr. Chakrapani, Dr. Keshav, Dr. Pallavi, Dr. Nishi, and Dr. Sarjit. Our junior residents who brought energy and dedication, Dr. Rajiv, Neeraj, Dr. Chandni, Dr. Bhavna, Dr. Ruhi, Dr. Bajla, and Dr. Trisha. I am thankful to veterinary officer Dr. Manoj Kumar and scientist Mr. Margoob Alam. A special thanks to Ms. Suchitra, Pharmacovigilance Associate, Akansha, and all other staff members associated with the Department of Pharmacology, IGIMS Patna, like Ravinder ji, Sakil ji, Sailesh, Kunal, Rekha ji, Tasleem, Om Kumar, Rajiv Ranjan, Jay Prakash. I also extend my gratitude to Mantosh ji, Satish ji, Hari ji for their technical support, which ensured the smooth execution of this workshop. As we conclude, I hope the knowledge and experiences gained here will continue to inspire and empower you to make meaningful contributions in the field of animal handling and experimental pharmacology. So thank you once again and wishing you all a joyful and prosperous happy Deepavali. जो बुक आप लोग को प्रोवाइड किए हैं ऑफलाइन पार्टिसिपेंट को, हम लोग कोशिश कर रहे हैं ऑनलाइन पार्टिसिपेंट को भी बुक प्रोवाइड करने का, और वो ऑनलाइन अवेलेबल भी है अमेज़न और कहाँ है किंडल, गूगल बुक।
20 नवंबर से अवेलेबल हो जाएगा फ्लिपकार्ट पे, अमेजोन पे, अमेजोन का जो पोर्टल आने के लिए उसके भी, और नॉर्मल अमेजोन पे भी, और आपका गूगल बुक करके आता है, गूगल बुक पे भी आपका तीनों 20 नवंबर के बाद से अवेलेबल हो जाएगा बुक। थैंक यू।
ओके, थैंक यू ऑल।
सारे लोग हट जाएंगे।
Please everyone gather for a group photograph.
कुछ आगे कुछ पीछे।
Recording stopped. Recording in progress. Recording stopped.